Good morning, everybody. Welcome to Porto. My name is Mike Nyack. I'm here with
Andrew Berger.
We just want to welcome you to the Quality Medical Publishing Facial Aesthetics Deep Plane and Beyond 2025 class. I have, in my opinion, the best panel of upper and lower face layer 4 deep plane aesthetic surgeons assembled in a really fantastic historic facility. I don't know if any of you had the same reaction that I did walking into this room. It feels like a throwback into the education of medical giants. You walk in this room with this tiered seating. The Cadaver lab is just as good. We have an abundance of fantastic fresh frozen cadaver heads. We have instrumentation that is really good. It was really good last year. And then we got some feedback from last year's attendees and from Dr. Mastery about what we could do to make it even better. Really fine instruments, really fine scissors, calipers, several needle holders per station, so enough to make it an excellent experience. So Marina Medical, who unfortunately can't be here today as a sponsor in the flesh, is a sponsor in spirit. They got you guys fantastic instrument trays. Please make sure all the instruments remain on the fantastic instrument trays. Always sounds funny, but it's important to say. And we got you really delicate instruments too, so be nice to them, please. And then Hayden, through Biolumix, got some headlights as well. And Hayden is here, is he? Okay, so. Oh, it's
yeah, Biolumix is here, and they have, there's a limited number, but probably cover most of the group. They've got headlamps if you want to borrow one. You can meet with Ryan. He'll be in the exhibit area near the lab. So.
We have a question for you.
Yeah.
We know that there's live streaming right now, so hello to all of our live streamers at home. And I know that you'll be providing a replay of this meeting for everyone who attended for what period of time?
So after the event ends, we'll go through sort of a series of productions. So you'll have more of a raw live stream at first, a raw version of it. That will be produced in 1 to 3 months. You'll have more of the final cut of the production. That would include the lecture presentation, the faculty demonstrations in the lab, and then some of the interaction between faculty and attendees. We call it about 97% of the content. Occasionally, there's some content that's shown here that's not allowed to be shown publicly on an ongoing basis. But knowing that that's the case, we would definitely say that you can't film the content that's coming up on the lecture because some of that is sensitive. So like I said, understand that you will get this video for ongoing viewing in the future, but no filming or photography for inside the lab. I don't mean you can't take a picture of the faculty or something of that nature. I'm talking about the presentations themselves. So.
Yeah, let it be freeing so you can be fully engaged and watch the entire time and know that you'll have the archive version to watch at your convenience as much as you want later. Finally, we have in the laboratory section this afternoon, we have we're trying to maximize your time on the Cadaver, and so many of the faculty have done video prosections where steps of the operation just recorded, and we'll play them for you right before you get started, because our goal is for you to have fresh in your head exactly what you're going to do. But we can get that image fresh into your head in 5 or 10 minutes if we have pre-recorded segments. Sometimes when you do it live on a Cadaver, you burn 40 minutes of exposure and talking, and you're losing lab time. So some of us will be giving you just the distilled video clips right before the step that you do to try to maximize your lab time. Others will do some live dissection. We'll try to keep that as time efficient as possible. And then you'll get to do your dissection. Even while you're doing your dissection, at the master station, we'll have some ancillary stuff going on. So if you're finished with your dissection or you're not so interested in one part, keep your eyes on the monitors or keep your eyes on the ancillary station, the master station, because there's so much faculty here with so much ability, we may be doing some other interesting things that you may choose to watch. For instance, at the Cadaver lab, we have the actual scheduled structure part to encompass the middle 80%. You're not a super basic surgeon, you're not a super gifted surgeon. You're 80% what you should be learning when you're here. Well, for some people that might need to know how to tailor and inset a skin flap, we'll do that on the side at the master station. If that's important to you, you might watch that on the screen or drift over there. If that's old hat to you and you just need more time in entering the various segments of the subsmass spaces, spend your time on the Cadaver. So during the Cadaver dissection time, there'll be some prosections that are on the program. You'll have your dissection time, and then there'll be some extra prosections of bits and pieces, odds and ends, that we're just kind of putting out there for anyone who's interested. Feel free to watch or feel free to continue to dissect.
And then I'd just like to thank you all for being here. People coming from all over the world. We had an amazing event last year. Looking to have another great one. And definitely thank you to Mike and the rest of the faculty who come from all over. A lot of people had some trouble in traveling, so I'm glad you guys all made it here. So.
And with that, we're going to start our tradition of this morning staying perfectly on time. Exactly 8 o'clock. I'm going to turn you over to our chairman for the upper face section, Dr. Guy Mastery. You can't do any better than that, so thanks, guys.
All right, so I'm going to talk about blepharoplasty, brow lifting, and canthal suspension. I'll speed through some things to stay on time, emphasize the things that are important. This is a lot to talk about, the upper and lower lids in 30 minutes. The videos I prevent, I think will be running later in the lab, so they'll be helpful too. I want to elaborate on it without anatomy. If you can't master it, you'll never master surgery. I'm an anatomy junkie. I became encyclopedic on it, and that's how I advanced my career, understand new procedures. Pearl. It's not what you remove in the eyelids, it's what you leave behind. Do not over-resect skin. Skin is not just skin to close the eye. Skin is also volume. Preserve muscle, we're going to discuss that. I'd like you to know that most of the patients I see that can't close their eyes after surgery is not a skin shortage, it's muscle weakness. Be careful what you do with muscle. And then always preserve volume. I have a 90-90 rule. 90% of the people that see me for eyelid hooding ask for a blepharoplasty. 90% of them need a brow adjustment. This is evidence-based. We're publishing this soon. Over 400 patients. Don't forget the eyebrows. Explain to patients the importance of brow adjustments. It's critical to their outcome. The brows and upper lids are an aesthetic unit. On exam, also, don't miss ptosis. The most common cause of ptosis after blepharoplasty is missed preoperative ptosis, not a surgical error. But if you don't tell them, it's your fault afterwards. Do not do levator surgery. Unless you're specially trained, it's a mistake. You'll have issues with height and contour. I promise you it'll cause you issues. Do posterior approach. I don't have time to talk about it. If anyone wants videos, I have them. I can give them to them. Never feminize a man. Surgery on men is very different than women. If you look at this man, his ptosis was corrected. His brow was adjusted, his blepharoplasty was done, he still looks like a man. Avoid hollow lids and high tarsal platforms in men. Critically important are superior sulcus hollows. You have no idea how unhappy people are when they have this problem. This was a redo, we fixed her lower lid retraction, it's a completely separate talk, I don't have time for that, but we filled her sulcus with her own fat, with grafted fat, and when you do a ptosis repair, it also fills the sulcus. Don't forget hollows of the upper lid. Surgery starts with marking the crease. The patient can be sitting in front of you. Tilt their head back, have them look down, push up on the lashes, you'll see their natural crease, and demarcate their excess. I always double check it on the table. I use this pinch technique, it works very well. I generally don't allow a minor amount of lag ophthalmos. However, if their orbiculus function is good, if they don't have dry eyes, etc., you can take a little bit more. It relaxes with time. When I inject the eyes, a lot of these patients aren't asleep. Patients have gotten up. Patients have perforated their globe. Bend the needle 45 degrees away. Hydrodissect the anesthetic muscle between the skin and the muscle. You can then push it forward. When you excise skin, you can use a scalpel blade, but you can also use a monopolar, a bovie. As long as it's in the pure cutting mode, they get less bleeding. Studies have shown there's no increased scarring. preserve orbicularis muscle. This is the most important thing I can tell you. Short-term studies have shown no difference in outcome when orbiculectomy is performed or is not performed. Long-term, we don't know. But this is important. This is factual. When you excise orbicularis, there is often a weak blink, closure issues, widened and white scars, and you know all the red blood vessels on the tarsal surface? When you excise orbicularis, that's exponentially higher. Finally, there's no long-term studies of these results in patients. When we see patients years down the road, the ones that have had traditional blepharoplasty with excision of orbicularis have a 90% higher issue of closure issues, dry eyes, red eyes, and tearing. We've studied this. As an analogy, every muscle in your body becomes weaker with age. The orbicularis is no different. Why do we excise orbicularis? I call this delayed iatrogenic morbidity. That means we're doing it to patients, and unless you've seen your patients long-term, you don't know what these outcomes are. Always preserve volume. Why? Because basically, we're all grapes that turn into raisins. We shrivel up as we get older. We need punch de leon back in our life. We need the fountain of youth. Know that the nasal fat pad is stem cell rich. The preapneurotic fat pad is stem cell poor. And when you transpose fat in the eyelid, you want to transpose stem cell rich fat to stem cell poor areas. Also know this, the trochlea of the superior oblique separates these fat pads. Like in the lower lid, the inferior oblique separates fat pads. You can get double vision by aggressive cautery of the nasal fat pad. In fact, most people don't know this. The incidence of double vision after blepharoplasty is higher in upper blepharoplasty than lower blepharoplasty for this reason. So fat transposition is a very useful tool. It's just shifting the nasal fat pad to the central eyelid space. We wrote on this 15 years ago. It's been a useful adjunct. And I think if you're comfortable, I would add this to your armamentarium. You can also advance the preapneurotic fat. What I usually do this for is for patients like this that have multiple creases and you want to create one crease. It acts as a buffer. You advance the fat and you can reduce the number of creases. It can also be done for volume. A brow fat suspension suture, also a brassiere suture, was first described by Harvey Zairm, a plastic surgeon in Los Angeles. What he did was he would secure the orbicularis to the orbital rim and excise fat. It would create a large platform. We don't do it for that reason anymore. We don't like large platforms. But when you secure the muscle to the rim, it elevates and anteriorly projects the brow fat pad and gives this effect. And I'll show you this on a video. Finally, closure of the upper lid. Here's what's important to know. When I run the video, I'll cut this out to save time. But just know that the lower ellipse is shorter than the upper ellipse. It's connected by a diagonal. So you have a big ellipse, you want to make many small ellipses. So I put a cardinal bite in the center laterally, and that aligns the relaxed skin tension lines. I also prevent dog ears by closing at the end, cheating this way. And I put a number of sutures in, especially the brow lift, because you have more tension there and dehiscences can occur. And when I close, I leave about 8 millimeters from the edge of the incision to prevent webbing. If you go to the corner, you can get webs. Every bite is perpendicular. And that way you align the relaxed skin tension lines. I use fat a lot. I'll show you in the upper lid what I do. In the lower lid, I won't repeat it. I use this little mnemonic as a basic, easy thing to remember. The location where you harvest fat does not matter. Anesthesia does. Dilute the lidocaine, it's toxic to fat cells. The size of the particle matters. The size of the particle, survival, is inversely proportional to the diameter or radius of the fat cell. So smaller fat cells do better, and technique's important. Multiple passes, small aliquots, and deep. I do not centrifuge, I decant. So I place saline on top of the fat. Like in the ocean, the oil rose goes to the top. When there's an oil spill, the saline goes to the bottom. I just open the stopcock, let the saline out. I pour the oil out on top. It's still not completely pure. So then we lay it on an absorbent material. This is telfa. Telfa just absorbs the remaining fat, remaining saline. I create a telfa sandwich. I compress it. And then what's left, I place into a 10 cc syringe. I put it through a stopcock to make it homogeneous, and we inject. I use the tulip system. You can use others. For the eyes, I use a 20 gauge 0.7 millimeter tip. For the cheeks, I use the 0.9 millimeter tip. And when I graft fat, it's multiple passes, small aliquots. I'm usually perpendicular, and I massage. Now, this woman I told you about lagophthalmos looks like she has lagophthalmos, and she won't close her eyes, but as you can see at the end, she can close her eyes. I'm going to show you a video. I'll cut out the end just with the basics.
Okay, so with upper blepharoplasty, I first do the marking. I marked her crease 10 centrally, 5 nasally, 5 temporally, connected the dots, and then performed what I call the pinch technique, where I pinch the skin together. I leave her a little lagophthalmos typically. She's been pre-injected already, but when I inject, I take the needle, bend it 45 degrees.
Always get into this habit.
That way, if she were to
every year there's 2-3 globe perforations. It's a terrible complication.
Under the muscle, hydrodissect, advance it, and in a awake patient, you can push the anesthetic forward and then enter with the next injection, and they won't feel anything. Next, I incise the skin. I use the cutting mode.
I have not used a scalpel in 10 years. I do not get more scarring. As long as you're in the pure cutting mode.
It's rapid movements. As you can see, there's no bleeding. That's why I like doing it this way. And I connect everything. And the skin incision is made. Okay, we'll now remove the skin. I'm an orbicularis muscle preserver. I believe that the muscle is important as we get older, so I'm using the pure mode on the monofocal cautery to dissect the skin, preserving muscle, so you can see that I have dermis here and muscle here. So I am preserving muscle. Again, I believe in that strongly. And I'll just continue along. My assistant will push now, push even more and more, because when they push, I'm in a better plane to remove the skin, and now the skin has been removed. Okay, now we're going to open the orbicularis and septum to expose fat pads. I cut down through both. You can actually see the preapneurotic fat here. Her nasal fat pad is pretty sparse. I'll use a cotton tip applicator to see if we could identify it. A little bleeding. And you can see it here as I push. It's very sparse on her, but I'll open it just so I can bring it out and you can see it. On her, you could theoretically make a pedicle of it and transpose it here, but she has so little, I don't think she'll get volume out of it, so we will not. You could then take the wooden end of a cotton tip elevator.
If you're just learning, this makes sense. If you push up on it, you cannot cut the levator.
And cut down on it, that protects the levator, and this allows you to expose the preapneurotic fat. You can see Whitnall's ligament here, the levator muscle, the aponeurosis, the postorbicularis fascia, the orbicularis muscle. The septum is this white tissue that covered the preapneurotic fat, and that shows you eyelid anatomy well. Okay, so we've now taken the preapneurotic fat and dissected it free from the lateral rim. You can see the lacrimal gland is prolapsed here. This is the orbital lobe of the gland. This is the arcus marginalis. I can blot the gland and you can see it. This is the brow fat pad, and this is the arcus marginalis, this white tissue. And on her, because her gland's a little prolapsed, we can reposition it with a suture. I'll show you that in just a second. Okay, so this is the prolapsed lacrimal gland. There was one suture put in already. I'm grabbing the parenchyma, going under the arcus marginalis. I will drive this suture into this gland into the orbit with the suture, and you can see how it repositioned to a degree, little bits that still remain afterwards can be handled with gentle cautery on top of the gland. I'm a firm believer that cautery on top of the gland doesn't do more damage than placing a suture. So if you just...
It's very safe. You will not damage the gland by cauterizing its tip or parenchyma.
It creates a scarring, repositions the band. Okay, the last thing I'll show you is what we call the brassiere suture. I'm getting a bite of the arcus marginalis to get a decent bite of it. And then what I'm going to do is suture it to the upper wound edge orbicularis muscle. And in doing this, I will elevate and anteriorly project the brow fat pad. And I usually put a few of
This
these
elevates the brow fat pad and gives you volume.
And
okay, so for time, I'm going to go on. I'll skip the closure. I showed you the slide of the closure. Let's move on to the lower lids. Why don't perform transcutaneous surgery? Many apologies, Nabil. Many apologies, Michele. It's an easier, open approach. That's very good. It exposes things better. That's good. It addresses skin muscle fat with one incision. That's good. But for me, the good ends here. Remember, I have a big revision practice. I see about 115 eyelid retraction cases a year, and 100% are from transcutaneous surgery. It doesn't mean it's a bad surgery. It means problems can occur with it. So lower lid retraction is too high with me. I think the scar is worse, and orbicularis weakness is high. And these are very, very damaged people psychologically. I have hours of lectures on how to do this in videos. I'd like to avoid ever doing it again. So I'm going to talk about how I do it, which is transconjunctivally with transposition and grafting of fat. If I want skin, I'll create a flap or do a pinch, and I can add a canthal suspension. Again, transcutaneous surgery is not a bad surgery, but across the board, the complication rate in the United States and in the world is higher. So the goals of surgery are to basically recreate the concavity, convexity of youth. What do I mean by that? This is a convexity, this bag, and this is a concavity. So convexity, concavity, convexity, and this is the CC, concavity, convexity of youth. You want to recreate that, and this is a very predictable way to do it. Who are the best candidates? Ones that have enough substrate, enough fat to transpose with adjacent periorbital hollows. And if you have those two things, that you can help these patients. Excising skin, canthoplasty, transfer, mid-facelift, etc., are all adjuncts you can use to add to surgery. We don't have time to go through all that. So it begins with how you access fat, and you have two options. You can go in front of the septum and open it, or behind the septum. It doesn't make a difference. The results are the same. And even if you violate the septum, you don't get eyelid retraction. So there's this dogma that a middle lamellar scar causes eyelid retraction. That is nonsense. The literature is wrong. In fact, it was changed in our board exams once we published this paper. It requires a multilamellar scar, skin, muscle, and septum to get eyelid retraction. And this slide is an important slide. It shows you the complex anatomy of the lower lid and explains pre- and post-septal entry to fat. This is the septum, this is the retractors and conjunctiva, and this is their fused connection. I'll show you a video. No one does this surgery. No one removes the retractors from the conjunctiva. I do it in retraction cases all the time, but the video will show you the anatomy that you only see in
okay, so this is the edge of the conjunctiva. This is the conjunctiva over the cornea and over the sclera. And then this right here is the recessed retractors. So to go through the retractors, you go this way. If you did a transconjugal F, you'd go to a conjun retractors. This is retroseptal to enter the fat. Here's her old septum. To get fat preseptal, you go this way. How do we know that's true? If I look between the retractors and the septum, you can see the fat.
So that anatomically shows it well. I like to go retroseptally. I use this technique that Andrew Jacono and I talked about years ago called the GRED maneuver, globe retrofulsion eyelid depression. The bone is rigid, the contents of the orbit are not. If you push on the globe, pull down the lid, the fat comes forward, you enter 82% of the time. If you make it about 6.5 millimeters below the tarsus, 82%, and the incidence of chemosis, even though it's a low incision, is not increased. I then use a Q-tip to dissect to the rim, separate the fat. This is the oblique. The fat pedicles override the oblique. The oblique is deep. It originates on the maxilla, inserts the back of the globe. So it's deep. So you have to find it. You have to separate the middle, the nasal and central fat pad. These are the separators, nasal and central fat with oblique. This is the arcuate expansion. It's extension of Lockwood's ligament, the suspensory ligament of the lower lid, and it separates the lateral and the central fat compartment. You then create fat flaps, free them from the oblique, the caronchymal and orbital rim. They will slide underneath the muscle freely. It just shows that there's no scarring or attachment or tethering. And you may reduce the very rare incidence of diplopia by doing that. So I make sure everything is free, because the ocular motility system is not just muscle, it's muscle, fat, and connective tissue. And if you tether any one of them, you can get double vision. I prefer the subperiosteal approach to transposition. You can go above the periosteum. I like a caudal rather than a freer elevator, and I place the fat on each side of the nerve. I'll show you the video. Doesn't matter if you go sub or superperiosteal. We've studied this in depth. The aesthetic results are the same. It doesn't make a difference which way you go. How does anatomy help us? Well, what you do is you cut the arcus marginalis, we'll show you in the video, which is where the periosteum, the orbital floor, and the maxilla meet. You then release the tear trough ligament. Brian Mendelsohn described it. It's where the eyelid and orbital orbicularis meet. There's a line right here. And then you elevate the levator labia superioris. The infraorbital nervovascular bundle will be there. Then the levator anguli oris. I dissect all the way to the side of the nodes, piriform episode, and place the fat low. You can then translocate the fat pads individually, one at a time, or you can do them together as an omentum around the infraorbital nerve, which is what I do. You want to secure it internally or externally. That has never been studied, which results are better, so you can go either way. If you tie too tight, you could cause ischemia of the fat pedicle going over the rim, and you can get nodules. If it's too loose, it can retract. Does it work? It wasn't until 2016 that anyone did any three-dimensional studies to show that you had an improvement in the depression, and we found 0.7 millimeters at 1 year. MRI studies and other studies now substantiated that, so we know it works, and just some results. And I can show you hundreds and hundreds of these. It's all the same. You recreate the concavity, convexity of youth. Oblique views show it really well, because from the side you can really see the filling of that depression. A few pearls. What about the lateral fat pad? Many say you can't do it. There's not enough fat. It's too tethered. They'll get double vision. It's not true. That's not evidence-based. Interestingly, in our field, we say things all the time based on pictures, but there's little evidence-based information. Everything I've said to you has been published or I've published it. I won't ever stand on a podium and tell something to someone if it's just an opinion of mine. So you can reposition the lateral fat pad. It works well too. I often graft there, so I don't need to do that. I combine the two. The arcuate expansion, do you need to release it if you're transposing all three fat pedicles? The answer is no. There are those that believe when you cut this, because it's connected to the suspensory ligament of the globe, that you do get changes in position of the globe or the lid and superior sulcus hollows. But that's anecdote. No one's ever shown that. If you have a thick pretarsal orbicularis muscle, tell patients, because it may be more prominent afterwards because you're shifting the fat below it. Just manage their expectations. If you tell patients beforehand what to expect, they're not going to be as angry than if you don't tell them. Because if you don't tell them, it's your fault and a surgical error. This is very interesting. A recent paper that came out is excess fat herniation necessary to transpose fat. In an Asian population, they found that it wasn't, because the orbital septum is so thick, it holds back so much fat that you can't see the herniation. I've operated in Shanghai many times, and I can tell you this is true. So long-term results, we looked at 427 consecutive patients. Satisfaction with repositioning alone was 96%. I love doing surgeries when satisfaction is so high. Incidence of chemosis was low, and increased wrinkles, complaints by patients, was only 2%. Only 2%. So this is just transposition. This is not cutting out skin, not doing canthal suspension. That's pretty good. What do we know? We know it works. We know satisfaction is high. We know you can go above or below the periosteum, pre or post septals, and that you can fixate internally or externally. That's the only thing that hasn't been studied, and that's next.
So this is a 20 SL tulip.
I showed you how it grafts anatomy of the lid. It's very similar in the lower lid.
And now we are going to start the
So I enter in the
grafting.
cheek.
So I'm placing it through a porthole created with an 18 gauge needle. My fingers on the rim so I can feel the bone.
So it's the same as the upper lid. Let me show you, and this is when you add transposition in grafting. So you can actually improve results. I always graft first, above the periosteum, transpose below. This is just a video of the procedure now. Oh, I really don't have time to talk about any of these subjects, but if anyone wants to talk about diplopia, filler issues, chemosis, lumps, we can talk about it. Most of the stuff we've written about.
All right, to begin the transconjunctival blepharoplasty, I use this GRED maneuver below the retropulsion eyelid depression, and I'm going to make an incision about 6.5 millimeters below the tarsus, and you'll see that the conjunctiva retractors are cut, and the fat comes forward, and we enter the retroseptal space. Now I use a blunt Q-tip to get to the retroseptal space, and what I will do is extend the incision to the caruncle and laterally to give myself more exposure. And you can see when I separate the fat pads that the oblique muscles in between them. I'll show that better in a second. Okay, so we've opened up the retroseptal space. This is the nasal fat pad, quite robust. This is the central fat pad. They've been freed from the oblique muscle. They move freely underneath. I've called this the inverse shoe shine sign. Is this critical? I don't think it's critical, but it helps me know that the fat is released from the muscle. This is the caruncle. This is the infraorbital rim. Your two fat pads. These will be put together as an omentum and repositioned into the hollow. Okay, so this is the nasal fat, the central fat, the oblique in between. The white is the arcus marginalis. I'm going to cut right through it to the orbital rim. And when I cut through that, what I'm reducing is I'm releasing the tear trough ligament. The tear trough ligament is where the eyelid palpebral orbicularis meets the orbital orbicularis, and you can see we're now down to periosteum. When I elevate beneath, I'll be elevating the levator labii superioris. The infraorbital nerve is below that. Okay, I'm starting my subperiosteal dissection. I'm going to elevate the levator labii muscle below the periosteum. We're getting a little blood there. It's not unusual. And you can see I'm down to periosteum here. And the dissection can go all the way down to the piriform aperture. So here's your bone. Periosteum's above you. It's a little bloody. So I'm just going to put this Q-tip to dry it underneath so you can see a good picture of it. There's a little foramen with a bleeder there. That's all. Okay, so this is the needle going transcutaneous into the wound. I'm going to grab it, pull it out. This is the fat pedicle, nasal, I'll grasp it, central, I'll grasp it, and I'll go to and fro a number of times to make one omentum of fat.
Make sure not to lock the suture because you won't be able to take it out.
There's quite a bit here, but that's important because I'm filling inferior, and I want to get all the fat I can to fill that space. And then I will fill this space by having this come transcutaneous through the skin and pulling it through. Okay, the pedicles have been transposed and have come through the telpa. There's a little bleeding. When you tie the telpa, look at the lower midface, how it comes up. The midface does come up, and the fat fills that hollow. So effacement is the midface coming up, and orbicularis covering the rim, plus the fat covering the rim.
Let's talk about brow lifting. Something near and dear to my heart. How I do it, it's a little different than others, but it's a technique that's become comfortable with me when I call it endo-styler approach. Why is it called that? Because I haven't used a scope in about 10 years. You don't need to. We have great data on that. No change in complications or outcomes. And I'm in the same dissection plane. It all starts with anatomy. Why is that important? Because if you know anatomy, you can do this surgery well. It allows release of all the tethering ligaments that hold the brow down and allows you to reset the brow to a higher position. If you don't know anatomy, you get into trouble here because temporal anatomy can be complicated in terms of its appearance, in terms of knowing it, and also in terms of its nomenclature. So it's really important to understand anatomy. And to detail anatomy guides us to better outcomes and prevents complications. So we'll review anatomy of bone, soft tissue, and neuroanatomy. This bone, which separates the frontal bone from the temporalis fossa, this line is called the superior temporal line. That separates the temple from the forehead at the bony level. There's 5 layers of the soft tissue on the face everywhere. They vary in thickness because of the constituents that are in those 5 layers. In the temple and forehead, the skin is continuous, the fat is continuous, the musculo-aponeurotic layers, the superficial fascia and gale layer are continuous, the surgical plane is continuous, and the deep fascia and periosteum are continuous. And this slide shows that these 5 layers are separated and perpendicularly divided by 2 septa. The superior temporal septum and inferior temporal septum. There's 3 septa in the upper face, superior, inferior, and the orbital septum. This is our surgical plane. This inferior temporal septum, where the superficial and deep fascia meet, separates the temple into 2 compartments. An upper compartment, which is a blunt dissection, like the subgaleal plane of the forehead, and a sharp dissection, which is like the midface. You need to know this anatomy. The frontal branch runs in the roof of this cavity. If you know this anatomy, you don't need a scope. This is a cadaver version showing it. We'll show you this in the pro sections. Superficial deep fascia, inferior temporal septum. The nerves. The supraorbital nerve is a branch of the frontal nerve, which is a branch of the ophthalmic nerve, which is V1, first branch of the trigeminal. It has 2 branches, a superficial medial branch that pierces the corrugators, gives sensation to the skin of the forehead, and a deep lateral branch that runs near the conjoint tendon. Injury to this nerve is rare. Injury to this nerve is common. That's why numbness occurs here and back here, but rarely in the forehead. And the nerve, because it's deep, can make a groove in bone. In about 20% of patients, you can see this groove. David Nyes described this years ago, and you can actually see the nerve at time. You just want to protect it and not cut it. The motor anatomy, the frontal branch of the facial nerve, the 7th nerve, runs about 20 millimeters lateral to the canthus, externally on top of the periosteum. Internally, it's in the roof of your dissection cavity. Here's your dissection cavity endoscopic view. Superficial deep fascia, sentinel vein. Do not sacrifice it. If you do, you'll get more edema and new veins opening up around the eyes. Patients are very upset about this. The frontal branch runs in the roof of your cavity. You are safe if you're over this plane. And just a schematic, this is the frontalis muscle. All the nerves, medial branch of the supraorbital, deep lateral branch, and the frontal nerve. You can injure it here, knock out the frontalis and upper lid, or you can injure it in those areas. Motor injury goes away. I have not seen a permanent motor injury in my hands. I've seen it sent to me, but so you don't have to worry if they get a bit of apraxia. Why do we do brow lifts? This gets into the important part. In most cases, the brows cause eyelid hooding. It's the brows that cause hooding. The brows are the culprit. The eyelids are just the bystanders. In other words, brows are adjusted because patients want a good blepharoplasty. They don't come in asking for a brow lift. It's very rare. It's as simple as that. You have to explain to patients the importance of lifting the brow. So let's talk limitations. This is the most important slide I'm showing you today. What are patient limitations with brow lifts? They're scared. Traditional brow lifts are vertical and perceived to be associated with a surprise look. The term scares patients. It's embedded in their brains. If we rename the procedure and explain the importance of natural brow adjustments, patients are accepting. I've studied this by using different names. I want to repeat. Brow lifts are about a good blepharoplasty. It's the only reason we do them. And in most cases, the brows are the culprit, the eyelids are the bystander. So I use 3 names: a brow reset, a temple lift, and a brow recontour. What is a reset? This woman did not want an extended scar, and she wanted higher brows. I don't think her brows are lower. So we did a reset on her. What does that mean? What that means is when you release the connective tissue adhesions which tether the brow, which are the conjoint tendon, that makes the subfascial space and subperiosteal space continuous. Then you release the arcus. When all this is released, you can elevate the forehead to its natural position. It allows free elevation of the flap that you created in a supratemporal vector along the 3D axis of the calvarium. Remember that. The calvarium is a 3D. It's rounded. So you have an X, Y, and Z axis. So this is her. She didn't want fat grafting. She looks a little hollow to me. And you may feel she looks a little surprised, but this is what she wanted. I call that a reset. The other term I use is a temple lift. Why? Because in the brows, greater than 90% fall most laterally. What's the reason for it? Look at brow aging. There's changes in soft tissue and bone. But to simplify it, let's just talk about dynamic muscular movement. There's an elevator throughout the brow, except for the lateral brow, beyond the superior temporal line in all but 2% of people, but there's a depressor, the orbital orbicularis, so it tends to fall laterally. So in greater than 60% of my cases, I do an endostylar approach temple lift, or what I call a T-lift. I release the arcus from the neurovascular bundle to the canthus, fixate to soft tissue and bone. I always use bone tunnels, I'll show you, and I lift in a 3-point vector for fixation. You do get passive medial lifts in these cases. In a full release, I release the central arcus through the temple. You don't need a scope, I'll show you that. And I never affect the glabellar muscles. It only leads to problems and scares patients more. So as I said before, I have a 90-90 rule. Most patients ask for a blepharoplasty, not a brow lift, when they have hooding. But 90% of them need the brow adjusted. So it's typically the brows that are the culprit and the lids the bystanders. I'm sorry I keep repeating that, but I think if you understand that, you'll understand what we're doing. Who needs a brow lift? Anyone with more than a mild amount of skin beyond the canthus, if you want to avoid an extended lateral scar, if you have brow strain, I'll explain to you what that is, and if a standard blepharoplasty can pull down the brow. So this woman is an example of the kind of brow lift I do. She had fixation to soft tissue and bone, no medial release, she was scared, but you get passive elevation. Look at the improvement in her shape, arch, and contour. And all she wanted was a good blepharoplasty. And if you look at her tarsal platforms, the platform of the tarsus, they're symmetric. And all patients care about is good tarsal platforms and a good blepharoplasty. They just don't know that they need to have the brow lifted. Now, what is brow strain? This is important. The frontalis muscle compensates for heavy lids, ptosis dermatochalasis, and it creates horizontal and diagonal lines even at rest. I call that frontalis fatigue or brow strain. And if you do lid surgery only on these people, when you offload the strain, the brows will fall and the eyelids become heavy. So anyone with brow strain needs to have the brow lifted because the frontalis relaxes afterwards. And this is an example of what I call an inverted V to C change. Look at the brow. It's a V and it's a C. She saw many people and they said, you don't need a brow lift. But the problem is once you fixed her eyelids, the brow would fall. You offload that brow strain. So in fact, she did need a brow lift. And if you look at her, her brow is not higher. It's actually lower because you relax the frontalis. But if I didn't do a brow lift on her, it would have been even worse. Sorry about her bangs, but this is a year follow-up. So you can see brow lifts aren't always about lifting the brows. They're about improving the shape, arch, and contour of the brow. A few more examples of V to C changes. Her brows are high, but I did a brow lift because of this. And that is absolutely an indication to do a brow lift. So in surgery, I don't use any of this material. I just use an elevator, Army Navy retractor, and a headlight. I lift in 3 vectors. It's supratemporal. This one is vertical. These 2 are supratemporal. You get passive medial lift even if you don't release this. If you do release this, you get a medial lift. Where you make your incision, where you fixate, whether soft tissue or bone, depends on the preoperative incision design. Here's a little video showing you.
So marking for brow lifting, I call this an endostyle lift because it's in the same plane as the endoscopic technique, but I don't use a scope. So what I'm going to have you do for me is if you can open your mouth and chew like this. So you can see where the muscle's contracting a little bit faster, and you can see where the muscle's contracting, which is here, and here it's not contracting. You can see the movement there. So that tells me that's where the temporalis muscle turns to bone. On the other side, we'll do the same thing. Go ahead and chew, and you can see where the demarcation is here. That demarcation, where the temporal bone turns to the frontal bone, is called the superior temporal line. Some call it the temporal crest. And then I'm going to decide how I want to lift. So in this beautiful woman, I'm going to lift this way. Look at me. Just like that.
So it tells me where I want to lift her. Here. Nothing vertical about this.
The lift will be up here. So you can see this is bone, this is muscle. And on this side,
so if the incision is over bone, I need a bone tunnel. If it's only over fascia, I can only fascia fixate, or you can do both. So in 60% of my cases, as I said, I only do a temple lift. I do not release the middle arcus, and you can see it's a natural, non-scary brow lift. In the remaining, I do a full release and lift the central brow too. This is the woman you just saw. So this was a full release just through a temporal incision, and it's not scary.
So this is the 3 vectors?
These are the 3 vectors. Supratemporal, and vertical.
And this one pulls that way.
And the outcome to the surgery has completely everything to do with the release, not the fixation. You can pull all you want. If it hasn't been released, the brow won't come up. 2 points. It's not just for women. This works very well in men. Sorry, this is my pre. He sent me the post because he flew from out of country. But it works very well in men. And the other is asymmetries. There are ways to adjust asymmetries. It's a complete separate talk. I can talk to people about it afterwards. How I do it, incision placement. If I'm just doing superficial or deep fascia, I mark the incision one way. If I'm bone tunneling, I do an inverted C. I'm going to show you little snippets in the end, show you a full video, which will be useful to you.
Okay, so this is my marking for my brow lift, especially with the temporal endostyle lift. So if I'm just lifting the tail of the brow, typically I'll take a forceps as a marker, go behind the temporal brow and turn it this way because I want the brow to go up this way. But if I want to lift more medially, then I'll bone tunnel and secure it to bone. And what I will do is round my incision like an inverted C. The apex of it is centered with the temporal crest or conjoint tendon, and then I'll secure the fascia here and secure.
I then release the conjoint tendon from the forehead to the temple. I stake under the periosteum to protect the nerve.
Okay, so my dissection is in the subappenodic space here.
This is the tendon being released. This is critical for the brow to come out.
Beneath the 2 layers of the teeth fascia, and this is your subperiosteal dissection. So this is the conjoint tendon, and we lice it this way.
So that's release of the tendon. I then use something called a finger sweep. I use my finger. For beginners, it's important. It shows you that the subappenodic space temporally and the subperiosteal
Okay,
space
so
are
I've done my
continuous.
dissection. I've released the temporal compartment, the subperiosteal compartment, the conjoint tendon, and the way you can tell that it's free is if you put your finger in, you can see that the compartment.
So you can see it's free. I then release the arcus, and I use something called finger sweep 2 to make sure the arcus is released.
So I have now made the dissection down to the orbital rim in this plane. The way I release the brow is I turn this upside down and pop and pop and pop and pop. I've already done it pre-dissected. If I put my finger in, you can see I've released it. When I pull back, there's no resistance.
And then if I need to, I release the central arcus. This is a mock-up of a Ramirez 4 elevator. I dissect above where the supraorbital nerve would be. You could release it. The only adhesions now are around the nerve. And with direct visualization, you can release it. You can also just do it with your finger and pop through. It usually just gives. So now everything has been fully released, all the connective tissue adhesions that hold the brow down, and then I secure
Okay, so now you can see that
to bone or
it
fascia.
will become a straight line when I pull this up, but here's your deep fascia, and we'll secure to there. And over here is bone, and we'll secure to
You
there.
can secure to there. And this is how I bone tunnel. I use the Stryker power system. You can use a piezo. It's a 1.5 or 1.9 millimeter drill bit. I core out the back because the needle has a long curvature to it, so that it'll go through. You pop through the outer table. If you have bleeding, you can use bone wax, or you can use fascia to stop any bleeding. So results without a scope. We're publishing this now. 327 patients. Sensory deficit, temporary, all resolved by 2 months, was 10%. I think sensory deficit is underreported. Motor nerve injuries, 1.2%. They all resolved. It's all very early on they resolved. It's just apraxia. Satisfaction was 94%. Only 9% asked for a brow lift. As I said, people want a good blepharoplasty. Again, the brows are the culprit, the eyelids are the bystander, and none felt they looked surprised. No vertical lifting, less scary brow lift. Just an example of a 1-week result. You can see the brows are the culprit, the eyes are just the bystander. A few pearls, this is important. Use leave-in conditioner. It's a conditioner you put in their wet hair, and when you wash their hair at the end, they have less tangles, less color changes, less hair complaints. Women complain about this stuff. Post-op comfort, 2 issues, headaches and nausea. For headaches, this is a great medication to give them pre-op if they have a history of headaches. It's a CGRT, a calcitonin gate-related protein inhibitor. We can talk to people about it in private. I inject Marcaine at the end. You don't need Exparel. It's basically Marcaine and a liposome. It's expensive. It doesn't do any better. And caffeine pills. Anyone who drinks coffee, give them 100 milligrams of caffeine afterwards. They won't rebound their headache. If someone has a history of car sickness, post-op nausea, or short foreheads, less than 6 centimeters, I don't know why that is. It's an observation. They have more nausea. If you give them Amend, which is a Prepitant before surgery, they will never have nausea. Afterwards, I like Zofran and I give Phenergan, promethazine, to patients that have car sickness or anxiety. It works very well in them. This is the most important thing. Prophylaxis, pre-treatment with these issues is much more important than rescue, treating them. This scares patients, pay attention to it. If you have a bad headache patient, it's the only person I put a drain in. The reason is I can send them home with a lidocaine Marcaine flush, so if their headaches gets bad, they can just flush themselves at home. If you have what's called a positive vector brow, the brow is more prominent than the eye. These patients, their brows do tend to fall more after surgery. Positive vector brow, and I treat most of them with Botox afterwards. I let them know beforehand. Asymmetries are about a graded release on the lower side. Pulling more on one side does not help. Cutting out skin does not help. It needs to be released. This surgery is about release, not about fixation. I add fat grafting to people with hollows. This is a woman who had a previous blepharoplasty. I adjusted her brow and fat grafted her, redid her breath. And this woman had a brow lift and a bleph. If you didn't put fat in, they'd look hollow. When you're lifting and cutting away tissue, people look hollow. And again, most importantly, the lift is about, thinking that the lift is about fixation is nonsense. It's about release, fixation secondary. Let me show you a video of the whole procedure and then we'll move on. I start my incision with a 15-blade dissect to the deep fascia with a Stevens-type scissors, using the tip of the scissors to create my plane. I then start the posterior dissection with a headlight, Arminimi, a retractor, and a Tenzel-type elevator. I dissect subperiosteal centrally medial to the conjoint tendon. This is the skin, fat, superficial fascia, surgical plane, and deep fascia. I now lyse the conjoint tendon from temporal to medial, staying on bone to protect the deep branch of the supraorbital nerve. This makes the temporal subepineuritic and the central subperiosteal planes continuous. I then use my finger to sweep across. I call this finger sweep 1. It assures the continuity of the dissection planes. I then flip my elevator in a bimanual fashion, release the arcus marginalis to the canthus or beyond, and then I assure that the periosteum is appropriately released with this finger sweep 2 maneuver. Now I use a longer elevator to release the arcus over the glabella, so the only tether now, or tissue tether down, is the arcus marginalis medial and lateral to the nerve, and I can break this from my finger, which is what you're seeing now, or under direct visualization. We found no damage to the nerve, no more sensory deficit than with the standard use of an endoscope. And you can double check it again with your finger, which is what I'm showing here in the video. I now create the bone tunnel through the outer table of bone and make the 2 ends connect. This is a 1.5 millimeter bit. Stryker power system. It has a guard. I don't need it. You want to break through the outer table, make them continuous. I assure that the suture goes through. This is a 2O PDS on a PS2 needle. I start with the most medial fixation, the supratemporal vector, through frontalis periosteum bone tunnel, and then I mattress it through frontalis periosteum because this is not robust tissue, so I want a good bite. So that'll be the first bite in a supratemporal vector. The second bite is through superficial fascia and then deep fascia. Through the deep fascia, because it's not as robust as bone, I'll cross-stitch it, or a figure of 8, and then I take a bite of the superficial fascia posteriorly so that when I tie the suture down, both the front and back part of the incision are tacked down. You don't get wound override, which can happen. The third bite will be in a vertical vector. So the first 2 supratemporal, this one in a vertical vector, and I'm getting a bite through superficial fascia, then deep fascia, cross-stitching again, as I did before, and then a bite through the superficial fascia posteriorly. Again, when I tie it down, this will flatten the incision. So at the conclusion of this, I'll have my 3 bites. I tie the most lateral one first, and that way the tension's on the superficial fascia, not on frontalis. Superficial fascia is more robust. I'll tie the middle bite second. Again, that takes the tension off the last bite, which is the frontalis, which is the least robust tissue. There should be no tension on it then. This is bite number 2. There's no tension on the closure. I'm not bunching the incision in either direction. That's important. And then finally, we'll put the third bite in, which is frontalis to the bone tunnel. And then once this is completed, the lift is done. I don't need central fixation in most cases. If I do, then I modify the procedure to include that. Once this is closed, I'll then close the incision. This is a 5/0 nylon suture. I do a running locking closure. You can use staples too. Many people do. A lot of my patients don't want metal in their head, so I don't. And then you just close along the incision line until you're done. And basically, that's the way the procedure is done. Everything through a temporal incision, full release of the ligaments that tether down the brow. And we've had really good results with this without increased complications, not using a scope. And for this reason, I really haven't used a scope for the last 8 to 10 years. So this is the temporal approach to an endo style or endo. So just take-home messages. You don't need a scope. You should learn with a scope. Make sure that you rebrand the name. Patients are scared of brow lifts because historically brow lifts were vertical lifts that made you look surprised. Don't forget brow strain. If you're doing this, you need a brow lift. And know that most patients just want their eyelids to look better, and that the brows are the culprit, the eyes are the bystander. You have to address the brows. It's about shape, arch, and contour. Lift in a supratemporal vector. You get passive medial lits. Make it less scary for patients. Okay, let's talk about the canthus. Now, I will tell you that the canthus, in my view, is the most confusing structure for residents, fellows. I have visiting physicians 4 or 5 at a time all the time, and they have a very difficult time with the canthus. So my only goal is to simplify the canthus. And I've given this talk in many ways 100 times. It's hard to make it new all the time, but I just want people to really understand the basics. So why is this talk important? It's because colleagues feel that the canthus is a complicated structure and is intimidating, so let's make it simpler. Few really understand canthal anatomy, so let's review it. Many are not sure when to add canthal suspension, so let's determine when you need it. Many don't know the difference between a pexy and a plasty, let's define it. And most feel that canthal suspension prevents eyelid retraction. That is the biggest lie that we have been fed in so long, and I'll show you the data. Let's discuss that. So anatomy. Everything starts with anatomy. The terminal orbicularis fibers create the canthal tendon. It's a true tendon, not a ligament, because it's muscle to bone. It attaches to Whitnall's tubercle, which is 10 millimeters below the frontozygomatic suture and 3 to 5 millimeters posterior to the orbital rim. There are 4 things that attach to Whitnall's tubercle. The check ligament, what that means is when I look this way, my eye stops with about 45-degree turn, then I have to turn my head. That check ligament's important. And then the canthal tendon, the aponeurosis, and the arcuate expansion, or Lockwood's ligament, which is a suspensory ligament of the eye. So it's a complicated structure because all this stuff attaches to it. Please remember this. A lot of stuff attaches to it, so it's complicated. Its dimensions, think of the number 137. It's a millimeter thick, 3 millimeters height, 7 millimeters in length. It's a 3-dimensional structure. It has a horizontal component, a superior and inferior component, the superior and inferior crust, and it has an anterior, posterior, superficial, and deep head. It's the deep head that's important. That's what allows the lid to oppose to the globe. It has a directionality. The lateral canthus is a little higher than the medial canthus. We call this a canthal tilt. When you exaggerate it, get a fox eye. That is the bane of my existence. It's very hard to reverse fox eye surgery. It's complicated. You have to do periosteotomies, relocate it. It's difficult. Be careful with that. Now, if you look at TikTok, our great aesthetic reference, they did a little review of viewers, and they found that a positive tilt was attractive, neutral was okay, and unattractive was a negative tilt. Please pay attention to high-risk morphology. A negative vector, a prominent eye. When the globe is prominent, the lid is prone to bowstringing or retraction when you tighten it. I call that the canthus at risk. Be really careful with that. You're going to upset patients. What could you do in this situation? You can set the eye back by decompressing the orbit. No one here is going to do that, and you shouldn't. You can move the midface forward. You can also vary your suspension suture. But the important thing is, when you have patients like this, be really careful. You don't want to make them worse. By the way, so that everyone knows, I'll repeat it later. The 2 most upsetting things I see with patients are post-blepharoplasty eyelid retraction and a canthus that's tilted too high. They are angry. They have PTSD. They're totally traumatized, and both those problems are very hard to fix. That's the take-home message. This is what you call an orbital decompression. This woman had about 10 surgeries to fix her retraction. It was just a pure scarred up eyelid. So a decompression is when you break bones inside the orbit and take out fat behind the globe and set it back. For every 2-3 millimeters of axial proptosis reduction, the lid comes up a millimeter, and if you reduce the thick part of the floor of the zygoma, the lid comes up another millimeter. You never want to have to do that. Understand lateral canthal function. We know that it supports the eyelid, but as I told you, it's a complicated structure because of everything attaches to Whitnall's ligament. So anatomically, because it's associated with the septum and aponeurosis, people have engaged that and induced ptosis. That can happen. It's involved in eyelid dynamics, closure, blink, orbicularis function. Because of all this, this is why so many patients have canthal complaints after aesthetic surgery. If you have an entropion or ectropion, you take apart the canthus, put it back together. If something feels weird or doesn't work right, it's okay because you fixed a problem. You take an aesthetic patient that doesn't have a problem and you give them a problem, it's very, very different. And so this is the reason why patients have so many complaints, greater than 30% when you do an open procedure. And a lot of complaints is not how it looks, it's how it feels. It just doesn't feel right. And if anyone in this room knows how to do surgery for a feeling, please teach me, because I've yet to learn that. What about aging changes? Tissue descent and deflation, bone and fat alter the palpebral aperture from one which is oval to one that becomes round. And because of all the canthal functions, they all become impaired. They can become impaired when you do canthal surgery. So the key is less disruption is better. I prefer closed procedures. I'll show you that. What about terminology? Canthal terminology is complicated. The lateral canthus is where the upper and lower lid meet. The commissure is their point of union. Tendon and ligament are used interchangeably. Retinaculum is where all those soft tissue structures that attach to Whitnall's tubercle also attach to the canthal tendon, and the raphe is where the orbicularis fibers from above and below come together. The literature uses these terms interchangeably, and it's confusing. Same thing with temporal anatomy. Every tissue layer has 5 different names. I think it's done just to confuse us. What about canthal surgical terminology? The incisions. A canthotomy is a cut with or without dividing the commissure. A cantholysis is a dynamic release of the canthal tendon, usually the inferior crust of the canthal tendon. So a canthotomy is different than cantholysis. What about approach? An open approach requires a canthal incision, a canthotomy, to do your work on the tissue. A closed approach is from the upper lid. It's closed. You don't open the canthus. It disrupts anatomy less. You're further away. Procedures. A canthoplasty is when the canthal tendon or terminal tarsus is modified, cut, shortened. You create a raw surface. When you resecure it, you get a scar. It holds in place well. A canthopexy is when these tissues are just folded on themselves. There's no raw surface. It's not as powerful. So understand that a plasty is a much more powerful procedure than a pexy. I prefer plasties on every patient. However, I don't like the traditional tarsal strip where you take the lid apart in cosmetic patients because I like to avoid lid shortening, preserve the commissure, preserve orbicularis, less disruption. Patients like this need it, but try to avoid traditional tarsal strips on primary aesthetic patients. Do it on revisions, but not primary aesthetic patients. You don't want them complaining afterwards. This will cause complaints. My preference is the closed procedure. Many people have published on it. 2012. It's been almost 15 years since we wrote about this. It's from an upper lid crease incision. I'll show you the video. You access the canthal tendon, do a graded cantholysis, and when you do this, you spare the commissure, the canthal angle, the orbicularis, less traumatic, and in aesthetic cases, it's absolutely enough. So a lid crease incision is made, a cantholysis, full thickness sutures are put through the commissure and then tied. This is elegant, predictable, and consistent. The next procedure I use is the commissure sparing open canthoplasty. It sounds like a tongue twister. Basically, it's when you perform a canthotomy, but you don't take apart the canthus, and I'll show you a video of it. So you make an incision, cantholysis, put full thickness to the commissure, and tie them. When do I use this versus the other? If I'm going to do midface work, and you're here, it's easier to access it than when you're doing it from the upper lid. And this just shows you the canthotomy, cantholysis, interorbital rim periosteum, sutures, and tying them. Tools that I use to help me with surgery. One is a retractor lysis. What do I mean by that? Let's say I'm just doing a skin pinch or a skin flap without a canthoplasty. The lid can still retract. The margin can still rotate. So I always add a transconjunctival incision to cut the retractors, and then I put a little intermarginal suture, which I'll show you through the corner of the eye. So whenever they open their eye, they pull the lid up. It just helps prevent retraction. A retractor recession, which is when I take the retractors off, I only use in retraction cases.
What I'm going to do now is release her
This is a retractor recession.
Is the retractors. Here's the edge of the conj right up there. You can do this with the scissors. Or you can do it this way. You
This is the conjunctiva over the globe.
Oh,
This
yeah.
is the septum. This is the retractors being taken off the conjunctiva.
The retractors off.
You do not get entropion, estropion, etc., but it does give you some elevation to the lid. And on patients that have retraction, I use it. This is an intermarginal suture. It's a suture through the lateral part of the lid, upper and lower lid. It does two things. When you open the eyelid, it pulls up the lower lid, and more importantly, it prevents chemosis. And when you're doing canthal work or transconjunctival work, you get chemosis. It bothers patients. This is what it looks
Okay, so
like.
this is a tarsorrhaphy or intramarginal suture that I put after lower blepharoplasty when I excise skin and do a canthal suspension, or if I don't think it needs a canthal suspension, I do it anyways. It does two things. As you can see, it is a transconjunctival incision. So when I put it in, every time the upper lid is elevated, it'll elevate the lower lid. That supports the lower lid during healing and also prevents chemosis. So what I'm going to do is put a suture through the gray line or lid margin. This is a 5-0 chromic. And then through the gray line over here. And when I tie it, it'll put the lids together laterally. So when the eye is open, it'll pull the lower lid up and also compress it to stop chemosis. As you can see, it pulls
See how
the
it
lid
pulls
up.
the lower lid up? It's just a protection. Okay, the two procedures. This is the...
So a temporal lid crease incision is made. This was in the setting of the blepharoplasty. So the lateral part of the incision was open. A suborbicularis pre-periosteal dissection ensues to the canthus. A cantholysis is performed. I tend to do it in a graded fashion. This shows you a full cantholysis as the patient wanted a little elevation of the canthus. Be careful when you do that. Changing canthal position on a patient can upset them unless they want it done. The Q-tip is used to expose the inner orbital rim at or about Wittnall's tubercle. As we discussed previously, many things attach to Wittnall's tubercle, so you got to be careful in that area. A double-armed 5-0 PDS suture is passed through the commissure. Both ends are passed through. Now, you got to pay attention when you do this to go through the commissure or terminal tarsus, but avoid engaging the levator aponeurosis or the orbital septum, because these tissues can tether the lid down and create a mechanical ptosis, which typically goes away on its own, but sometimes is permanent. I've had these referred to me where I've had to go in and revise them. The inner rim is then exposed again, and a bite will be taken with both arms of the suture to secure the lid to the inner rim. So that was the first bite that was placed, and here will be the second bite that's placed. I like the RB2 needle because it's small and curved. The RB1 needle is too large. You can use any needle that's kind of like a fishhook in this area, so you have a needle that's not too large to maneuver in this area. Now you can see when I secure the lid by pulling on the suture, the effect on the lid. So we're pulling on it there, releasing it, pulling. I'll repeat this a few times just so you can see the effect on the lid. Also see that the commissure is left intact. You don't have to reform it. That's less disruption. When I tie the suture, I'll usually do 3 throws. I don't like doing more than 3 because the suture can be reactive, and when you put more bites in it, sometimes you could feel it afterwards. But when I do 3 throws, I don't tend to feel it as much, and you can see how the lid is secured, and that is the procedure.
Okay, now this is
So
the...
a canthotomy is performed, and I typically spare about 3
This is the one
millimeters
with the
of
canthotomy, commissure spare.
That ensures its integrity at the end of the case so that it doesn't have to be reformed. Dissection is carried to the periosteum, and as you can see, an incision to the canthal tendon is made, the common portion of the tendon. The reason for that is to expose the inner orbital rim periosteum. You want a raw surface so that when you secure the lid, a scar is formed to hold the lid in position. A double-arm 5-0 PDS suture on an RB2 needle is then passed through the commissure, or the commissure with engagement of some of the tarsus to secure the lid. If you engage some tarsus when you secure the lid, you may get a little buckling at the corner, but that goes away usually within a few weeks. It's not an issue. You can see when you pull on the lid, the effect on the lower lid. Both ends of the suture are then passed through the inner orbital rim periosteum. That space was created when the common tendon was cut. And this is the second bite of the suture. When you pass them both through, you can secure the lid. It is harder to engage aponeurosis and orbital septum with this procedure as compared to a closed procedure through the upper lid. That's one benefit of doing this surgery, although you still can induce ptosis if you engage those tissues. You can see that the commissure is intact here. You have to leave enough commissure intact so that you don't have to reform it. And then again, I close this with 3 throws. I don't like doing more than 3 throws, as you can often feel the suture. And then there's more suture substrate for inflammatory reaction postoperatively, so I limit it to 3 throws. Another nice thing about this procedure is because you have an open canthotomy, you can engage the midface and lift it if you need to in conjunction with this procedure. That's harder to do from an upper lid crease incision. And then you just close with interrupted bites. It's important to put one interrupted bite adjacent to the commissure so you don't get a little web in that area.
Okay. So in my experience, these procedures were much more... Patients were happier than doing traditional open procedures, so we studied it. And what we found that if you looked at complications, really complaints, because they all go away, that if you did the closed procedure, there were less complaints. And this is just an example. If you do this a lot, it doesn't matter how you did it. This is a tarsal strip, this is a commissure sparing, and this is a closed procedure. The results can all look the same if you have experience with this. The only time I use open procedures when I disarticulate the canthus is for cases like this. Typical eyelid retraction. I do a lot of eyelid retraction. Unfortunately, I should do less of it. As you get older, you have less tolerance for this stuff. Eyelid retraction, crazy, same kind of stuff. This is a woman who just sent me her photo, so I added it. This was her before. She lives across the country. This is her own picture at 6 months out. These are hard cases. This was a rock star, believe it or not, who had this happen to him, had a poor skin graft. So I took skin, I did a flap from the upper to lower lid. I couldn't get rid of his old skin graft. Looks good in pictures, though. Again, when I do an open suspension. So take-home messages, perform less invasive procedures if you can. Who do you do it on? Transcutaneous surgery, you always do it. Standalone transconjunctival, it would be rare. Transconjunctival with a skin excision, I do it 70% of the time. And in revisions, I always add a canthal suspension. Take-home message number 3, do not change canthal angle or tilt without serious discussions with patients pre-op. Even then, be careful, because this really upsets them. And this is the most important thing I'll say. Canthal suspension is a support and canthal angle reformation procedure which should have no tension on the closure. Just like on a facelift, you should have no tension on closure. It does not prevent lower lid retraction. That is false teaching. As I said, I see more than 100 patients a year. In the last 5 years, I saw 565 retraction patients. Does anyone want my practice? I don't think so. Most of these patients, greater than 90%, had a canthal suspension, a majority of pexy. So if all these patients were getting canthal suspensions and still getting retraction, why does the literature say it protects you? It doesn't. What you do to the skin, too much skin removal, muscle, weakening it, fat, taking out too much fat, and globe morphology, the vector, dictates postoperative low lid position, and a canthal suspension cannot overcome any of these issues. An hour and 20 minutes of talking, my mouth is dry. One last thing I wanted to say. This is my new puppy. This is Ocean, the newest member of our family. Most important thing I said. Thank you.
So in fact, I'll be talking about the axial vector suspension technique and how do I do my lower eyelid surgery. To start by a dramatic sentence, I hate transconjunctival approach. And imagine I'm in front of my professor and saying this, where he told me the best way to go is transconjunctival for safety reasons. But again, in life, you have to think why someone quits doing something and what you can do to change. So in fact, I've published everything. I was very critical in eye. 15 years ago, I never thought that I'll be working a lot in eyelid surgery. And I created things that think about how can I fix problems. To fix problems, you have to take the risk of doing things new and to accept where to find solutions for them. So nowadays in lower eyelid surgery, I do in fact only two techniques. The boomerang technique, which I published about how to resect the maximum skin in lower eyelid without having retraction by a mathematical strategy, which you can read the article. And the second thing is my technique, which I do in 85% of my patients. So when someone comes, have excess skin, I'll be doing the boomerang technique. If someone has fat bags only and very young without any additional problem, I'll do transconjunctival. This is the only way. I do less than 5 surgeries a year. And the rest, I do the axial vector suspension because the patient has fat bags, tear trough, tear valley, a part of any laxity. So when I see eyelid surgery, I don't see the fat bag. I see where is the cheek, where is the tear valley, where is the tear trough, where are the malar mounts, how's the lower eyelid suspension. I need to suspend everything. So this is patients from social media, from colleagues, my friends, which when I see the result, okay, the patient is much better. It's maybe a 9 over 10, but I'm searching 10 over 10, which is difficult and perfection is not there. So what things makes you don't choose the case? Oh, you corrected the fat bags. Well, how about the hollow? And how about then you need to find other solutions like fat grafting, like other solutions that you have to add on. And for me, what is correct in eyelid surgery to see cheek suspension, fat transpositioning, tear valley correction, tear trough correction, nice transition, a nice canthal support, all this. So this is for me top eyelid surgery. But again, what is top for you doesn't mean what's top for others, what's top for patients, what's top. I don't operate for the patient, I operate for myself. If I don't like the result, I'm the first one who's criticizing my own result. So I don't care what he thinks the patient. I think what is natural and what I think is correct for him. Then if he doesn't believe what I'm doing for him is correct, then it's better not to choose me. And again, for me, having nice transition here, nice transition here, nice transition here, and okay, you can also add fat grafting here and fix it. But then again, you don't get the suspension. And for me, this is a sentence from Dr. Guy, which I copied him from a slide he had one day. He says, contour lower plastic lid and cheek junction as a unit. And I don't know if you remember this slide. So in effect, it's a unit. Not only the eye and the face is a unit, everything is a unit. From down to up is one unit. Yoth is one unit. You need to have good suspension, you have to have good fat volume, and this is all one unit. So what I've been doing through years is trying to increase my results. And how did I increase my results? Start resecting skin, then resecting fat, then fat transposition, then canthopexy strip, then cheek suspension, then muscle suspension, then doubling the muscle, then boomerang technique, then skin resurfacing. And this is how I do now my live surgery. All is done in every patient. So again, my technique is a technique that it's not my technique. It's a copy from many people I've seen in the world and add on for everyone's things I like and I get it back to my surgery and add it. By this, I can create the surgery. So let me tell you something. In surgery, you have two options: to copy the people or to create Control-Alt-Delete for what you know and then paste what you think it works. And all roads leads to Rome. And again, what is happy is that if the patient is happy. So this is pearls and wisdoms after thinking everything. You think that your trough depression is a must to fill. You need to fill this area. So the only way to fill this area is by transposition, except if he has a very nice bone, the depression there is not there, and you can resect a bit of fat, but you need to select. Second thing, there is a need for suspension. We have bone loss. As we age, we lose bone. And losing bone, you lose result. Point. So or you suspend now, or later you need to suspend. Periosteum. Periosteum is very weak. Never suspend on the periosteum. It's so weak, the periosteum, that you're suspending over periosteum there in that area will not work. So the best place to suspend is the orbital thickening. The orbital thickening is the best place.
That's why you can dissect without any problem. There's no veins, there's no arteries, there's nothing. It's a space that's clean space. It's very important to understand that this zygomatic space is my space.
Great. The second thing is I never dissect in the perizygomatic space. I always dissect submuscular. And I think worldwide, I've seen on many people, they are saying that they are dissecting in the perizygomatic space, but I see the slides, he's dissecting submuscular orbicularis. And this was published by Mendelssohn. And I mean, I don't know if I need to call it the fucking from fucky space. So again, for that reason, and as you know, the thing is, when you go downwards, your space is the submuscular space and not the perizygomatic space. Because when you dissect submuscular, the cheek lifts up. If you go through the perizygomatic space, which is below the SUV, you don't have too much to elevate. You have restriction in elevation. The second thing is the SUV is fixed. This is a video from Dr. Carlos Neves. And the SUV cannot move. So the SUV is a fixed fat over the bone. So you cannot dissect under the SUV to lift also good correctly. So what you lift is exactly the subcutaneous fat and the skin and the orbicularis muscle at one point. The third, if you want to increase your support, you need to double the muscle. So if I double my orbicularis muscle by doing this and shifting all this upwards, I'll be creating and adding more support to my orbicularis muscle and creating a more thick muscle. This creates more power support. So again, and finally, you need to resect the correct excess skin. Because if you little correct, then you have skin laxity. If you overcorrect, then you have retraction. You have to manage. So what does the change made the boomerang technique? It's a lateral vertical cut. It's not a straight cut downwards, creating more cut obliquely, creating a drift shift from medial to lateral resection. I would recommend everyone to read because it's a step-by-step article. 9, do a checklist. Know what to do. Depends. I will not stop here discussing every point because it will take me time to discuss it and I don't want to lose my 25 minutes which I have. Again, copy this. If one day you want, I'm there, you can ask me. I can step by step tell you what I should do, analyze, and what things I would recommend. So again, something else which is important is, first I'll be drawing the patient. I'll be drawing from A to B, from B to C. It's a 10 millimeters distance here, and always a 10 millimeters distance, but later I can change if I need. And then I measure all these things there. I will mark the areas that she has hollow. I'll mark the suspension points which I need to suspend upwards and shift things upwards. So after I do this, and after I plan, I'll be starting making skin excision from A to B and from B to C. I never use blades like Dr. Guy said. I'll be using this radio frequency cut. And again, I'll be dissecting subcutaneously only in the orange part, not from B to C, only the orange part. After dissecting subcutaneously, the second thing what I do is a cut in the muscle, and I'll be dissecting under the muscle, release the ORL, and go below the muscle. So then, as you see, my cut, I can cut by scissors, or I can use the monopolar if you want, and you cut the orbicularis muscle at 15 millimeters. I want all the orbicularis muscle up there, helping me as a support. And after this, I'll be searching for the fat bags and create the release. After I do this, the fat bags is there, visible. And now my second step is to really push the orbicularis muscle downward, release my ORL, and enter submuscular plane. Always I'll be going submuscular plane. Okay, so my release is there, and I continue my release. I'll be reaching up here to really release all the area from one corner to another corner in submuscular plane. So remember, in the anterior part, I'll be making a cut at 50 millimeters. I'll be transecting and go submuscular plane. Now I'll be going in the lateral part. In the lateral part, remember that I did not elevate the skin here. The skin was only elevated in the orange part. So what I do is I'll be reaching the submuscular plane in the lateral part, and I'll be going over the SUV below the orbicularis muscle, also in the lateral part. So then my cut is here. Maybe we can stop if you want the sound from the videos. And then after I make the cut here, what I'll be doing exactly is that I enter the submuscular plane. So this is the submuscular plane. As you can see, I really search with my peristome. This is a 90-degree peristome. And again, I'll be seeing this whitish orbital thickening that we have at that side. So remember that the orbital thickening reaches up to here, exactly. So all this is orbital thickening that you have here. So the orbital thickening is not only here, so it can reach up to down here. So as you can see, this is the difference between going over the orbital thickening and below the orbital thickening. You see, this is the periosteum, and the other side is not the periosteum. Okay, so it's very important to leave the orbital thickening there intact, and you go over the orbital thickening below the orbicularis muscle. So after I did this, you can see this is the orbital malar retaining ligament. We should not call ligament, because ligament is from bone to bone, but here we don't have from bone to bone. It should be attachments. We should change all the names of eyelid surgery, because also the canthal tendon is a ligament, my friend. Then if you're talking about ligaments, it's from bone to bone, and we don't have bones here. So again, after this, we release this attachment, and after releasing this attachment in the submuscular plane, we will continue downwards to, remember, I'm going submuscular plane. After I did this, you could see the orbital thickening there, very nice to support. It's very important. You can put a suture on the orbital thickening and lift the cranium if you want. I can show you today in the anatomy lab. I will put a suture and lift the cranium with a suture, with a zero suture. You can lift it. It's very powerful attachment. So after I do this, in that all attachment, I can really have safety for attachments. Again, I'll be dissecting. I can reach anywhere from here to the corner of the mouth if I want. It's a safe plane. I'm going under the orbicularis muscle, transecting, going deep in the subcutaneous, deep fat, or the zygomatic muscles, and I can go to the mouth if I want. I release up to here just to make all the cheek release and lift upwards. After I do this, I'll be finding the three fat bags. Remember, this is the nasal fat, the middle fat, and the extension of the middle fat. This is not the lateral fat. If you transect the arcuatus, you will see that it moves medially. So this is not the lateral fat. That's why many surgeons leave this lateral fat. They think they really sect the lateral fat is an extension of the medial part. The same thing happens with the upper eyelid, that the middle fat extends to the lateral part, covering a bit the gland. So after we do this, I search for the oblique inferior muscle, and as you know, this oblique inferior muscle continues with the aquatic expansion and inserts in this. You need to cut here, because usually the middle fat extends a bit laterally. Not in the majority, but I can tell you maybe in 90% of my patients. After this, I transect and identify the ligament. I transect it so I can do a good transpositioning of this. So after I transect everything there, I can move all the fat correctly. And after things, I free the fat. This fat, you need to transect it from there. And after you release, you can see that you move the fat. You see, this is all the middle fat extending laterally. Again, if you want to go for the lateral fat, you need to push a bit more deep. It has also a bit of different color. You can always see it and see the difference between the extension of the middle fat and the lateral fat. After I did this, I start transposing my fat. I need to transpose from up here, from up there to there. You can't start transposition from here, because after surgery, you'll also feel there's some hole here. Then you need to use fat grafting to transpose there, or add fat there. So I start fixing first the middle part, and I transpose exactly from this. This part is difficult to transpose because you need to release a bit the liquid nasali sometimes. You need to push there. There's not too much good suspension to the periosteum there, so you need to really be creating a soft dissection and transpose it in a way that you can really fix. So I'll be using vicral sutures or monocral suture, soft suture to transpose. I started with nylons and I shifted for the last 5-6 years with vicral. So after I do this and I transpose everything there, all this transposition is done. And as you see, I'm transposing everywhere. So I really need to transpose well. So I need to really reposition the volume. And it takes time to reposition every stage of the volume in every place. So I can create a nice transposition of everything of the fat in the area, giving volume to all these places. You see, I'm transposing very high upwards. And then after transposition, if there is excess, I'll be cutting and reduce with bipolar or with the scissors. So all this transposition is done. I go for the lateral part, and I'll be resecting the lateral part. You don't need the lateral part, and you reduce it. You can use the bipolar, the scissors to reduce it a bit. Try not to over reduce, because you need a bit of fat to transpose nicely to the other side. So after I did all the fat transposition of all of it, you see, I'm transposing up to high here, because why? I'm putting also there because the patient doesn't have a sulfa to create this nice transition into their cheek also. And again, I have this transposition there, everything is transposed, and then I do dissection upward, submuscular again, submuscular dissection upwards. Why I'm doing that? Because I want to do now a cantopexy. Cantopexy doesn't do nothing to suspend you there, but doesn't prevent, as Dr. Masri said, from any retraction, from anything. And there's a friend of mine which is in Los Angeles, which is called Dr. John Shamoon, and he thinks that it's a bit of nonsense if you're not using it for anything else, and it can only create more recovery in the patient's healing. And again, he started not doing cantopexy on the axial vector suspension, and he found that it's very similar, but I'm still doing it. Maybe I need to jump and see if that's true. So again, after I do this, I'll be doing cantopexy there, okay? And in fact, this is where I'm putting, really you should feel that you've taken a good bite, and you have really a very good suspended there. You try to check, and if that is down, then you're good. After I do this, I'll be putting another 2 sutures there downward, 1 up for the cantopexy, 1 for the muscle suspension, and 2 for the cheek suspension, or are tackling the orbital thickening. So as you see, this is the lower part of where I'm putting. So these 2 sutures are exactly here. If you see my face, it's exactly here. It's not up here. It's exactly in the hollow of the tear valley. Okay, so now everything is suspended. Okay, so I have a 6-0 for the cantopexy, 5-0 for the muscle suspension, and 2-4-0 for the cheek suspension. Great. After I do this and everything is there, you need to suspend. Doing transcutaneous surgery without doing all these points is a failure. Yeah, you have high incidence of problem. But doing with all these safety mechanisms, your failure is much less. Barely. I never had it up to date in my procedures, because you see, I'm doing a lot of things add-ons to reduce my risks. So one of them is part of the technique and others of the suspension until now. So now I have everything suspended. I start doing cantopexy. So I will jump about not reducing time for explaining how we do cantopexy. Dr. Gomez showed it. But again, you need to tighten well. It's tight. You don't over tight. You need to continue nicely good. So as you push it there, you need to put it in a way that it really stands good and nice. And you can really need to check how good you tight it by checking. So as you see, I'm pushing it, I'm tightening it. And after the tight is good, I evaluate and check how it's looking. It's not creating any here in a way that is being not nice. So after this is done, and you can always check what you can do with cantopexy, and you need to validate how it is. I can feed the tight, okay? If you do this and it comes more, you need to check if the medial cantle is also well suspended, and you need to do a medial cantopexy. Or if it's too much still there coming outside, maybe you need to do a tarsal strip. But then these patients, if you don't add things for them, you have a problem, because you need to evaluate how is the tendon at that place is good retained. So again, after doing this, in some cases, I'm obliged to do tarsal strip. And in that patient, I did medial cantoplasty, lateral cantoplasty, a tarsal strip, because it's a very long tendon and very weak. And if I don't add these add-ons, I know that I'll have a problem. As much I add add-ons, I reduce my problems. So again, after I do this with, as I said, cantoplasty here, I can see that it's well tight, powerful, good. Then I know that I'm adding all my results safely. Again, after adding safety to the result, I do now the cheek suspension. This cheek suspension, I should tackle all the cheek upwards, and all this, there is no SUF relapse. The SUF does not relapse. What relapse is the muscle and the subcutaneous fat and the skin relapse downwards. See, if you do like this, on anyone, only taking the skin, you lift it up. You didn't lift the SUF. The SUF is much more deeper space. Again, all this is elevated. The flap of the orbicularis muscle with the subcutaneous fat and with the skin is elevated with a 4-0 upwards. This elevation, and I fix it. So I fix with two sutures, one suture here and one suture here, to create a very nice fix upwards. There should be no indentation in the skin and nothing. So after the cheek is well suspended upwards, all my team is pushing upwards to really create a good suspension of the cheek. And after this is done, I fix another suture beside as an add-on helper. Okay, after this is suspended and cheeks, I can see now everything is suspended very well in the area with two suspensions. I have this. You push down with the cheek, it's very powerful suspended there. So you're adding safety to your lower eyelids. So after I did this, the suspension, as you see, the muscle, the orbicularis muscle is doubling now the other muscle. Remember that the orbicularis muscle flap, it's coming to cover the other 50 millimeters orbicularis muscle on the back. This covering of the orbicularis muscle, I'll be doing now the boomerang technique, which is a vertical cut. So as the flap of the muscle pushes upwards to cover the other flap, I'm adding orbicularis muscle tone, doubling the muscle tone. So with this creates much more support to my orbicularis muscle at that area. So I'll be doing now as you see, the skin of the muscle is covering the other muscle, and I'll be doing my boomerang technique. And as you see here, I'm showing you how the orbicularis muscle from the lower flap comes upwards to cover the upper flap. And by this, I'll be doing my boomerang cut. Okay, so I'm showing you many. See, the cheek is fixed. You can't get down here. Nice fat transpositioning. Now the orbicularis muscle here is covering the other orbicularis muscle, giving more add-on and more support because in the back there is. And now I'll be resecting the skin. So I'll be doing my boomerang cut, which I would recommend to everyone to read about it. So which is an oblique cut in the skin. And after I do this, I'll be putting a suture here to fix it. So you see, it's an oblique cut. It's not a straight cut. It's an oblique cut, shifting the skin in oblique, pushing all the medial extra skin to lateral side. So after I do this oblique cut, I put a suture, and by this I fix it to the area, and then evaluate if my plans to resect skin are good. So how do I evaluate? I check exactly, and I draw exactly, and I push the eye upwards to see that it really covers all my excess skin that I have. So after my assessment, pushing the eyelid upwards and see that the skin can go up to there, then I cut the excess skin. After the excess skin is cut, I'll be putting simple sutures on every place to really do. And after simple sutures to that place, I close all the middle part. I still have the lateral part to manage the excess skin. Before I manage the excess skin in the lateral part, I finalize with redoing again the orbitomolar ligament, the one I removed, so to create more tighten on the orbicularis muscle, this part. So again, with the suture taking the bite of the orbicularis muscle, without creating, if I see there's an indentation, I need to release it and take it from more deep. You see, then I went to more deep and recreate again this support and suspension. After this is done, the suspension is done and closed. Again, I'll be closing, and the last point which I'll be doing is resecting the lateral part by a straight cut. Now remember, boomerang cut here, now straight cut. So after the straight cut, I do a straight cut, and then I'll be doing cutting all this by a straight cut and using the monopolar to cut. And after using monopolar to cut, I'll be doing vicus sutures there, 3 to 4 vicus sutures, depends on the incision. And then after I do the vicus suture in the subcutaneous layer, I close with simple sutures all this part. So simple suture closure is done, and voila, we have everything solved for the eye. So after this, you have now a very nice support of the eye, good cheek support, nice fat transpositioning from medial to lateral, nice support in the cheek, everything seems nice, and you have a very full lateral cheek. After I did this, you can always see how powerful is the support on one side compared to the other side. I can show you millions of cases of either supports, and other cases you can see the difference in when you shift and when you support everything. So this surgery is transcutaneous, but with many things to save my results. Because if I don't know the many things I do, then you have high incidence of retraction. And then for sure, if you want to teach, you would say, don't do transcutaneous surgery. I always say, everyone who comes to see me said, don't do transcutaneous surgery. Learn very well transconjunctival, and then add on to your, but you need to do all the steps to be safe. This is complex, also tough. This is my maximum. She has permanent fillers here. I'm not able to increase more. And you see, as I lifted up all the cheek, you need to do a abroad because there's excess skin moving there. Again, this is the improvement of someone who has a dramatic issue on that. Again, another case of another patient, young with cheek relapse, fat bags, tear trough, tear valley, mid-cheek volume, no fat grafting there, only the fat I use from her eyes. Again, see the lifting capacity of the cheeks when you push upwards to correct tear valley. There's another option to do a facelift or to do the more technique or to do the other techniques to push upwards. Every instrument here is built up with a lot of time of investigation. And again, for why I do this technique, for me this technique is more corrective. I transition at 50 millimeters for leaving more tone. I do submuscular planes, better suspension because I suspend over the orbital thickening. I do vectoring suspensions, more safety, more correction. I double the orbicularis muscle, more support, more younger transition. I do a bone closure, better adaptation for my this. And if you want to get all the articles and you would love to have and get access to all these articles, you can scan the QR code and just jump in and get all the, we have a community. I'm there always to help you. I can help every patient as much as he is reasonable to the results we can achieve. If not, then we are not. This is the truth if selecting patients. Just if you're a starter, choose wise. If you're an experienced, choose wise. Keep learning. Knowledge is very nice. Thank you.
So good morning, everyone. It's a pleasure to be here. Thank you again for organizers, Mike Nayak, for the invitation. It's the second time. Also, it's an amazing city. And I talk about my technique. My new technique is the temporal lifting, but I show you that it's not only a temporal lifting, but more. So look at, if a patient like this came to us, we have to correct several problems. Look at the hooding effect in the upper eyelid, the positional eyebrow, the deep elliptic junction. So in patient like this, the problem is not only the excess of the skin in the upper and the lower eyelid, because sometimes patients come to us asking for a simple blepharoplasty, but sometimes a simple blepharoplasty is not enough to obtain the best results. So during the last 20 years, I focused my attention on different techniques. I published several articles from a deep approach and the tie ribbon. And today I arrive to my favorite approach. My favorite approach, you know, probably is a temporal more techniques, because I think that the role of the orbicularis muscle in the aging process in the periorbital area is very, very important. It's the key of success in our hands. So without retention in the orbicularis muscle, we can obtain the best results. I'm very excited to present my new article, Temporal Modified Orbicular Deposition Technique, just published on PRS journal. This journal is one of the most famous journals in the world in our field. Through a temporal approach, we can address the entire mid-face area, elliptic junction, lower eyelid, and we can improve in a very, very effective way the aging defects that we can recognize in this part. In this article, we analyzed more than 200 patients with reported daily satisfaction rate with a face Q questionnaire, and the technique was very, very effective, quick, reproducible, and with few complications. I invite you to try this technique and hope you enjoy this article. So the problem is that in the temporal area, we can choose between just two approaches, because the anatomy, I always say, is not an opinion. So we can choose between a superficial approach or a deep approach. You know probably the different layers. We have to recognize the superficial temporal fascia, the innominate fascia, the fat, the deep temporal fascia. So in other words, we can dissect the temporal area or by means of a superficial approach, just under the skin and over the superficial temporal fascia, or vice versa. We can decide to dissect deep between the superficial and the deep temporal fascia, because you know that our friend, not our enemy, our friend is the frontal branch of the facial nerves. You know that the nerve runs just over the superficial temporal fascia. My first approach, I used this approach for several years. Sometimes when there has indication, I use this approach in my daily practice. This is the transtemporal with the deep approach. I published several articles because in this way we can anchor the scalp to the deep temporal fascia. It's a very, very effective technique, but sometimes my results are not so effective. So look at a patient like this. Is a particular patient with a negative vector, with a sagging of the midface, with fat, sclera show. So in this case, it's not sufficient to perform just a simple blepharoplasty, but we have to consider several auxiliary techniques. Look at the correction of the negative vector and look at the position eyebrow. So the deep approach allows us to obtain good results. What about the endotyne? You know the endotyne is a very, very effective tool in our hands in order to obtain a stabilization of the flap. I used this technique for several years. You can find the article on PRS journal published in 2009. And this is my publication. Look at the patient, upper and lower blepharoplasty, endotyne in the temporal lifting, good results, very natural. But my patients sometimes wanted more, and me too. And so why? Because the aging process in the periorbital area is a complex process. Is the similar thing in the lower eyelid. Patient thinks that is the skin the problem. It's not the skin. The skin is the top of the iceberg. And at the same situation in the periorbital area is the sagging of the muscle, the entire orbicularis muscle. So sometimes we have to add to correct several problems, from the position eyebrow to the elliptic junction, the malar mounds, malar festons, sclera show, laxity in the lower eyelid. So I find to optimize the correct technique, and this is my technique that I use now. So make an incision the airline, we arrive to the lateral border of the orbicularis muscle. I show you during the dissection where we have to open the muscle, and then we dissect the muscle and this muscle, and with the position entire flap, orbicularis muscle and eyes muscle to obtain the best results. So you invented this technique. Many authors during the last 40 years have focalized their attention on the importance of the orbicularis muscle in the aging process. They describe many techniques with orbicularis muscle suspension or with orbicularis muscle dissection. You can find different articles. So they recognize the importance of the orbicularis muscle in this part of the face. Anatomy is very important. Look, we left the skin and we dissect the muscle. This is the line where I open the muscle. It's 1.5 lateral to the orbital rim. It's very important when you make an incision. Then I dissect the orbicularis muscle and the high portion of this muscle. You can decide how long should be this distance. Sometimes it's sufficient to address the orbicularis muscle. Sometimes you have to expand. You drop lower. So you can combine orbicularis with the smart flap as you want. In my total mass facelifting that I show after, I combine orbicularis, mass platysma. So it depends what you want to obtain in your hands, in your operating theater with your patient. So look, this is important. This is the orbital rim. So this is the periosteum over the orbital rim. So I dissect the orbicularis muscle from the periosteum. As this is the space that I dissected, zygomatic minor. So it's very important to arrive up to here because I can release the zygomatic ligaments. It's a key of success if you want to reposition the entire midface area. So this is the suborbicular occiput, and this is the extended dissection area that I use during my technique. So I repeat again, for you, anatomy is very, very important. You can recognize the fascial nerves with the different branches. We examined it after with the total mass technique, but it's amazing. It's a dissection course that I performed several months ago, and you can recognize the muscle. You can recognize orbicularis muscle, the frontal branch, the transverse artery with the zygomatic branch, the buccal branch, the sternum dorsum, and then the fascial and the artery vein here, and the relationship between the marginalis branch and the artery. It's very important because in order to obtain good results and to prevent complication, we have to know the anatomy very well. And this is the relationship between the frontal branch and the orbicularis muscle, because a common question is where you make an incision on the muscle. You make an incision on the muscle 1.5 to 2 centimeters medially to the frontal branch. Also, look, is the medial. The average is 1.5 to 2 centimeters. So it's very, very, very important. Again, another common question is the denervation of the muscle. So there are many articles we describe the anatomy and the innervation of the orbicularis muscle. We have to recognize the first, the most important probably is the frontal. The second is from the buccal and the small portion of the zygomatic part. So we cause a denervation of the zygomatic part. The positive effect is that the crossfit disappears forever. So for the Botox injector, that is a negative aspect. It's very important to avoid to open the lower, because my friend's guy, Nabil, you know that one of the causes of the lower height displacement, probably, it's not the amount of skin that we remove, but the denervation of the lower height. When you make an incision, also in your technique, I have performed Adamson flap for 20 years. Sometimes you can cause a denervation, partial of total of the lower part of this part. In the postoperative period, you can have a weakened situation in the lower height with the sclera show if you are fortunate. Ectopium is you are not fortunate. So it's very important, in my opinion, to leave intact this part of the muscle and to focalize your attention in this small portion in order also to treat this part. You can read a different article about this, but it's very important. This is another important article which describes the importance of to leave intact the lower part of the orbicularis muscle. So what about my technique? So there's a limited subcutaneous dissection and extended deep dissection. With my deep dissection, I arrived up to the nasolabial fold, sometimes as described by Nabil before with this technique. In my opinion, it's very important to release the orbicularis of retaining ligaments. Sometimes we have a very lower leaching junction. Our goal is to reposition the leaching junction. The only way is to open the lower eyelid with a subsidial incision. With this technique, you can address the position by means of a lateral approach without opening the lower eyelid. So look, in this patient, you can recognize the different situation, the different anatomical landmarks, the orbital rim. Another important thing is to perform a cantopexy without opening the eyelids, only by means of retention in the ligaments by means of a lateral approach. Finally, again, is the orbicularis retaining ligaments. You can release the orbicularis retaining ligaments by means of a lateral approach. This is the zygomatic space. We have a little different point of view with Nabil about the zygomatic space because, yes, it's a submuscular dissection, but sometimes I leave some fat attached to the muscle because I want to create the correct thickness. So it's like a trans-zygomatic space. But you're right with your opinion. And my goal is to arrive at the zygomatic measure. During our face lifting, after, we can arrive to the zygomatic measure by means of a lateral approach. With this technique, we reach the muscle by means of super lateral approach. Because when we reach this muscle, we can release the zygomatic ligaments. And you know that it's osteocutaneous ligaments. When you release the ligament, you can move as you want the entire soft tissues in the mid-face area. Can you lower the volume? This is my new dissector I show you after. It's similar to Tripsa, but it's carved on the top with a light. It's very useful when you have to dissect this part, but I use also in the neck because it's carved on the top, so it's easier in my hands to reach the medial portion of the face in order to preserve the infraorbital pedicle. With light, it's amazing because you can check every time when you are dissecting the mid-face area. And this video shows the different steps in my techniques from the incision to the excess of the skin. So it's very important to make a zigzag incision. Is the skin dissection, is a limited skin dissection. Orbicularis muscle opening. I open the orbicularis muscle 1.5 lateral to the orbital rim, and you can appreciate the zygomatic major muscle here. So limited skin and extended deep dissection. The key of success is a similar thing in our extended deep plane. Limited skin, extended deep. And the deposition of the muscle is a very, very powerful tool in our hands in order to restore and to correct different problems in the entire mid-face area, not only the temporal area. Orbiculari portion and the mass portion. You can appreciate the different color. And then you manage the excess of the skin. But our goal is not to remove too much skin. Our goal is to support with the deep deposition. Finally, just sometimes a pinch of skin removal in the lower eyelid without opening the orbicularis muscle. This is my goal. Is the patient of the video? I showed the video. Just 2 years. Because another question is, how long does my result last? So it's very important. We have to obtain long-lasting results after 2 years, after 3 years. And the deposition of the orbicularis muscle, I think that is the key of success in our hands. Remove just the skin or the fat is not sufficient. 3 years after. So look at the restoring of the volume in the cheeks area without feeling, only by means of soft tissue repositioning. So what about the scar? The scar is another crucial aspect. The scar is our signature in our field, but there are no results without scar. Endoscopic approach. Endoscopic approach is my hands in this part of the face. It's in my hands. I repeat, it's not the correct way. Sometimes I remove 3-4 centimeters of the skin. So zigzag partner is the first thing. The second, and no skin tension when you close is my rule. Also when I close my face lifting, and the postoperative management. Sometimes I do CO2 laser just 2-3 weeks after, and I repeat 1 month, 2 months, 3 months. My goal is to obtain good scar, invisible scar when it's possible to do. And so the patient that I showed at the beginning, she came to me. She said, I performed by another blepharoplasty from another surgeon, but I have to repeat a blepharoplasty. The problem is not the excess of the skin. The problem is the hooding effect, the hooding deformity in the upper eyelid due to the sagging of the brow, the sagging of the temporal soft tissue. This is the result 3 years after opening the upper eyelid. Only by means of the positioning of the orbicularis muscle in the correct vector, along the correct vector. So look, the improvements also in the lower eyelid, in the leaching junction, in the volume in the mid-face, without feeling. Because the key of success sometimes in our hands is to lift and not feeling. Sometimes we can combine. But in a patient like this, the problem is to retention the orbicularis muscle at the end of our surgery. Similar patient. Sometimes I perform, my technique is a middle-aged patient like this. The results are very, very natural. I opened this patient during a live course several months ago, and this is the patient just after 3-4 months. So you can appreciate the results not only in the temporal area, but also in the malar area, in the leaching junction. So it's very natural, and for this reason, I appreciate this thing, I use this technique. Young patient, the problem is this patient, it's not like she came to me asking for a lower blepharoplasty. The problem is not the excess of the skin in the lower eyelid in this patient. The problem is the leaching junction, the hollow appearance in the lower eyelid, the sagging of the soft tissue, loss of volume in the mid-face and in the malar area, and probably the position of the tail of the brow. Yes, we can address, but the main problem is another area. So I propose a temporal moral technique so you can appreciate the situation intraoperatively. The fat in this case is a powerful tool. It's the only way in order to restore the volume. I prefer inject the fat after repositioning the soft tissue, and it's the same philosophy I used during my face lifting. And this is the patient 2 years after. I model also the nose and revision. And in this view, you can appreciate also the improvements of the dark circles here because the fat is very, very useful. So color of the skin and the volume and the position of the tail of the brow also we can obtain if we extend a little bit of the incision upper, also the position of the tail of the brow without go deep. Similar case. And so you can appreciate without injection Botox, but the improvements in this part, because with the partial denervation of the muscle, we can obtain this kind of results. Temporal molar cantopexy. Sometimes we have to combine orbiculari deposition with a cantopexy, because there are many anatomical situations that we have to manage because our patient asks to have a foci. It's a common request in our patient today. So my philosophy in this technique, I published this article about 10 years ago, is the Tassel sling is a very easy procedure, just one stitch. You can prevent and you can manage the lower eye displacement with a simple stitch, and by opening or not by opening the lower eyelid. I saw that guy use the same technique, and so in our meeting in Rome, it's very, very effective. And in my daily practice, it's a very common technique. If we want to obtain this kind of results, and we want to lift 3-4 millimeter the canthal tilt, we have to put this kind of suture. suture because the temporal deposition is not sufficient. Sometimes we have to do more aggressive cantopexy, like in this case, and it's a very, very useful technique. So without opening, you can pass from inside to outside with the tarsal plate, outside, inside in the same hole. I use a permanent. Do you use permanent, Guy, or absorbable suture? Yes. I use sometimes, in severe case, proline suture, and it's a very, very useful technique. So look at it. Imagine to see the preparative situation. Look at the sclera show. She had no surgery before. Look at the position of the lower eyelid, the lytic junction, the sagging of the malar tissue. So in this case, a simple blepharoplasty will be a disaster, 100%. In a patient like this, ectopion, 100%, without making some ancillary techniques. And this is the patient by temporal more with fat grafting and cantopexy with the technique I showed before. So very natural results. The same. When she came, she said, I need blepharoplasty. The problem is not only blepharoplasty. If you want to lift the lateral canthal position in a patient like this, you have to add some cantopexy. So it's very easy. Temporal more to restore the tension and to correct the volume associated with cantopexy to obtain this kind of results. Similar, sometimes young patients like this want to change the shape of the eyes. In my country, it's a very common request. And so we have to manage this request. First choice, okay, I don't perform cantopexy. This is the door, bye-bye. The second, we have to obtain satisfied patient. If you want to obtain satisfied patient, you have to obtain results, stable results all the time. And this is the only way to perform a cantopexy or cantoplasty, because sometimes we have to perform a cantoplasty. Another common problem in my country is the filler, the permanent filler, the absorbable filler, because we represent the last step. Okay, they try to solve some problems with medical doctors. They inject a huge amount of filler, a huge amount of fat, and they come to us, and we have to solve the problem. This is my practice. This is my daily practice. And so look at the silicone. In this case, I asked for MRI, and we remove the silicone in order to restore the tension on the soft tissue on the skin. I perform a temporal more with a cantopexy. So this is the patient 2 years after. So she had 15 laser treatments in order to try to solve the silicone, but sometimes laser is not the correct way. Temporal more cantoplasty is another fourth step. In revision, I don't trust the periosteum. In revision, I make 2 holes in the bone because I want to be sure that I have a stable reposition on the canthal area. And so she had a previous direct approach. You can see the scar, 2 holes in the lateral orbital rim, and we anchor directly the tarsal plate to the hole. So look at the situation in one side compared with the other one. At the end of surgery, then 4 days. This is the hospital. It's not natural, but our goal is to obtain stable results. So we have to explain to our patient that the results after 3-4 days is not natural. Okay, but this is the patient 2 years after. So when they want to obtain this effect, we can talk about is natural, is not natural. Okay, but she's our patient. She wants to obtain these results. So our goal is to have a satisfied patient. And look, it's very interesting to observe the position of the brow. In other words, she had many attempts with direct approach without obtaining the correct position. With a temporal more, without opening here, we can lift also the tail of the brow. So this technique is effective also to manage the sagging of the tail of the brow. Look, before and after. I put some fat here because fat is very powerful in order to improve the aspect of the scar. And look, the scar is almost invisible. And in another lateral view, another patient with the same situation, the cantoplasty. My last part of my presentation is a new article that I'm writing, so the application of the temporal more to treat the lower eyelid displacement. Look at the patient like this. Summarize the dramatic situation in our hands to correct this kind of patients. The lower eyelid displacement is a complex process. You know that we have to recognize 3 lamellae, anterior, middle, and posterior. Sometimes the problem is lack of the skin in the anterior, sometimes the problem is the scar in the middle, sometimes the problem is the scar in the posterior. So we have to recognize the problems, and we have to manage by combining several techniques. When the problem is the anterior lamella, we have to recreate the correct length, the correct space, the correct amount of the skin, and the first way is a skin grafting, but in my hands sometimes, and I've seen a lot of patients who have this kind of surgery, the results are not so good under an aesthetic point of view. The second option is a vertical mid-face lifting. I wrote this article with my friend Giovanni Botti several years ago, and we described this technique in 200 patients, because by means of a mid-face with a lower approach, we can shift the skin from the mid-face area for the malar area to the lower area, where we really need to have more skin. But sometimes it's a very, very effective technique, but it's more difficult to perform, and the edema and the healing sometimes is very long. So I changed a little my opinion, and today, when I can obtain the results by means of a temporal more, I prefer temporal more. I show you why. This is the patient several times to correct. I open with a temporal approach. I dissect my muscle. I release completely the tendon, not the canthal, the tendon deeper by means of this approach. Just 1 centimeter is no more. I have to reach the orbital rim, 2 holes, because in this case, I said to you that I prefer hole in the bone. Cantoplasty, no cantopexy, and then I fix the muscle. In this way, I can recruit some skin in the lower eyelid without putting a graft or without performing mid-face lifting. Fat is a powerful tool at the hand in order to improve the scar. Look at the situation after, but look at the situation just 2 weeks after surgery. Sometimes also a very, very fast healing process is another request of our patients, because they have to return their social life and they want to have a very fast recovery. So when you want to open the lower eyelid to destroy this part, and you can manage it by means of a lateral approach, it's a good way to obtain this kind of results. But we have to judge the results after 1 year, not after 2 months, 3 months, 5 months. So you can appreciate the stability, because we restore the tension, the position of the canthal by means of a cantoplasty. We restore the correct amount of the skin by means of a temporal more, and also we improve the scarring process with fat. So by combining this approach, we can obtain this kind of results. I think that I have a video, I don't know, chef, okay? And this video showed that changed completely her life, because we restored the correct shape and the correct position. And another patient, similar case, several attempts to solve the problems, cantoplasty, cantopexy, mid-face lifting, tarsal strip, sometimes techniques, and I changed completely my point of view, and I performed my temporal more technique associated with cantoplasty and fat grafting, and this is the results after. This video showed the situation 6 months after, and we changed the life of our patient when we can manage this kind of process, this kind of problems. So I think that we should consider this approach, and we write in this article. In this case, total muscle with a temporal more, she had several attempts in order to remove the silicone in the mid-face area and total muscle with the temporal mode. This patient is just 1 year after surgery. Another patient, dramatic situation. Sometimes in my country, some surgeons perform together different procedures. So rhinoplasty, blepharoplasty, face lifting, lip lifting, and so on. This is the situation. Total mass technique with temporal more and cantoplasty and fat grafting. And this is the result just 1 year after surgery. Can you observe also the pixie deformity? In this case, I perform again a deep approach. So this is the article. It could be interesting to make some discussion with Guy, with Nabil, the complication in the revision. First of all, the chemosis. The chemosis sometimes is very difficult to manage. And in this article, we reported a very, very low rate in the chemosis. And Plastic accepted this article. It's under review, and I hope that it will be published very soon. And also another discussion could be how to manage the chemosis in the first operative period, and how to prevent also the chemosis in our patients. And we are publishing another article about this, and we try to prevent. And in our opinion, but I would like to know the guy's opinion, there are many anatomical risk factors. So in patients with a lower laxity, with the sclera showed before, with a negative canthal teeth, negative orbital vector, the probability to have the chemosis it's higher. So we can manage different situations. And when you have chemosis, I think that one of the way to treat it is very easy. It's to do a tachography and to maintain for 4 or 5 days. And in 4 or 5 days, you solve the problem without having problems for 2 months, 3 months, because sometimes they last this time. So in conclusion, I think that the temporal mode is a very effective technique, more than the traditional techniques. And I use the temporal mode also to correct the lower area displacement. Thank you so much.
And we have about 15 minutes or so. We'll do a Q&A and then our quick break.
One of the things which is important, which Dr. Pascali said about the nerves regarding the lower eyelid surgery. If I'm cutting, which is the question of everyone, you're cutting the auricularis muscle, then all these nerves where they are. The trick is here in this picture, which I'm showing. So my incision cuts, it's 50 millimeters coming from here to here. I don't have any cut on the lateral side, 50 millimeters. I don't have any on the side, maintaining all my nerves active. So all the areas which is risky for nerves, I'm maintaining there, untouchable. So this is where I manage. But if you don't see this part, then you will see that, okay, because it's not explained. So part of the lower eyelid is also for cheek elevation. So if you do buttocks in the lower eyelid, you lose cheek elevation. So for that reason, the more could be reasonable if you want to, because if you paralyze the lower eyelid, you have cheek relapse. Point. This is toxin. We avoid injecting too low here or too much here because the patient feels like fake. He's like fake. So in the technique, I'm maintaining all the nerves intact because remember that the frontalis muscle is you elevate by the temporal nerve, the lateral part by the zygomatic, and the middle part by part of the zygomatic and the buccal. So that's why when you make this part, you move your nose, and also you use the elevator of the labia, so you can't control. In 2019, I discovered that the corrugator muscle is not a depressor, and the corrugator muscle is only an approximator, and it's at the same time an elevator, an add-on elevator because connected to the frontalis muscle. This has been published in 2001 by Dr. Nikakor Isi from LA, and no one took it into consideration. So I started investigation. So we started investigating all the muscles of toxin injection by electromyostimulation, and we found that polarizing too much your lower part, you need to suspend the cheek. You need to change something in the cheek as an add-on if it affects the nerves. So that's why my cut goes high, then goes 15 millimeters down, then goes high again, maintaining connections from all the sides.
So I want to report my experience in the lower eyelid. Lower eyelid, I think that is a challenging area in our field because sometimes it seems to be very easy to make an incision, to remove the skin, to remove the fat, to remove the staple muscle. Why I changed completely my philosophy? Because I had a lot of problems to manage. And you know that the patient with just half millimeter of the symmetry in the eyes complain about results. And they say, doctor, my father, my mother, my friends, they say that I have problems with my eyes. So for this reason, there are many techniques that we have to consider. First of all, like cantopexy, cantoplasty. I perform Adamson flap, modified Adamson flap in order to restore the tension of the muscle, in order to correct the leach in junction with the releasing of the tear trough and the orbicularis retaining comps for many years. Now, when I can, I prefer to manage the problem here by means of a larger approach. After the tension in the muscle, the excess of the skin, because sometimes we have an excess of the skin in the upper portion of the iris, I remove just by means of a pinch or a cutaneous flap. And when there is a laxity, also during my surgery, I reposition the muscle, I note that there is a laxity in the iris. I put just like cantopexy, as you show. It's very easy. So for this reason, I changed a little bit my focus. Because my goal in 100 patients is to have, if possible, 1, maximum 2 unsatisfied patients. This is my philosophy. Let me open for you something which is important we're discussing here. Don't copy us. Really don't copy us. It's risky to copy things. Copy him. He's wise, very wise, and he teaches wiseness. And because for sure, when he said that beware, it's risky, whatever. In fact, it's risky. Or you go for something more and you become good. If not, don't copy. Because I learned don't copy people early, maybe. And I was telling you that maybe because if you learn from people who are predicting a lot of things, then we didn't succeed from one day to another. Success comes from many errors we made. So copy him.
I think what he's trying to say is this. You're saying very, very sophisticated procedures. And I think if you're starting at that level, you're going to get yourself in crazy amounts of trouble. This took years and years and years for Michele to get here. I met Nabil 15 years ago in Los Angeles. This was not how he was thinking. But when you have experience and you do something, as Michele says, I wasn't happy with this. I was having an issue with this, et cetera, and you become a seasoned surgeon, you can take the next step. Let me tell you how different things are in Europe and in America. In America, if you violate the periorbital orbicularis muscle, you're considered a criminal. I'm not telling, they think you're psychotic. It's nuts. And there has been no advancement beyond that form of thinking. And why is that? Because they're just afraid of denervation. And if you really study the articles on anatomy, there is a window of safety. But the reality is you have to take that step. And when someone's been in practice for 10, 15 years and they're comfortable with their results, sometimes I use the term they're comfortable with their discomfort. And it's very hard to make changes as you get older. You're looking at two people that are trying to advance the field but took risks to do it. And when they got there, if others learn from this, they don't understand the risks that they took. But this just doesn't come from the beginning. I think you got to learn basics and really understand basics. And once you've done that, decide what steps you want to take. And learn anatomy. He just showed you a drawing. The drawing he showed you was all about knowledge of anatomy. The papers that Michele showed up there will describe the innervation of the auricularis very, very well. It's primarily innervated medially by the buccal and zygomatic branches. The innervation here may mean nothing. Who knows? So, but you can't go to these advanced techniques immediately. This is years of experience. You have to start at the basics. And this is about basics. Because if you go out there and start doing this thing immediately, it's going to ruin your confidence because you're going to have problems.
Thank you. Preventing incarceration or pincushioning when you are doing the brassiere suturing, which suture you typically
So the
use?
purpose of it, we were having a little discussion. The purpose of it is not to raise the brow, just to raise the brow fat pad. If you want to do it without having, do you mean the dimples that you're created by incarceration?
Copy.
Yeah. So what you do is you want to split the orbicularis down the middle. If the orbicularis is too close to the upper edge of the incision, you're going to create a dimple. And if it is, undermine the skin, and that'll help prevent that too.
And what type of suture do you typically use for that?
I use a 5-0-chromic. I want to get a little inflammation and scarring. I don't like putting permanent sutures. By the way, my whole thought, same thing with canthal suspension on permanent and not permanent sutures. The reason, I used to use permanent sutures, but I do a lot of redo surgery, and I find when I go in that I don't think it's the suture that's doing anything. Usually when I go in on a revision, a suture from 5 years ago is barely doing anything anyways. I think if you suspend the cheek appropriately, as they showed, the canthal suspension suture should be under very little tension. It's a support stitch. You get granulomas, you get infections. Same thing when you're doing brow lifting, your deep sutures in the deep plane from superficial to deep fascia. I used to use proline sutures. They would spit out, create all kinds of problems. I'm not a big fan of them. There's something, if it's not sticking after 4 months, I don't think it's the suture that's going to hold it up.
Is it a bro lift, bro fat lift, roof lift? Because I don't like bro lifts with the roof low. When I see a woman with a eyebrow, the hair, and the roof is low, I don't like the case. I see the woman, this is not natural for me. So when I see pictures doing people bro lift, I want bro fat lift too. And there's a discussion that it made me think, why I need to cut and lift the ORL upwards? And that's why I changed in the bro lift surgery. And I don't think the only way to lift the bro fat is or you go from down and you lift it, or you go from up and you scut and you lift it. But I can't see in people doing from up here a bro fat lift. I see only a bro hairline lift. And if you become critical, you see that. But how much you want to see criticalism? Is it the patient criticalism or your criticalism regarding a case? And that's, we're becoming crazy as surgeons. We're starting seeing things, as patients comes crazy, we're seeing too much craziness in every area. I think 30 years ago, you were not operating, patients were not that crazy. Maybe, I don't know, I was not there. I was a kid at that time.
Social media changed everything because people look at photographs are doctored. Let me just say one last thing. 95% of your patients that come in to see you when you're doing your general practice, if you use basic techniques that are consistent and reliable, you can make patients happy. The kind of patients that may see us may be a different patient population, and they may have different mindsets and different expectations. It's about identifying expectations, doing the simplest thing you can so your life is easy. Because patients can eat away at you, which shortens your life.
But sometimes the problem is if you, with the simpler techniques, can achieve the results which our patient want to obtain.
That's correct. So your decision is, do you want to do that case? That's like you said, goodbye, I can't do it, or I'm going to figure it out.
Yes, because I have a lot of patients, young patients sometimes, it's a very, very particular category. They come to me and they want too much. So the problem is to refuse to have surgery, to do surgeries. Because with the simple procedures, you can achieve the results.
Do you refuse, or do you
Sometimes.
How much? How much?
I want to thank our expert panel this morning for fantastic lectures and for giving each other respect for enough time to speak.
Okay, so thank you so much, QMP, Andrew, and thank you so much, Mike, for your invitation. It's really a pleasure to be here. This is a great meeting, a great Cadaver workshop, and I'm really looking forward to it. So I'm going to go ahead and present initially on lip today with my technique that I call the POW lift, the Philtrum Accentuating Upper Lip Lift. So what are the indications of performing a lip lift? So the first one that comes to mind, of course, is based on this paper from Val Lambers, which is an incredible paper showing what are the areas of the face that age the most. He did 100 patients and averaged the face of 25-year-old and 75-year-old individuals. And when comparing faces, he found out that the area that changes the most in the face with aging, because I believe the one that changes the most with aging overall is the neck, but in the face, it's definitely the upper lip. The upper lip lengthening. So this is very relevant to understand that this is an important feature where we can change that and immediately improve the appearance of aging of an individual. Of course, this was already confirmed with the great part 1 and part 2 studies from Patrick and Alexis from Belgium. But I wanted to bring up this other feature that is important in order to understand why we should perform lip lifts, and that is to improve attractiveness. Because there's a feature that very attractive individuals have, that is when they have opened their mouth, which is called in the kind of, if you look in the hashtag in social media, hashtag Fishgate, you'll see it's like a look of models. So it's like now a lot of girls are looking at, and they have all these look like, blue, whatever, or, and one of them is the half open mouth. And when you do that in an attractive individual, you have to see a good amount of the dentals, or a good dental show of the incisors. Okay, so lip attractiveness. I did this in order to confirm this. When you have a theory about beauty or of attractiveness, you can't sort of in a scientific field like ours, you can't sort of say, I like this more than that. No, that doesn't work. Okay, because we're scientists, and we cannot have everyone come and say here and say, what, I like big humps in the nose, and I love them. So no, there's attractiveness and beauty is science. It's study. It's not something you can say. Oh no, it's like colors. Everyone has their choice. No, this is study, and this is studied through perception studies. Okay, perception studies are very important. You need to show to a population different individuals and ask them or her which one looks more attractive. Okay. So in this case, I showed this to different individuals. I did not tell them, anything. Just tell me which one out of an instant, which one looks more attractive. And I did this with a lot of individuals, and just tried to ask them which one looks more attractive with digital imaging software. And of course, the results of this study was, overwhelming. Practically, more than 95%, considered that, the shorter lip more attractive. There's another interesting feature that I want to, bring you or point out to you, which is when you see these incredible pictures and photographs of these models, you will notice that the artist that was doing this, the photographer, wanted to really showcase something here with these lights and shadows. And it's this feature here. Okay, this is also incredibly attractive, and that's a Philtrum, right? So I did a Philtrum effectiveness study, which is more complex because a lot of individuals, when you show side-by-side pictures of this, they really don't notice any difference, and they'll say, but they're the same. I don't care. Just tell me which one looks more attractive. And when you have individuals with a Philtrum, it's not as overwhelming with a shorter lip, but it's definitely statistically significant. So definitely that's a very important feature. Now, talking back about indications, another feature that will help you and help your patients understand why it's important to do a lip lift is a little structure. I don't know if you noticed there. You have to really look carefully around here. You notice that thing there. And that is a very interesting wrinkle, and I called it the LUL horizontal wrinkle line, or the long upper lip horizontal wrinkle line. It's a sign of a long upper lip, okay? And a lot of individuals will have this, and you can show it to them, because that's where the lip wants to really end up when a patient smiles, right? So if they end up smiling like everyone does, they'll end up having a wrinkle there. So again, a lot of these individuals, you can just show them, oh, you have a long upper lip horizontal wrinkle line. So it's not a pathognomonic sign that you need a lip lift, but it's definitely something that will help them understand why it's important to get a lip lift in these individuals, okay? And just to point out, because there's some orthodontic studies that have described a crease, a horizontal crease in the upper lip, and of course orthodontics is mainly done in teenagers, and it's not a wrinkle line, it's a crease that can be formed in some individuals that have a very short lip, like very young patients, that are very, very plumpy on the lip. And when they smile, they will form a crease there when they smile, which is different than my description. So you can have that sort of crease with a long upper lip, or what I call the clown shoe upper lip, and very thick upper lip with very short upper lip in very young patients. But definitely, you can see there that long upper lip horizontal wrinkle line, and of course, when they smile, they avoid that when you have a shorter lip. So the lip lift classification, I proposed and I presented some time ago. When do you do a lip lift? There's 4 types of individuals that can benefit from upper lip lifts. First of all, of course, facial rejuvenation patients. We just mentioned it. You know, these individuals that are coming for a facelift, facial rejuvenation, sometimes they didn't think about their lip, and you show them how they can benefit them, and you also perform a lip lift on them. Young patients with high beauty awareness. This is really going up. You know, some years ago, we didn't perform that many lip lifts. In fact, this was a patient that I did, nearly 20 years ago, and she was a very, high profile computer, engineering and internet sought-out female that was working between Miami and Madrid, and she came asking for a lip lift, and I'm like, how the hell do you know about this? You know, it was well before all the social media. Now every 22-year-old will come in and ask for a lip lift because they see it in social media. Okay. The other group that is very relevant are the post-rhinoplasty patients. This is very interesting because this is a very large group of individuals. So if you do a lot of rhinoplasty in your practice, you're definitely going to have to see patients and consider lip lifting, because there's a study by Derek Steinbrecher that showed that there's lengthening of the upper lip. He did it with a 3D analysis after rotation of the tip and elevation of the tip. So definitely that's something. And of course, these individuals are very kind of central face aware, and they will always be looking at their nose, and they will be aware of their long upper lip afterwards. And finally, the post-lip filler patients, which of course are a very also important group of individuals. I'm going to point out a little bit about pattern of incision versus incision line, because a lot of people are very focused on what's your pattern of incision. Is it a bullhorn? Is it a Poirot incision, like Patrick and Alexis like to say? Pattern. I'm not more about patterns. I'm about really where to have incision. So I propose this nasal seal classification between a single nasal crease, single crease nasal seal, and a double crease nasal seal. So these are individuals that can either have just one little crease below their nose, in the base of the nose, or 2 creases. Okay, and that basically changes your approach on where you should have your incision. So the nasolabial mucocutaneous junction is up there, so you can either do a low incision or a high incision lip lift. Okay, and in order to hide it in the crease. I'm going to talk a little bit about this later if we have some time. So my technique is a philtrum accentuating upper lip lift again. Basically, I remove the skin, and then I undermine over the muscle and remove a little bit of the orbicularis oris muscle where I want to recreate that philtrum. And then I place a weaving suture up and down like a hemostatic net with monocryl in order to create that philtrum. Okay, and I leave that for 3-5 days. It's a 6-0, and that way you can create that philtrum. Notice that nice philtrum over here that you've created in patients that oftentimes, even if they've had fillers, they just don't have any philtrum, which makes them look very awkward. And another word about fillers: I will not put volume in the upper lip unless the patient allows me to do a lip lift. I think that's the most terrible things you can do for attractiveness and youthfulness of your patients if you put volume in the upper lip and then you cover the dental show and makes their lip look longer. So unless they have a very short upper lip where we can put volume in the upper lip, I will not put volume on the upper lip unless they let me do a lip lift on them. So again, patients that have had fillers, notice also some of these patients that have had fillers in the lower lip where I've also had to reduce that from the on the lower lip as well. And the patient also around here, you see that sort of sausage deformity there on the lower lip that I was also able to correct. She practically couldn't smile with all of that sort of permanent filler that she had there, and that's the effect of the upper lip. Another concept I want to bring into you is the averting or a non-averting lip lift. So when you look closely on your lip lifts and you try to understand what's going on, what happens is that there's 2 ways of performing a lip lift. One of them is just a skin-only lip lift, and then you're going to have lip eversion, of course. But the other way of doing it is en bloc elevation, where you're removing muscle and skin, and that way the whole lip shifts upwards, and that's a non-averting lip lift. Okay, so you can see here, this is the skin-only. You get vermilion eversion, but if you would do it in the muscle and just elevate with the muscle and reduce the muscle, you will get a full thickness en bloc kind of elevation. Again, so that's why when I'm doing lip lifts, I will remove a little bit of orbicularis oris muscle cranially in order to be able to elevate the whole lip en bloc. Okay, and removing that bit of muscle. And again, I will use a 4-0 PDS suture to elevate the whole muscle en bloc that way. And why manage the muscle? Lip lifting, it allows again aesthetic contouring of the philtrum, like we mentioned. It avoids a natural-looking vermilion eversion, and improves the scar also because it supports the wound closure. It's sort of like this mass, and it avoids muscle bulging underneath the wound. It's sort of imagine doing an abdominoplasty and just removing skin and leaving all of the fat there. That scar is going to be under tension from all of that volume. So again, if you just remove skin, when you elevate that, all that muscle is going to bulge and it's going to make your scar be worse. Okay, and I really want to point out a little bit because the orbicularis oris muscle and it's a sphincter muscle, just like the talk we heard before about the orbicularis oculi muscle. So these muscles really, when you remove a little bit of them or partially denervate it, it's really hard to, if you really start well, to get rid of that sphincter function. So for example, this is a good friend of mine, Silvio Poda, that's a great cleft lip surgeon. We all know that you can restore function in the lip, in a cleft lip, and nothing happens. Or this is a patient of mine with oncological resection where I did a carapancic reconstruction, and of course you know that when you put that muscle back together, you can have perfect function of your orbicularis oris muscle. And I mentioned this because the first time I presented this technique in the US, again, a guy was mentioning before, Guy Musri, about some of the nuances about our colleagues in the US. I presented this in New Orleans in 2019, and the audience sort of almost, like Guy was saying, call me a criminal. I don't know what's happening when you go into aesthetic surgery. It's sort of like you can only touch skin and fat. If you touch muscle or a gland, it's sort of like, oh my God, you're crazy. And of course we do muscle resections for reconstructive surgery, and there's no harm in removing a little muscle. Again, I got incredibly criticized and killed in the US for mentioning removing a little muscle until recently I think it was in in Vancouver, Timothy Martin, mentioned that he also removed a little muscle, and then, of course, I was granted forgiveness. So again, I think it's not a problem if you know how much muscle to remove and just a little bit of touching a little bit of the muscle. And again, I did a lot of studies with movement and video, and of course, there's no issues with muscle movement if you just reduce a little bit of that muscle to get the philtrum and a little bit of the cranial orbicularis oris muscle. And again, you can also use that little muscle flaps, for example, for previous rhinopathy patients to sort of improve the columella retraction or some issues around the columella as well. Okay, with that lip lift procedure. So complications. First complication is a visible scar. You cannot consider doing the procedure if you're going to have a visible scar. And this is a patient that came to me from Barcelona, supposedly by a surgeon that was doing the most in Spain. I don't know. I think that she told me he was an oral surgeon, but supposedly he does a lot of these. But this is a big problem. You cannot have this issue with your scar closure. So in order to avoid that, what I do is I first fix my ala to the piriform ligament with a 4-0 PDS suture, so I don't have splaying of the nasal ala. And then I do a very a lot of closure with a lot of sutures with again 4-0, 5-0, and even 6-0 PDS sutures to avoid any tension at all on my scar. And then once I have that done, I will finish off with very little tailoring and adjusting, because again that skin on the lower lip is much thicker than the one on the mucocutaneous junction. So you need to bevel that incision. Be very careful. I do this with under loop magnification, so I get a perfect affrontation of my wound edges. And then this is the final part, which is also very important. I close with a 7-0 proline on a non-cutting blunt needle, and this is very important to be a non-cutting blunt needle because cutting needles like a nylon will produce cheese wiring. This is a very thick, oily skin, and that will cheese wire your skin, and you're going to get stitch marks. Okay, and again, these are some of the results. Now notice here, this is a single crease nasal sill of a previous rhinoplasty, and I don't like this scar at the end. So I did a conversion. You see, this is I don't like the scar going on the single crease nasal sill. So I'm now converting all of my incisions from a low to high incision conversion. Okay, and I know this is tricky because it can look artificial if you put thicker skin up in sort of that mucocutaneous junction. But I think it's worthwhile to always convert your low incisions into high incisions, even in single crease nasal sill patients, because you're going to have a better hiding of that scar, much better. Again, this is a patient that had a single nasal base, and I converted to a double crease nasal sill. And again, you see, I think you can hide it much better, the scar up there, and it's not visible. Another example is you can actually have single crease nasal sills and keep them that way by doing a deepilation of the skin. So this is another patient that had a previous lip lift with a low incision because he had a single crease nasal sill, and again, that scar is going to be visible all the time. So I want to convert that into a double crease nasal sill and keep the scar nice and high to hide it much better than having it that low. Okay, and the other option is to not convert patients that don't want to change their single crease nasal sill and want to maintain their nasal sill the same way. You can actually deepithelize the nasal sill and just thin out that skin of your upper lip lift, and then be able to bring it up without changing that configuration, but at the same time being able to keep that scar nice and high in the mucocutaneous junction and avoiding a visible scar. Another complication, which is very prevalent, is the inverted V deformity, also called the beaver deformity by some colleagues in the US, where there's too much central elevation and not enough lateral elevation. And the best way to avoid that is to do either less elevation in patients that have very narrow base of the nose with very wide mouths, because you're going to be able to only elevate the central part of the lip, and it's going to look awkward if you elevate too much. So you tell the patient that they have this issue, you're not going to be able to elevate too much, and they might have to go to a dentist to get more dental show. But the other option is to elevate as much as you want, but then also associate it with a corner lip lift in order to avoid that sort of central elevation excessively. So I do perform quite a lot of corner lip lifts. This is the patient initially before doing the corner lip lift because she didn't want to do corner lip initially, and after I told her it's better to avoid that sort of inverted V deformity to do it. The other option is to do the gliding lip lift that Jerry O'Daniel, my good friend Jerry, does, which is sort of undermining this patient that had a little asymmetry. You can see here that asymmetry there with that right vermilion, which is less averted than the one on the left. And in those cases, you can do that sort of wide undermining, and do a progressive tension hemostatic net to really overdo it on the right side, and you can get a better result. But I think that overall, in my hands, I'm more comfortable doing a direct commissuroplasty or a corner lip lift. And you can do it staged. You can tell the patient, okay, some patients are afraid of that. Let's do it this time, and if you don't like it, we can just do the commissure again, like in this patient. And then when you do it, I really think that it's going to bevel the incision on both directions. So I bevel it on one side, I will bevel it on the other side, and then again, I will do quite a number of 1-5-0 and 6-0 PDS sutures all around, and then close with a 7-0 proline again. And again, if this is after doing that corner lip lift, that again, you can do it very well without having a problem with the scar. And then finally, over resection. This can be a problem. Another patient that came to me from the Netherlands with an over, she could not close her mouth. These are very difficult problems to solve. I have to do like a VY advancement flaps from the mucosa underneath orally in order to get some result for her to close the mouth. And then the final kind of patients is the long upper lip with adequate dental show, but that have a gummy smile. Would you do a lip lift on these patients or not? And this is a big question that a lot of colleagues have and have asked me. So this patient like this, she has a long upper lip, but she has good dental show. It's not always about dental show, but it's about the proportions of your lip and your face. And she did have a little bit of a gummy smile when she smiled, so we were very concerned about doing a lip lift on her. But at the end, this is the before and after, and you can see here, there's no problem, with excessive dental show with just in her half open mouth, and she did not have more gummy smile when she smiled. And I've done this in several patients where, in the pre-op, she does have a gummy smile, and interestingly enough, that lip lift improves her gummy smile post-operatively. So again, patients like this that have good dental show when they smile, they're not going to have any problems when they smile with a lip lift afterwards, and you can get a better dental show on the static position when doing a lip lift. So this is again my preferred technique, a lip lift associated with a corner lip lift in order to improve upper dental show, combined with a facelift like this patient with that lip lift there. That's my preferred technique when you have problems in the commissure like this, and in order to combine those procedures. And then finally, my last part here is the wet dry border lip reduction, because one of the problems with corner lip lift, when you get an aversion of that vermilion that all the incisions that are placed near the vermilion produce, some of these patients that have had fillers will have, one of the techniques for fillers in the upper lip is to put a lot of volume right at the wet dry border to kind of avert the upper lip. And when you do a corner lip lift on those patients, then they have a very artificial, that sort of volume pops up, and you need to sort of reduce that wet dry border and to have more lateral dental show, like in these patients here with that lateral dental show that I would not achieve without doing a wet dry border resection from the inner part of the mouth. And on a patient like this with a lot of course, fillers previously, where you need sort of that improvement there laterally. Okay, so finally, I just think that some of the concepts that I've been able to review with you today, hope that they've been useful for your next lip lift when you're planning one. Thank you so much for your attention. Thank you very much.
Who here performs forward reduction? Nobody? Oh, welcome. So it's easy. If you know the anatomy, it's very easy. I started my frontoplast 25 years ago. My first class was endoscopy, and I had no iPad that time. I draw in a paper, the anatomy. The anatomy is your friend. If you know anatomy, you are free. You can fly. Now pay attention, pay attention. Open your eyes, wake up, wake up. This is the innominata fascia and superficial fascia, okay? And under me, on my floor, I have the deep temporal fascia. The nerve is here. Don't touch here. Okay? You are my friend. You want to know this. Don't touch here. So I never cut this fascia. Superficial fascia and innominata fascia. The nerve is under the superficial in between the innominata fascia. So you want to surf, as Michele surf on the snow. My friend do ski too. So you want to go to ski in the superficial of the deep fascia. You need to see the deep fascia crystal clear. If you are here, you have no problem. Okay? So let's go. The anatomy. You became old, as our guide master told us, the age. So the age is a process constitutional. You have familiar genetic in androgenic loss and other problems. You wanted to know about the anatomy of the frontoplast, the forehead, the woman's and the man's is different, the position of the brow. It's very important to know what you wanted to do, the size that you put. Look me. I'm indicate? No. I did a hair implant. So I became beautiful. And now, this woman, she wanted a hair implant? No, forehead reduction. This woman, they want a forehead reduction. So, scar is a problem. No tension. If you have no tension, good scar. If you have tension, bad scar. Because of this, the plane works very well. Thank you so much. So you can see the result, and you can see the result. Quaternary rhinoplasty and forehead reduction and mid-cheek. Forehead, full face, total face, chin augmentation, forehead reduction, face lifted plane, neck lifted plane, morphos, and none of that. Our paper, it's coming. So anatomy is very important. As Guy told us, Nabil told us, you are expert right now with this anatomy, please. Different types of frontal muscle. You want to know because you work different. The fat, the superficial fat is only one part. Under this fat, you have other fats. They are totally different. You want to know this anatomy. So after this, you will work in different places. We have the first part, second, and the last part of the frontal. And this is a very important ligament to work the forehead reduction. If you don't remove this ligament, you have no successful. So pay attention in this ligament. I wanted to release this ligament for the forehead reduction. The anatomy of the vein is different. Surgical technique. So this patient is a total facelift. I perform directly lip lift, upper lower blepharoplasty, forehead reduction, face lifted plane, neck lifted plane, morphos, and none of that. Incision. As Pascal told you, you wanted to do wave incision. Wave incision to avoid the scars. I draw the performance of the brow as the patient's wanna. Something that I love to do, I go in the mirror with the patient, and the patient look in the mirror, doctor, I prefer my brow like this or like this. Not you, the patient show you what he likes. And the woman know better than us men. So I go to the mirror and I decide the vector with the patients. Dissection. As I told you, I do the dissection under the periosteum. I prefer. It's much easier. It's much easier to release that ligament that I told you that is very important. Okay? It's a true ligament until the bone. And after this, pay attention with the nerve that I told you. Remember, on my hoof is the superficial and the innominata fascia. The nerve is here. On my floor, I have the deep fascia. I'm free. I can walk free because the nerve is there. So I'm not afraid about the nerve if you are in the correct place. Yes? So now, let's go again. Here is under the periosteum, surfing in the deep fascia, crystal clear fascia. It's very important. You want to release the temporal line. So I release the connection between the deep temporal fascia and periosteum, the both sides. As I told you in the first video, the close, that patient was only the frontoplast, not for forehead reduction. The same, the difference is I open the skin and I pull the skin. So look, crystal clear. I surf, if I'm surfing here, I'm totally safe. So, very important. To open the periosteum, you want to do the incision like this. Never cut like this. If you cut like this, horizontal, you can hurt the nerve or the vein. You can have problems. So I show you, look, pay attention on my movement. Like this. You never hurt the nerve or arteria if you do this movement. Okay? Crystal clear? Easy, easy, very easy. If you know the anatomy, it's easy. Look, I will found the nerve here. You see the nerve. I'm removing this ligament. It's very strong. If you don't remove this ligament, you can't pull the tail of the brow. So look the nerve. I'm totally safe. So that's the problem. Again, the movement, as I show you, it's easy. Okay? Now, a full open. I release the temporal ligaments until the edge of the orbital and until the occipital ligaments. So I'm free. I can move 5 centimeters. You know the size of the bone, so you are not afraid to do the holes. I decide the vector, as I told you, with the patients. I decide the vector, and now I prefer piezo, because I have piezo. I'm a rhinoplasty man, so it's easy for me. So I decide where I put the hole, and I suture. Nowadays, I'm using Etibond 2.0, okay? In the past, I used nylon. So look, I have the vector that I decide with the patients in my ulcer, and I draw exactly the vector. And now I did, in this case, 3 rows because of my vectors. Sometimes 2 rows. Sometimes the suture is in the deep temporal fascia. It depends the vector. Where is the vector is going on, okay? So now, look, it's possible to move and to release the extra skin that I decide the size of the frontal. Very, very important. Pay attention, wake up, pay attention. This is the important thing. If you know this, you are able to do the forward reduction. You wanted to do incisions, periosteum, gallia, until the fat. Avoid to hurt the hair, the follicles. So you wanted to do 3 or 4 lines here, so it's possible to move more the scalp. Remember that I release the ligament, I release the temporal ligament, you see in the cadaver lab, it's easy, easy. And then I'm doing incisions, like 1, 2, 3, sometimes 4. Depend the size of the skin that you wanted to release, to remove. So after this, I can move more and more and stretch the incisions. So it's very important, this step, to have successful in this technique. And sometimes, look, I can open more the incision. Look, the lines, in this case, 3 lines, sometimes 4 lines. So I have flaps. Pay attention, another thing that's very important. The suture want to be between the incisions to pull the scalp. Pay attention again. Put the drain first, and then you do the sutures. If you do the sutures first, it's impossible to put the drain, okay? So here, normally I use 1 or 2 drains. 1 drain for the forehead back, occipital, and others for the frontal part. If it's necessary, I can put. And I try to use the drain until the last incision of the occipital. The drain is mandatory. You want to use the drain. And now, I'm showing you. Now look, attention. The suture of the flap between the incision. If you go close the incision, it can rump. Yes? So pay attention to do the suture in the middle of the flaps, the incisions. And now, I'm pulling the occipital part. After this, look, I can cut the extra skin, and I have no tension on the scar because my occipital part of the scalp can come easy, without tension. If you want to help of your assistant to contact the incision, something is wrong. Back and do another flap. So my assistant holding for the occipital scalp, I suture it. Here you can see that I wasn't using nylon. It's not a problem, you can steal the nylon, only because I prefer the edge bond, it's easier to work. It's not hard. I try to use 2 sutures to be safe. Not only 1 suture, 2 sutures, the same place. And remember that I put the drain. The drain is here, then I do the suture, okay? It's very important. Brow lift. We decide with the patients the shape of the brow. Some patients has a sadness, brow, a target, angry, happiness. So we decide that according with the form of the face, we have different face here, different shape. If you see your partner, they have different shape of the brow. So decide with your patient in mirror. It's very important. And now, I pull the brow. Sometimes I don't want to move the brow. The patients became, doctor, my brow shape, it's amazing. Don't touch this. I do only the forward reduction. Okay? It's possible. Here. Remember, I fixed the occipital part, and now, if the patient wanted to change the shape of the brow, I do this suture, and I pull the central part of the brow, the middle part, the tail part of the brow, and I'm using, in this case, nylon, but nowadays I'm using the edge bond. And something that's very, very, very important. The same vectors, look, this vector, I did a suture close from the edge of the orbital, and with the same suture, I do another suture, another vector close from the incision. So look this, 1 and 2. This is very important to avoid tension on the scar, on the incision. Okay? So 1 and 2 sutures in the same vector, same direction of vectors. Easy? Easy. Tomorrow, you are available to do this technique. If you know the anatomy. If you know the anatomy, easy. You see in the cadaver lab that it's so easy to perform this technique. And I try to be exactly as I draw with the patients in the officer, in front of the mirror. It's very important. And this part right now, closer. In the past, I used nylon, simple suture. Now, I'm using observal suture, yes, subdermal suture, so it's not necessary to remove the suture, and the patient look in the mirror, and she is happy in the post-op, immediately the post-op. So we can see, I have no tensions. I did first 1 step of intradermal, and look, no tensions in the suture. And in the past, my problem was the scar. Now, I'm 100% happy with the quality of the scar. Take home. Hope in the bond is very important. Tension-free. Depend of each patient, 3 or 4 slices. Periosteum gallus elasticity. Open the periosteum, open the galleon until the fat under the hair. And you can associate the brown leaf or mid-tick. Results. Look the size of this frontal. I remove here 6 centimeters. 6. It's possible with this way, this technique. Look this result. 3 months, post-op. Base view, rhinoplasty, and forward reduction. This is 2 years post-op, rhinoplasty, face display, neck display, chin augmentation, infrared reduction, front view, three-quarter view, three-quarter view, quaternary rhinoplasty, forward reduction, and mid-cheek. So thank you so much.
So thank you, Mike, for the invitation. Thank you, all QMP leaders who invite us also. So today I'll be talking about direct lip lift. In fact, I like to criticize myself, see my results, see them, where I can improve. If I can improve, go change the system. So I started doing indirect lip lifts a lot. But what happens with indirect lip lift, which I didn't like, that the corners are not lifted. And if you lift the central part from indirect, and you do corner lip lifts, go check every case you do. You will see some people have a D flat, because the lip is not rotating upwards. The volume of the lip doesn't approach. So this is criticism. Then you start seeing yourself that you want to criticize some areas that, oh, people are happy, but how much can I improve my happiness? So at that day, I decided to create a direct lip lift. But what happens with direct lip lift? The scar is bad. Oh, I need to study how can I reduce my scar to be invisible. Oh, not visible, little visible, or barely visible. Okay, let me think about. So as we know, you need to have around 15 millimeter in the center. You can reach up to 1 centimeter if you want, but technically 12 to 10 centimeter is the, like it's a window, and then 16 and 19 millimeters in the other sides. So why I need to do indirect lip lift if I cannot correct all the lip? Okay, I can do indirect lip lift only in one case, patients who have big lips. Patients who doesn't have big lips, I will not do indirect lip lift. I was only doing indirect, and now 80% is direct, 20% is indirect, because the majority of the patients who come with lip lifts, they need also correction of the lip. So what happens? And also what happens if the patient have small base, did rhinoplasty? Then you need to offer him indirect lip lift and corner lip lift, then the corners rotate giving volume, and the center gets a bit deflated. And then I want you, everyone who does this technique, go to your before and after cases, go see the central part, how it does resonate that volumization effect. So I start reading everything regarding indirect and direct lip lift. And in the literature, there is 21 techniques for indirect lip lift. And there's only 2 techniques for direct lip lift. One is my technique, and one is the published technique, no others. So, and in the 170 articles published, the 21 techniques, one is my technique and 20 is the others. So I started with indirect because it's easier to hold safe for the scar. So the issue with indirect lip lift, after 1 year, 2 years, I didn't see any change in the lip size. Any change, very little change in the lip size. Then I could not see that what I was searching for. And also you can create A-shaped deformity if you don't treat the corners. So this is patients at 30, but this is patients at 30 and this is patients 12 months. I resected 9 millimeters. What happened is that the first month is some doctors show the result at 4, 5, 3. Patient with makeup, you can't see the redness of the scar, and maybe you appear that the lip is big. But after 1 year, go put your picture. The majority of my patient doesn't have this lip. I was expecting at the picture of 3 months or 5 months or 6 months. And this is a 9 millimeter resection. So finding that I cannot make a big change in the lip will improve, but little. Doesn't that amount of happiness for me? But the problem of any scar on the lip would be the scar. So I start seeing a lot of patients coming that did direct lip lift with bad scarring or banding. So how do I solve the banding and how do I solve the visible scar? So I start seeing that people, when they smile, they have this indentation line. Remember, this is, I was telling Dr. Gomez-Bravo about this, I call it the declaration line. I published in my articles. It's not my idea, but it was published before, but written in my article. Declaration declares you, hey, I need lip lift. But here, there's a declaration line to tell you, hey, I'll make a band, beware. So well, if this is the daughter, there's the mother doesn't have. This patient will have an invisible scar, invisible and invisible. This little, but with an instance in recovery of banding that at 1 year she will not have it. So I started understanding where I need to position. Here you should take a lot, because if you take little, 3 millimeters, the result is nothing. You will have the same, after 1 year you see your corner lip lift, little improvement. And people are afraid to take that because, but they don't know that appears too big, but then after you, much goes down. So you need to open yourself. You don't need to close yourself. The second thing, you have to know that you need to finish in the external part of the lower lip lift. Because go home, open your mouth, wives, if you're a girl, open your husband, wives. And you will see that the upper lip finishes in the external part of your lower lip. And the lower lip, when you do indirect, you finish inside. And you see there's a band of the upper lip finishing in the lower lip. And I'll show you. See this patient when she opens. You see? She finishes in the lower lip. You'll see it in person, this band. Third, I draw the patient on my couch. But after drawing, I go to the computer. And I draw it on the computer. And then, after drawing the computer, I see the asymmetries that you're not able to see with your own eyes. Plus, I put where is maxilla is positive or negative. We have a maxilla is more higher and one more lower. In the higher maxilla, you need to go normal. But in the lower maxilla, you need to overcorrect, because if you don't overcorrect, after inflammation goes higher maxilla, it appears that the lip is rotated more. So you start creating precise correction. You become crazy when doing this. And then, first is, and I call it sashimi cut, because you have to be like the Japanese, cutting the fish with a knife very thin. So I'm entering exactly here to touch the muscle. If I go deep, I will cut the muscle, and then the scar is worse. Second, the same in the upper part, I need to go deeper, transecting all the subcutaneous tissue. You see? Transecting all the subcutaneous tissue, you need to reach the muscle. After you do this, you can remember that my upper lip finishes in the lower lip to maintain a natural transition. After I do this, I elevate the skin and the subcutaneous tissue. And it seems easy to elevate the skin and subcutaneous, but this is what part of the success of the technique. And the sashimi comes from here. You need to release all the skin and all the subcutaneous tissue, leaving 0% of any subcutaneous fat over the muscle. This is correct and this is incorrect. If you leave any small bumble over the muscle, you cannot do the accordion contraction of the muscle. The muscle needs to accordion, like gets inside so you can rotate. If there's a subcutaneous tissue there, in its rotational accordion, bumps, creates bad scar. So that small detail, I will show you here. This is here, there's some subcutaneous fat. All you need to release all this. And I'm showing you so you can understand this will create here a bad scar. Release, clean, like a sashimi chef. All the muscle, 0 fat, clean. So after you do this, you put 3 sutures. 1 here, 1 here, and 1 here. After you do 3 sutures now, suturing. I always suture subcutaneous sutures, and then I put simple sutures in all my surgeries. I remove simple sutures at 2-3 days. not simple sutures after good treat. And I maintain all my suspensions, always suspend and then always intradermal. So if I remove earlier my simple sutures, oh, why so you're putting simple sutures to apposition well? I want really good apposition of the skin. So in the healing process, skin is to skin appositioned. So part of the success of suturing technique is three things: good suspensions to reduce tension, good suturing intradermal, good external apposition. Remove apposition fast, maintain intradermal, maintain suspension. So you become crazy suturing. I lose more time in suturing. Alessandro knows me. He told me you're a very not fast surgeon. In suturing, I lose my time. Sometimes it takes me facelifts 2.5 hours, and suturing 3 hours. So I'm putting attention in every point because the patients will always sometimes he will sue you if you had not a good result but a bad scar. Having a bad scar is a negative position for suing. So protect yourself. So I'll be doing intradermal suturing from here, goes inside, up here, inside intradermal goes from here, and then intradermal from here goes outside, and then intradermal from here goes outside, and then I have 3 connecting. I'll be flipping this to close it, this with this I close, this with this I close, this with this I close, and this is with itself. So when I suture, you need to take here the muscle, but you go from up to down. But when you take the suturing from up, you go horizontal. You enter only in the subcutaneous. I'm not taking subcutaneous and muscle. So from the lower part, I'm taking the muscle. From the upper part, I'm going horizontal. I'm like, as this, the suture is coming only in the subcutaneous layer. So this goes from up to down, and in the upper part goes horizontal. I will show you how it goes horizontal in the upper part. So it's very important to see that that's the way you're doing it. After I do this, now the closure I have. So after the closure you have, then you put simple sutures for appositioning. Okay, 6-0 nylon. Okay. After you do this, then you'll have like this, the 3, why I'm putting them here, not here, to avoid here anything of entering the sutures will heal very perfect. I'm removing sutures, simple sutures at 2-3 days, and I'm removing the intradermals at 7 days. No more suture after 7 days. Oh, it will not open? Never open in my life. I do a lot. I was afraid first, maybe I left 9, then 7 days you can remove them perfectly. So after you do this is at 3 days, I'm taking the simple sutures, and this is 7 days post-surgery. Videos to show you, 7 days post-surgery. So I'll be removing this one, okay, I'm showing you so you can understand how we remove them, okay? And I'll be removing from here, and I will take them out from here. Okay, so I'll be showing you so you can technically, after cutting from here and you start pushing upwards. You see this scar here is pretty excellent heal. It can't open. It's like fast healer, very fast, more fast than any other places. Okay, whenever I take sutures from here at 7 days, 8 days, 10 days, it's not pretty healed as much fast as this place. It's true. So again, after doing this, you can also do corners, and this is wrong corner lip lift. What will happen with this corner lip lift? The result is the same after a year. So I'm putting it to understand to do corner lip lift, you have to open yourself more. Because not opening yourself, the result after 1 year is the same. So it appears very nice post-surgery, but then the result is not nice, it's not top. Again, upper and lower lip lift, sometimes I manage. So remember that the lower lip lift, you should finish not here. So I'm putting you to understand that this was how I was doing it. And now I'm pushing because I'm doing this goes outside and this goes inside. And then you have the incision done, and I'll be showing you later the results of this patient. Simple sutures will be removed at 2 days. So this is 7 days, the suturing healing. I'm showing you, and at 6 months, same patient. So you can see, sorry, let me go back. And this is at 7 days suturing, and this is at 6 months. I mean, pretty barely visible, the incisions. Pretty barely visible. You want to maximize more the alignment, the color, you can make small fine tattoo and all the contour of the lip mixed, wow, another level. And this is another case of patient. At 7 days, at 1 month, at 3 months, at 1 year, barely visible. Barely visible. You can rotate all the lip. I sit with the patient and design the lip. You want more circular in the lateral part, you want straight. Some people like straight, some people rotation. Some people like more V, some people less V, some people extensive V. I design with him. I like to have a powerful V in the middle. I like, but not everyone likes. Some people like less V. I like a bit rotation, but some people like straight. So I design with them the idea, and I show them my idea and my plan. So you will see patients straight, you will see rotation, and you will see that for me it's much nicer rotation and extensive V, but it's very personal. I design with him here, I need to accept the design of the patient too. Whatever I like more, I recommend them more, but maybe it doesn't go for it. So this is 1 month scar and 3 months scar, barely visible. You need to clean very well the muscle. So after you do this is another patient. This is a patient from Pascal who did the more technique on her. I did for her the direct lift. She's in my social media. She did the more technique with him, and she came for direct lip lift and upper and lower to correct also asymmetries. So as you see, this is a 12 month, okay, straight. I don't like straight. I don't like straight. This is 6 months, straight, literally. I like more V and rotation. This is how I like. But again, you have to think, if you like these types of lips, it's like everything in aesthetics. I like a bit extensive V and rotated on the other side. But again, this is a patient, she operated in Turkey from no surgery. Okay? So she had a complication, an infection, blah, blah, blah. But at the same time, she did their lip lift. They proposed her to do only indirect lip lift, but not thinking of the corners. She became crazy, this woman. She thought that she's like a rabbit effect. Then I proposed for her to do, again, corner lip lifts. Open myself to the maximum to get the result she was searching. And this is not because the surgeon didn't knew. It's easy, you can do an additional corner lip lift. But sometimes it's difficult to know how much you need to remove corner lip lift with the indirect lip lift, because you don't know how it deflates a bit the central part and rotates the lateral part. So again, offering her, as I said, this type of technique changed to aesthetic lip. So it happens a lot with these patients. This is another patient. She is a patient 1.90 meters, very thin lips. I did for her lip lift. But after I did the lip lift, she wanted more. And said, okay, I will go with fillers. This was her dream. And this is, she has lip lift and fillers, direct lip lift and fillers. Whatever I do fillers here, I will not get that result, rotation. But she wanted that. She wanted that effect. So as a conclusion, it's a fine cut in the lower part with a little depth. Better for intradermal suture, because as you cut the muscle, transect the muscle, you lose the support, the rotation. And then what happens, the scar is bad. So the cut should be very, very thin. Then slice like a sashimi, having no at all fat on the muscle, zero fat. Sometimes it takes me out, there's a little here. So my assistant, no, there's a little here. We go for every point, because you're trying to remove and sometimes you leave. Do external sutures, remove at 2-3 days, intradermal sutures 7-8 days. I remove at 7, I remove at 2 days, the other ones nowadays. And for me, it's a very proper technique if you do really a good suturing and the maneuver by itself. So again, as I said before, if you need any of the articles, you can scan this QR code. Thank you so much.
I'm going to start off with a couple of questions for both of you, and then we'll go up again with the audience. So, Lissandro, first of all, excellent talks, by the way, both of you. But Lissandro, let me know the biggest question with these techniques about reduction of the forehead is that option versus hair transplantation, because of course hair has involved so much transplantation that sometimes you wonder if it's not better to just do a few lines of hair transplantation. What's the answer to that?
Both of us have hair transplant, so we know what we live with hair transplant.
I'll tell you some history. That patient that I show you, a beautiful woman with rhinoplasty, chin augmentation, facelift replane, neck replane, and forehead reduction. She arrived in my office, and she has a daughter, studied medicine, and did a hair implant. The same size of the forehead. And the student of medicine told me, oh, doctor, if I have a idea that has this technique of forehead reduction, I prefer instead of hair implant. Because the hair implant is not totally hairstyle of the women's, because they want to exactly direct of the wave of the hair, the shape of the hair. When, as I have a hair implant, it's not normally. Right. It's not normally. So if you can compare the both for the women's, the better thing is forehead reduction.
I had my forehead here, and now I have it here, which is 6 centimeters what he resected. In fact, it depends how fast you want to go with the result. With hair transplant, you have to take from here, sleeping is hell for 15 days, going like this. Then the hair first bones as it wants, and then you have to manage it. Yes. And 15 days you have to take out your hair from here. Maybe you can make a small hair elevate and then take, but okay, you can hide that point, and the hair appears like fuzzy first. I did hair transplant, and I would always do it again. I would recommend anyone who doesn't have hair, you can do it. But again, except if you live it, if you like it. But again, it's how much faster you want to live that.
And it's much faster, the result. And for example, to have a 5 centimeters of hair implant here for the women.
Yeah, I heard about that. Some of the comments of some surgeons that prefer this technique also comment that their hair transplantation in females is quite different than in males, and that the results of a hair transplant in a female with a very recessed hairline are not as good as in a male, right? So definitely that's something interesting.
I always tell the patient, do you want to live with a 5 centimeter like fuzzy hair growing for 6 months, or do you want to have a small fuzzy 1
exactly the same.
Okay.
Right, and then the other question is, complications. That's the other thing when you see some of these surgeries that appear as a very large procedure, sort of like craniofacial surgery that we used to do some time ago. You think of complications. You mentioned the importance of anatomy, which is important, to avoid any problems with the innervation of the dentalis. But how about sensation issues, necrosis of flaps, infections? What is your percent of complications?
Please, it's easy, okay? Don't put your mind. It's difficult. If you put it's difficult, you'll never be a great surgeon. So, complications with the nerve, the worst complication. Well, scar. If you have a tension suture, the same with the lip lift. I had complications with lip lift. Now, after Nabil, I'm totally free with the direct lip lift. Sensitive, as Guy Master told us, that nerve that come here, sensitive nerve, you will cut that nerve. Impossible to not cut. Right. 6-8 months with 6 and 8 months. I put in this. And another complication, hematomas. When I started, I not put rain. Please use rain. Please use rain. And a natural position of the brow, another complication. Because of this, Nabil knows, he was with me in Brazil, and I have a big screen in my operating room. I took the photo of the patients, exactly where they want to put the brow, and I put this in my office, in my operating room. And I'm putting the surgeon and look at the photo. Put the surgeon and look at the photo to have a great position of the brow. In the past, I had brown like here, another here. Now I'm totally free. So that's the complication. But it's easy, please put in your mind.
Lissandro, would you ever consider doing this without the drill holes? Because some surgeons will just advance a couple of centimeters and just do that scoring on the gallia and then just do
because of this, I put my first slide was with my master in Brazil, Wilson Davis. Wilson Davis was my first teacher. And my first class of forehead was in 2000, 25 years ago. That time, I used backbone and I used the suture on gallia. Don't do this. You want to suture on the bone because you want to have a very strong support for the scar.
Excellent.
So one thing else in complications is that when you do the gallectomies, try to really, usually I use a blade, and I start with the blade, I enter and I feed you. With the blade you can feed the depth, and my finger on the other side feeding the depth. I try to be really reach the subcutaneous. So you cut the piece on the gallia and that's it. Do not, if you have like Lissandro's experience, you can push and you can use, but try to be as much as respectful not to dip in because you can affect the hair and have hair loss. Because I saw a patient who've done that, and she had a big hair loss like this. But what I learned from this case is that, I don't know what happens after several while, she grew hair, and finally the only loss was like this. From something like this. I have the pictures. From something like this, you finally have, and I don't know what is that. Maybe vascularization again.
In this case of complication, hair implant.
Oh yeah, that's the answer to that. Okay, Nabil, let's move on, and then we'll have more questions for Lissandro for the audience. So Nabil, interesting, wonderful presentation, great results. Regarding tattooing, because of course that made me think also of the direct brow lift, which a lot of females now do that. Microblading of the eyebrow, which of course helps in terms of us with our procedures. What percentage of your patients do you think are having that sort of tattooing in the lip?
So I'm in the Arab world, and Arab world 100% women have tattoo everywhere. Wow. And technically these patients, I tell them it's an option. But from all the people at the surgery, the patients, all the procedures, no one has tattoo in the picture. But I can tell you that the majority go back for coloring, because now when they become nice and big, they want the color, because I expose them that the color here is not perfect anymore. Sometimes it's more red, less red, and they become seeing things, and they push themselves to tattoo. Maybe I can say 50% of the people are operated, then later did tattoo. These all patients don't have tattoo, which I think I would
about
50% maybe they will do, which I would really want to let's make a debate, because it's how we go from down and from up. So what is the indication? If we go indirect lip lift, go direct lip lift. So because when you do indirect lip lift, do you feel that you really rotate the central part of the lip?
Well, that's what I wanted to mention, because most people will do a skin only, and I think you can really tweak the amount of aversion of your vermilion with the amount of muscle reduction. I know that, of course, the biggest averting procedure is a direct lip lift like you're doing, especially around the corners. That's the best way to avert the vermilion, of course, there's no doubt about that.
So I will give you one thing, which is, I think that's what I want to reach, because I didn't find it till now. So I'm replicating the technique of Bintali in the lip. I could say the technique is dissection, and rotation, but we're not resecting muscle. Zero. When we don't resect muscle, I see zero rotation of the lip on long term after 1 year. So you're resecting muscle. You're resecting. How much muscle do you resect?
Very little, normally just 4 or 5 millimeters.
Okay, so it's good to maybe make an article resecting muscle versus not resecting muscle, which we're opening, resecting subskin, and suspending. If this is the reason why I'm not able to see lip rotation at 1 year, maybe it's good to get all your patients at 1 year, pictures of 1 year, and create a re-criticism of the assessment. Because if we could rotate the lip from up, I would not go to down. Because with my technique I'm doing, which is without muscle resection, I can't see it at 1 year.
Right.
And for that reason, I shifted myself from up to down. And I still see that the scar here, if there is cells, is visible. But if there's no cells, I'm the first one who want me to do it. So when there's cells, the shadow of the light hitting the cell and transferring to your eyes is high. And if the woman is a bit at your eyes dull, you see it more.
Right, no, definitely. A lip scar can be very visible if it's done, as I mentioned before, low. It can be very visible, although a lot of times in photographs, the shadow of the nose from the flash will cover the scar, and it makes it look like it's less evident than in a real person. Okay.
So how do you manage the patient with cells then? With
So I mentioned that. So when I have a patient with a nasal sill, I will disregard it and just place it higher and de-epithelialize the nasal sill. I think that's very helpful to avoid that visible scar. But then again, the other question is regarding your lip aversion, which looks like it's one of your goals in lip lifting. You know, it sometimes can look a little bit more artificial in regards of what you were mentioning, the type of lip that some patients request from us as attractive, where some of the European kind of standard might be sort of like over excessive upper lip volume, which a lot of patients really want, especially younger ones. So what is your opinion in that regard? Do you have your own kind of standard? And if you want a patient that wants these sort of like exaggerated, like Barbie kind of lips that are huge, you will provide that to them, or you say, no, I just don't want to do that for you because I don't think it looks natural?
In fact, I operate for myself.
Right.
This is my philosophy. With a flexibility with the patient's ideology to see if I can see it in him. If I see that I can't see in him, I reject the patient.
Right.
But part of the result, to make it more natural or less natural, it depends on how much you take for sure, but also how you draw. Drawing a rotation in the lateral part, it's more fake. If you go more straight, less fake. So here I can show the patient how much more fake or less fake he wants. I don't exaggerate, but I can make it a bit.
You can tweak it a little bit.
The V, as much less V, much older women. As much young V, much being like you are younger. If someone is 70 years old, it doesn't fit too much V. I can see it. So I try to be in the middle. So I check the age also. Like
you didn't mention, Nabil, or you're not looking in your type of patient population that you were mentioning that might be different where we are practicing. You didn't mention about dental show. What is your take on the dental show you can achieve? Because it seems that you are achieving excellent aversion of the vermilion, but perhaps less dental show in patients that have very little dental show.
So dental show, technically, the real surgery for it is maxilla change.
Yeah, of course.
But again, who doesn't want to do orthodontic? No one.
Right.
So then, based on a publication by Bentley, 823 cases published, he measured all the dental show. If you check the data that he has published in an article, a 5-6 millimeter resection, which is the typical resection, it gives you 1 to 2 millimeter, which is barely visible on eyes.
Right.
So to get 3-4 millimeter, 5 millimeter dental show, which is the patient would give you to appear the dental show, then you need to resect a centimeter, which is too much. I don't think people are reaching the 1 centimeter resection.
Well, you know, I don't think, Nabil, that you can be so rigid on a paper from Ben, because my observation is that you can get quite a lot of dental show in some patients without that much of excessive resection. Of course, there's variance between their maxilla height between patients, and some patients that want very good dental show, you just cannot provide that to them. I totally agree. But definitely there is a huge impact on dental show from upper lip lifting in the majority of patients. And of course, that is the advantages of doing a lip lift with a composite kind of en bloc elevation. But I agree that it's not everything about lip lifting is about dental show. But that some surgeons, for example, Oren Pepper in his paper also in ASJ tried to, with Cadavers, showed that sort of also relationship between resected and dental show provided. And actually he works a lot with dentists, not even with orthodontic surgeons, but you can use, you know, dental aesthetic dentistry to provide a little bit more dental show. But definitely I think, as I showed before, dental show is very important for facial
But I think, and this is maybe we need to study it.
Yeah.
Bentley and me are doing very similar, we're not resecting muscles.
Yeah,
So
placating.
maybe placating doesn't create a good dental show. Maybe resecting the muscle create more. Do we need to
We need more
investigate?
study. I agree with Nabil. I think that we all are aware that lip lifting is getting an incredible, it's gaining popularity. It's sort of like a new specialty. Sort of like, you know, now we have panels, and this is great. Thank you, TNP, for having a panel on lip lifting and new techniques like the forehead plasty by Alessandro. But definitely there's some new fields in facial aesthetic surgery that we need to have more research on and to provide that result.
In fact, I measured all my lip lift, and very little.
Yeah.
But maybe because we're not resecting muscles.
Exactly. So any questions from the audience? Yeah, there's several of them.
Hi, Dr. Martins. Do you think you can minimize the amount of brow lift you get, like in a man, that you don't want to raise the eyebrows too much when you're doing the forehead reduction? Too much. That you want to minimize the amount of brow that you get, the amount of lift you get in your brows?
It's difficult, but I think it's possible, but it's very difficult to tell you exactly. But I try to put exactly where the patient showed me, and I never do an overcorrection. Yes, I never do the overcorrection. In the past, I did because of the gallia, and they back. So I did in the past overcorrection. Now, as I suture on the bun, I never do the overcorrection. I try to put exactly where I want to put the brown. So it's very important.
Excellent. Yeah. Another question?
Yes, for you, Dr. Bravo. So when young patients come in and they want more color show on the upper lip, do you still resect muscle, or do you don't? Or do you just resect?
Yeah, when they want more dental show, young patients, or when they want more vermilion?
Want more vermilion.
Yeah, exactly. So that's a great question. So again, in patients that want more vermilion or more rotation or aversion, I will resect much less muscle and maybe bevel it out a little bit to have a little bit of both that aversion and not aversion effect. Yeah, that's a great point. Yeah, there are some patients that benefit from vermilion aversion. Yeah.
Thanks.
Great.
Okay, so they wanted me to show the video on upper bleph and adjuncts. I think Dr. Fakih is going to show the lower lid bleph. The video I presented is available to all of you wanted also. And then I'll do some stuff on canthal suspension. So you want to start running the video? I usually will mark my crease with the patient preoperative area sitting up, but you can double check it on the table. The crease in men is in women is approximately 10 millimeters centrally, tapering nasally and temporally. It's a little lower in men. In your dissections, you may want to inflate the eyes with saline because they collapse. It's harder to do this. Got it. The faces and eyes have been inflated. You don't need to do that. In real life, when you're injecting someone, bend the needle so that it's not pointing towards the eye, especially under sedation. You can use a knife. Most people do this. However, Dr. Fakih and I both use the cutting mode on pure. Studies have shown there's no additional scarring from doing this. In fact, studies have shown that the result of the scar is actually the same. I like doing it this way because it bleeds less. Once you finish the incision, you then want to remove the skin. I preserve muscle at all times in upper blepharoplasty. Excision of muscle down the road many years later, and you don't know this unless you've been in practice for a long time, leads to weaker closure, reduced blink, thickened white scars, and also pre-tarsal skin gets many more telangiectatic vessels when you do this. I think something happens with engorgement of the muscle. You can see that the dissection plane is between the dermis and the muscle. This is all in cutting mode.
And I'll just continue along. My assistant will push now, push even more and more, because when they push...
And then once you remove the skin, it's just hemostasis, and then opening the septum.
And now the skin has been removed. Okay, now
so you can use 4-prong rakes to open the septum. You can also use 2 fingers to block the globe. When you open nasally, stay up high. That way you won't touch the levator. The levator goes around the nasal fat pad, so nasally you can't hurt it. On this person, it's very sparse, so you'll see what the allotment of the globe does for you. So when you push, you can see the fat pad coming forward. And you could excise fat here if you want. You could also make it into a pedicle to transpose. In this particular case, fat was sparse, so transposing it would not have been of any help, but that's what it would look like. Be very careful in the dissection if you're going to transpose, because the trochlea of the superior oblique separates the central from nasal fat, and if you damage the trochlea, you will get double vision. It's a different form of double vision with the lower lid. It's called pseudo-Brown syndrome. You can see that the preaponeurotic fat is a different yellow. It tends to be stem cell poor compared to the nasal fat. I pointed out Whitnall's ligament, the levator, the posterbicularis fascia, and the orbicularis muscle. And that's the orbital septum. And there's Whitnall's again. You can see the muscle and the aponeurosis. So the middle fat pad has been reflected off, and you see a mild prolapse of the lacrimal gland. For video purposes, I showed you how to transpose it. Something like this you probably don't have to transpose. It's clinically not relevant, but the lacrimal gland can prolapse significantly. That was the brow fat pad we were holding on to just now, the roof. So next you'll just see how to put a simple suture through the gland. You can put it through the head, the parenchyma of the gland. It sits in the orbital plate of the frontal bone, and you can pass it through the periosteum and tie the suture. When you tie the suture, drive the end of the suture into the orbit, and whatever is remaining, you can cauterize the tip. It is the same trauma to put a suture through it or to cauterize the tip of the gland. You don't get dry eyes from this. If you cut the gland out, that's a different story. And there's no lateral fat pad in the upper lid, so know that you want to look to separate the gland from fat. And this is just cautery to the head of the orbital lobe of the gland. And if you do that, it forms a little cicatrix and prevents the gland from reprolapsing. So that's lacrimal gland repositioning. This is grabbing the arcus marginalis periosteum of the suture and then grabbing the distal edge of the upper part of the orbicularis in the wound. And when you tie it, the orbicularis will act as a hammock and will elevate and anteriorly project the brow fat pad. This does not lift the brow, it lifts the brow fat pad. There are many ways to do this. Nabil does it differently with his volumetric technique, but this is one way to do it. It's very predictable, it's pretty easy, and generally complication-free. When you do this, split the orbicularis muscle down the middle. If you are too close to the skin, then you'll pucker the orbicularis down and pucker the skin. You then have to undermine the skin so you don't get that pucker. This was first described in the 90s by a plastic surgeon named Harvey Zarum. He did it for other reasons, and then it got repopularized about 10 years ago. And again, it just volumizes the brow by taking the natural fat of the brow and lifting it to a higher position with the orbicularis acting as a sling, hence the name brassiere suture, because it acts like a bra to lift the brow fat pad. And then the last part is closure. You have a large ellipse. The arm of the lower part of the ellipse is shorter than the arm of the upper part of the ellipse, so you can make the ellipse smaller by dividing it into smaller ellipses. That makes it easier to close the incision and align the relaxed skin tension lines. You know, what Nabil was saying earlier about his indirect lip lift, it's all about the scar. You can do pretty surgery internally, whether it be a facelift, an eyelid, a lower lid. So the end of the closure is put your cardinal bites in. At the end of the incision, don't allow yourself to chase a dog ear, put it together. You can cheat towards the middle part of the lid, don't cheat externally because then you'll have a lengthened scar. And then just, I run it all the way along. You can do subcuticulars also, and don't start your closure immediately at the apex. The incidence of webbing is much higher. So it's a pretty straightforward procedure. Moving fat around, lifting the brow fat pad, securing the lacrimal gland. I didn't go into crease formation or ptosis repair because I don't think it's critical here. I think it's about really learning these basics well. So that's upper lid, in a nutshell.
I'm Dr. Faki, I'm a cranial maxillofacial surgeon, and I'll be explaining about lower eyelid surgery. In fact, this technique is a technique that it's a transcutaneous technique, and you need to add all the add-ons that I explained before, which makes this procedure more safer. For that reason, the first step you have to do is an incision line from A to C, and we will be using a blade in that case in the anatomical lab. And after doing this, we will be doing a subcutaneous dissection. Remember that only in the orange part, it's a must, and that's how we'll be dissecting it from all sides. I would recommend to put anesthesia in all the cadavers so the dissection could be much more easier. So as I said before, with that, it's very important to maintain tension and try to dissect all the other part. After this, I want you to transect the orbicularis muscle downwards. Remember, it should be 50 millimeters in extension. I need to maintain my maximum. As you see, the orbicularis cut is circular, is not going much down to always maintain the nerves there. After I do this, this is how you will have the fat bags. Second mission is to create a dissection, submuscular dissection. You release easy. As you open and push downwards, it will open in the submuscular plane alone. After you open and you release everything, now you have everything released. Laterally, we'll be making a cut, and your incision you'll be using a blade. Try to use the peristome to find exactly where the muscle finishes. The muscle is very thin, so you don't need to dip too much. After you do this, you need to find the orbital thickening, which is a white sheath that you need to feed it there. This white sheath is responsible. You need to create dissection going downwards so you can recreate the opening. Remember maintaining this white sheath in your floor of your dissection. After you do this, try to learn today to extend much more. I'll show you if I move by the rooms, I'll be putting my finger reaching to the nasal level if you want. Try to search the 3 fat bags, but remember the lateral fat is not the fat you have to transect. The aquatic
expansion so you can release it well. Do after this transpositioning, you see how I'm transpositioning. You go exactly from below and you later put the fat. So the suture could be on the upper part of the fat so you can really close and do a good transpositioning. Try your helper team push the fat downwards like this as you see so you can do a good transpositioning and you fix it. Try to fix it to create a very nice bed. Forget if you have too much fat because later you can resect if you need. After we do this and all the transposition is done, my next step is really to create a nice transposition of all the fat and all the below the orbital rim. Later search for the lateral fat and try to put a mosquito and resect it. Remember that to make the surgery easy in a cadaver, try to inject a lot of saline in all the eye as this expansion of liquid inside the eye will create you do a very nice and easy dissection. If you don't inject too much, then you will not be able technically to create a good dissection. After this, dissection upwards in the submuscular plane, and by this you would be seeing again the orbital thickening in all that area. Try to release and put a cantopexy as much as high from canthal tendon upwards. It's not below. As you can see, it appears here below because I'm pushing upwards the eye. But as you see, there's a good suspension there. Try to tackle it good. After this, we'll be putting two sutures of 4-0, as you see, both at the lower below the canthal line, so you can really create a good suspension of that area. Try to feel how it's suspended well, so you can create a good tackling suture. In between the 6-0 and the 4-0 sutures, I'll be using a 5-0, and this will be for the muscle. And remember, it is the last part of the procedure. So we'll be check them, take a picture, try to learn what exactly you put them, and remember that the mission of the lateral sutures is to tackle the cheek. First one is cantopexy. So I'll be putting a suture from the canthal part, and I'll be closing. Try to learn here. Try if you have any doubt, ask me. I'll be passing by every one, and I can always see how you're doing it. If you push it and it's too much, then release it back, and it should be sleeping like this. You see when I close it, it appears nice. If you put it very high, it will dip inside, so maintain it to take it from below. As you see, try to check always how it's done. If it goes up, goes down, and if you push downwards, it goes along upward. This means that the cantopexy has a good unclage. After this, you need to try to unclage the orbicularis muscle. Maybe some fat could be over the orbicularis muscle, a little fat, but again, it's the orbicularis muscle unclage. Your helper should push upwards so you can really close very well, and by this you create a very nice suspension. We'll be putting, this is the most powerful suture, so this really needs to be very well tackled. The lateral part is a helper, it's only a transitional helper. It doesn't have like a big part of the game. So also now you need to push upwards the cheek. As you push upwards, you'll see that the muscle, the orbicularis muscle from the lower flap will be at the same height of the incision path, covering the other orbicularis muscle that it's below. This creates really a doubling of the muscle at that layer. After this, remember that we're doing the boomerang, which will be a 5 millimeters laterally to cut the 5 millimeters more from X prime to X. So if you're there and you want to know the cut, just call me and I'll be going there by everyone and showing the cut. Again, after this, you need to really close the orbicularis muscle. And after closure of orbicularis muscle, you try to push it upwards so you can create a nice support for the muscle. You close it, and after closure, you have this muscle is well positioned in place. You're recreating the orbital model ligament. After this, remember Vicar sutures below, and finally simple sutures. For timing period, I'm not showing the subcutaneous sutures, and we're finishing with simple sutures. Thank you.
All right, so we're going to show some videos on canthal suspension. This is through an upper lid crease. So an upper blepharoplasty was performed, but it wasn't close to its temporal extent. A suborbicularis dissection ensues to the lateral canthal tendon. You could then grab the commissure, strum the tendon, and do a graded release or a full release. It depends how much you want. Try not to change canthal angle position too much on aesthetic patients. Generally, that's not a good idea. You then expose the inner orbital rim, in or about Whitnall's tubercle. Remember, a bunch of things attached to Whitnall's tubercle, so when you put sutures through there, you want to make sure you don't imbricate anything, because you can induce ptosis if you grab the orbital septum or levator aponeurosis. The suture goes through. It's a double arm suture. You can do it with a single arm too. It's just easier with a double arm. Both ends through the commissure. You want to enter through the same hole, bring the suture through, and then both ends of the suture will go through the inner orbital rim periosteum. If an eye is prominent, then stay on the outer edge of the bone, of the orbital rim. If it's anophthalmic, you get more on the inner edge. If it's a prominent eye and you go too far on the inner rim, you'll bowstring the eye and retract the patient a little bit. That's one bite, and then your second bite. The nice thing about this technique is you haven't disarticulated the canthus, you haven't changed the commissure, you've preserved the orbicularis of the canthus. It's less disruptive. This is very, very predictable. It is really, of all the things that we do, that I do in my world, this is really complication-free. Patients do really well with it. And if you're doing an upper blepharoplasty, it simplifies it. You can see when you pull on the suture now, the canthal angle doesn't change at all. And the commissure is intact. So that's through the upper crease. When you tie the suture, it's a general rule, don't put more than 3 throws of the suture, or else it becomes, the knot can be felt afterwards and you have more substrate to have inflammatory reactions to. I do not use permanent sutures here. I used to. I don't think it makes a difference. PDS lasts a number of months, and I think that's plenty to get the result that you want. You want this under physiologic tension. If you're doing a lower lid retraction repair, then obviously you're doing a different procedure. You're taking apart the canthus, and I can show you that too. There's a second video where rather than doing it through an upper lid crease, you can do it with a canthotomy, still spare the commissure. This is easier, and also gives you access to the midface to do stuff like Nabil was doing, or if you're doing a retraction repair. So it's a canthotomy about 8 millimeters, you spare about 3 millimeters of the commissure, and you do the same thing. Double arm suture through the commissure, then through the inner orbital rim, that's the cantholysis. Now if you have a single arm suture, you can put the suture through periosteum, go from in to out to in, and then put it through the periosteum. So you can do it that way too. I don't know if you have double arm or single arm here, we can do it either way. You can grab tarsus, not just the commissure, but again, in most aesthetic patients, you don't need tension. So if you put your sutures through the commissure, there's enough robust tissue in between that you don't have to get a tarsal bite. If you do get a tarsal bite, temporarily you'll kink the canthus, but that all settles with time. The reason I present these two procedures rather than the traditional tarsal strip is because once you do a lot of these and master this, it is so aesthetic, they can't see a difference in appearance at all. And then the last little cue, when you're closing this is the second bite going through. Once you've closed the suture, when you close the skin, make sure that the area just proximal to where you made the canthotomy, near the commissure, make sure you have a good suture closure there. It prevents the little webs that you get. Also, if you're doing an upper and a lower blepharoplasty together, leave yourself at least 5 to 6 millimeters of skin between the two incisions, the lateral extent of the upper bleph and the canthal suspension, or else you can get webbing. Webbing is a very difficult thing to fix at the canthus, and patient satisfaction with its correction is extremely low. So you want to avoid the things that get you into trouble. So these are just two very simple there's so many ways to address a canthus. These are the simplest, easiest way to do it without getting yourself into trouble. And for chemosis, Pascali showed it, I showed it too. If you want to prevent chemosis after surgery, anytime you manipulate the canthus, anytime you do a low transconjunctival incision, anytime you do a revision, anytime you do internal ptosis repair, you're going to have chemosis, almost always. If you want to minimize it, put a little tarsorrhaphy suture, leave it in for a week. Even after a few days, the pressure of it will really make it a non-entity. There are ways to treat it with medications, drops, etc., even cut downs, and little cautery burns in the conjunctiva, but you want to avoid all that, and that tarsorrhaphy suture really makes a big difference in terms of chemosis. So that's it. The deep fascia has an anterior and posterior leaflet. This is the posterior and anterior leaflet of the deep fascia from the galea. And then in between it is the fat pad, which is the roof. And you can see the roof if you split here. So this is retroorbicularis oculi fat. It's like the SOOF in the lower lid. Now if you want this, we can come off there for a second. If you want to add volume, what you can do is put a suture through here and put it through the muscle, and that will force the brow fat pad up. It doesn't lift the brow, it just forces the fat pad up. That's a pretty good dissection of the anatomy. You don't have to free it. No. You can just put a suture through the arcus and a suture through the muscle. I just opened it to show you that it was the fat pad and that there are two fascias, one above and one below, and they come from the deep layer of the fascia of the galea, and they split around the fat pad. Just ask her, she taught me. So that's a pretty good anatomical dissection. Levator or posterior? Okay, so let's do this. Yeah, we do have 4-prong rakes here. You can hold that. So if you're going to do levator surgery, what you want to do is take a strip of orbicularis. You're going to expose the tarsus. Again, I usually do this with a cutting cautery. You see this yellow connective tissue? This is the tarsus. So here's the levator, aponeurosis. This is the tarsus. You can just clean it off. Let's go this way. So if you do levator ptosis repair, you need the patient awake, because you have to check lid height and contour. So this is the levator. Underneath the levator is Mueller's muscle. So what you do is you undermine it. This one is fatty infiltrated. And now you can let go there. So what you'll do is you'll choose the place in the tarsus you want to grab, your sweet spot, and you'll put a suture through tarsus and a suture through here, and you'll advance the levator. Once you've advanced it, you have the patient open their eyes, the eye will open, and if you want to form a crease, you sew the skin or muscle to edge of levator, and then to the edge of muscle here too, because when your eyelid, this is your levator muscle, aponeurosis, when the eyelid moves up and down, watch as I come up how it forms an indentation. Very slowly, follow my finger. So the crease is dynamic. When you're looking down, you don't see it because the muscle is not active. When you look up, the muscle is active and it creates the dimple. And the way to reform that is by taking a bite of muscle to edge, of aponeurosis to muscle. You don't have to reform a crease. It actually, most people won't because it's a little more complicated, but when you do a ptosis repair, I would suggest you do it. The posterior approach, which I think you should do, I don't think you should do levator surgery. Do we have like a Mar retractor or something to flip the lid? Yeah. So what you do is you're going to flip the lid, and we have a little, can you pull that off? Yeah. So I'm going to balloon the conjunctiva. So we've already dissected the levator. So what you're looking through now is conjunctiva and Mueller's muscle. And what you will do is you will make a measurement based on drop testing. So you place phenylephrine drops into the eyes. Have you done posterior approach ptosis before? Do you know much about phenylephrine testing? Okay, so Mueller's muscle is a secondary eyelid elevator. The primary eyelid elevator is the levator that I showed you. It's a somatic muscle. That means if I ask you to open your eye, you're going to open your eye. But if I get behind you and go, boop, and scare you, your eyes are going to pop open involuntarily. This muscle is an involuntary eyelid opener. And I'm just going to show you how it's done. It's complicated to go into how much you do. So you're going to basically mark it, and then I don't know if we have a ptosis clamp. If we don't, which I doubt, if you hold this, I'll show you how to do it freehand. So there is a clamp made by a guy named Alan Putterman. Have you heard of the Putterman clamp? He has a clamp, not a fat pad. It's like slightly curved. He has an instrument. So what the clamp does is you can also use a hemostat. Let's see. Do we have a hemostat here? Okay, we can try a needle holder. So what you do is go ahead and put your light back on. On the top and below, you clamp the tissue. And once it's been clamped, you can take a knife and then sever the tissue. You can also do it freehand. So if you cut this tissue, you've now removed a certain amount of Mueller's muscle and conjunctiva, and then you sew this together. And when you resew it together, you'll get the repair that you want. And I have videos with me, so you can see where this is open. See if there's another pickup here. Anything else? And you build it with micro? I use chromic. So do you see how this comes to this? So you'll end up sewing it together. Usually what you use is a running suture. Now remember, the suture can rub on the eye. So what I do is I go external to internal, run the other way, and then go internal to external and tie it in the blepharoplasty wound. And then I usually put a contact lens in the eye for a week so that if it rubs on the eye, it's a bandage lens, it's paper thin, so that if it rubs on the eye, usually I don't feel anything, but the 1 in 50 cases where they do, you don't want to run into the office in the middle of the night. At least I don't want to. And my fellow doesn't want to. So I put contact lenses in the eye. This you can do with sleep. It's based on an algorithm dependent on phenylephrine drops. So the muscle, that's Mueller's muscle, is an autonomic muscle. It's a fight or flight muscle. So if you ever go to Halloween Horror Nights or anything like that and you get scared, your eyes will pop open. If anyone ever scares you, they do. And so when you put phenylephrine in the eye, 2.5% is enough. Some people put as much as 10%. What happens is it dilates the eye, which is one side effect. The other is it'll lift the eyelid because Mueller muscle contracts. Depending on how much you lift, there's an algorithm for how much tissue to resect. And some people put those sutures in before they remove the clamp. You should, yes. We just didn't have the suture here. So I have a video I give everyone if they want. We just didn't have time to talk about ptosis. Okay. Can you do the operation also without going to the eyelid, just going internal? Yes. And then bring the sutures through the skin and tie it on the skin. Yeah. Yeah. Internal ptosis repair is a very basic procedure that helps a lot in blepharoplasty. Every one of you could learn it well. I can give the video to them and they can send it to you. If you just ask for it, I can have them email everyone. You never go through the levator. You always stay from inside. Which procedure? With the internal. So when you do the internal, you're taking conjunctiva and Mueller's muscle. You can't assure that no levator gets engaged. The way to assure it is, remember I told you the crease is levator to skin, right? When you have the clamp on, if you pull on the skin and it moves freely, it means you don't have levator. But if you pull on the skin and it seems stuck, because the levator forms the crease too, you probably have some levator too. Whether or not that makes a difference in outcome, we don't know. When you ask why does that surgery work, no one knows. You think it's resection of Mueller's muscle. But people that have Horner's syndrome, where Mueller's has been denervated, it still works. Is it advancement of levator? Because when you shorten Mueller's, you actually advance levator too. Who knows? Some people take the conjunctiva off and just resect Mueller's. Some people take the conjunctiva off, cut Mueller's, don't put any suture in. Some people just do 7 millimeter resection on everyone instead of following the algorithm. It still works. So it's one of those things that everything works and we don't know why. Could be. Who knows? No one really knows. Everyone will come up with every theory. It's very straightforward, very simple. And the outcomes are good. 95% satisfaction. All right? Now do the other side. Replicate it on the other side. So there's a fat pad here and there's a fat pad here. So what you can do is you just cut the base of it, and then you can see that you can move it over. And you can sew it to the undersurface of the muscle. Let's do this. Where's the two-prong rake, the rakes? Here we go. I'm going to show you guys a little trick that'll help. Boy, I can't believe how old I got. I can't see anymore. You want to hold these up. And then you could put it, if you get under the septum orbicularis and you cut on top of that, this is called the orbicularis tent. You've tented it up. So here is your levator muscle. That's your aponeurosis. And you can sew it to the arcus, to the undersurface of the septum, anywhere. And you take this fat, which is stem cell rich, and transpose it here. And so you're preserving all this fat. So you have a good substrate to preserve here.
And do you combine it with fat grafting?
Absolutely. Absolutely. I do this in the fat grafting last. Some people do the fat grafting first. Let's see if there's a lacrimal gland here. I don't see it on him. And then you preserve this always. You can just shove it back into the orbit. That's pretty good anatomy. Make sense?
Yeah. And what kind of suture material to take?
So because I close the lid with 6-0 nylon, I do everything inside with 6-0 nylon too. Because I don't want to add extra suture. Except when you're doing, if you're doing a brassiere suture, here's the arcus that you're going to sew to here. I use a 5-0 chromic because I really want it to form a scar. Make sense? Pretty simple. Here's Whitnall's ligament right here. You can see it, this white tissue. It's the transition of muscle to aponeurosis. It attaches to the trochlea and to the lacrimal gland fossa. Whitnall's ligament does not attach to Whitnall's tubercle. That's just anatomic. I don't know why. Sound good? Lower down, you're more prone to getting webbing than if it goes up. Because when you close this incision, what you do is you hold it here, and you wait. You give about 8 millimeters, and you can start the incision there, and you allow all the edges to find themselves. When you come to a point so close to here, it's very easy to get a web that continues into here. And webbing is very, very hard to fix. Make sense? So you're asking about repositioning the fat. You have a scissors? A little scissors? That's fine, that's fine. Grazie, grazie. So what you do is you want to spread. Now, nasally, when you spread, you absolutely cannot damage the aponeurosis because the aponeurosis attaches around the nasal fat pad. If you take a Q-tip or an instrument and get underneath the orbicularis muscle, where's that knife that you had? You can cut down on the septum and orbicularis. I call this an orbicularis tent, and that way you don't have to worry about damaging the levator muscle. If you do this, it's the same thing, it's just that you can damage the muscle, and that usually scares people. So here's your fat pad. You asked about transposing it.
You never take out muscle, right?
I never take out muscle. You're going to pay for it as they get older. When they're younger, it doesn't really make a difference. It looks better at first, but the question is, what does it look at 20, 25 years? So there's your fat pad that's been freed. This is the fat pad. This is actually probably a little more of the nasal fat pad too. And then you can transpose it and sew it to the orbital rim, undersurface of muscle, undersurface of septum. This fat is stem cell rich. It becomes more prominent as we age. So when you transpose it here, you'll get more fullness.
Okay.
Yeah.
And is there a specific point or a landmark that we should use for us to take the first bite?
What do you mean, of the fat?
Yeah, or is it do we stretch it until where it gets, where it lays?
You want to put it where it lays, but you want to make sure that there's no tension on it. Because the tension on it could induce atosis. And as you can see, this is a good example of the levator muscle, the levator aponeurosis, orbicularis, orbital rim, arcus marginalis. No one has a lacrimal gland today. Yeah, there's no lacrimal gland there. You can't see it because it's so desiccated. But you can see the difference in color of the two fat pads, and that there is no lateral fat pad. And then this is the brow fat pad here.
So we just lay it under the muscle, under the septum. That's where we fix it with one stitch.
If I were you, I would fix it with one stitch. I'd probably sew it. You can sew it to the arcus. You can sew it to this tissue over here that's fixed. So this will come here, and you'll just transpose that fat to that area. And it helps prevent the A-frame as you get older. Because traditionally everyone and most people still just excise it, but it helps prevent hollowing. Now, if you fat graft, then you could augment with that too. But this improves the volume of the upper lid. Fat grafting improves the volume above the frontal bone here. I call this the orbitoglobular groove. This is the nasojugal groove because of its surrounding anatomy. This is the orbitoglobular groove in this area. You can cut some of it off if you want to. Yeah. Make sense? Awesome. So once you've made your incision, you want to anchor it to the inner part. So you're going to have to create a little opening so that your suture will now go through here. So you have to do the cut in the canthal tendon so that you'll have somewhere to put your suture through. You see that here's the edge. Is there another pickup, or is this the only one? It's okay. So if you have the suture now, you have that double arm suture, and I'll show you what we'll do. It's one-armed. Okay, so one-armed, I'll show you how to do one-armed. Where's the needle driver? Here we go. So what you want to do is this. Find your inner rim, which is here. Turn your wrist, so you have a bite of it. And now you can see this is fixed, the periosteum, correct? Because it's single-armed, you have to go the other way. You have to go from here, through here, and then the other way. Now on these cadavers, the tissue is so lax. And now your second bite, you can even use it. If it's hard to just use this to get your exposure, then you can use a Q-tip. Just turn your wrist. And then when you tie it, you've secured the lid. If it's single-armed. If it's double-armed, you can go out to in with both ends. If it's single-armed, you have to grab periosteum, go this way, go the other way. Make sense? Yeah. And so you can see how nice the lid is reformed, and you don't have to reform the corner. The commissure is already formed for you. And you don't just take muscle. In apexy, you just take the muscle, and when you do that, you don't get much tension. Look how lax that is. Now pull on this. So you went from here to here. And it looks natural. And the further in the rim you go, the more apposition you have to the globe. This is a cadaver, so it's different. Let go of the suture and pull on it now, and look how lax it is. And when you pull on this, let's see. Okay. That's a small pickup. So the way to tell the difference is pull here, and now do this, and you can see the difference. So if you completely pull up here, and then you pull here, you see the difference. And we haven't done a canthal-lysis. This, if you pull up here, you can see that the inferior crus is still attached. Do this, you can see how the inferior crus is still attached. If you really want to change the position of the lid, you can cut that part of the tendon also. Make sense? I don't believe in transcutaneous surgery. Neither does his boss, her boss. You will get yourself in trouble eventually. There's no way around it. So I see well over 100 eyelid retractions a year. Everyone had transcutaneous surgery, and more than 90% of them had a canthal suspension. What that tells me is that maybe if you're Michele Pasquale or Nabil Fakih and you're used to doing it and you've perfected it, that's fine. But the average surgeon is going to retract lids. And if you have lid retraction, there is nothing more disturbing to a human being than changing the shape of their eyes. And when they're really pulled down, they're miserable, they have post-traumatic stress, they're angry, and they're very litigious. So like her boss and myself, I'm anatomic, I'm careful, I don't do things that could lead to problems. Problems are going to happen anyway, in the best of circumstances. But those techniques that you were watching, and it's not any negative on the doctors, are techniques that you should do at a very advanced level. What I'm showing you is the basics you need to learn before you can make those decisions. So if there's skin, you go transconj, do a canthal suspension, and do a little skin flap or skin pinch. The chance of you getting retraction there, we've studied it, is this big. But if you do pure transcutaneous surgery, when you go through the skin, the muscle, and the septum to get to fat, in the literature, look at the published literature, do you know what the incidence of retraction is? Anywhere from 6 to 28%. That means 6 out of every 100 patients retract. Is that acceptable to you? That would not be acceptable. And I can tell you something else too. The point of these courses, you come here and spend a lot of money to learn how to do things that are safe. Everyone starts and wants to learn safety, safety, safety. So anything that's a little more complicated, that leads to potential problems, isn't good for you. Once you have basics down so well that you can do them in your sleep, and that takes volume, it takes time, then you start playing with other things. This cutting the orbicularis all over and moving the orbicularis around is fine if you really know what you're doing, but if you have one problem with it, one unhappy patient that makes your life miserable, you know what you'll do? You'll stop forever. On the other hand, if you learn the basics really well and make little baby steps to getting there, it won't scare you because you'll have a basis already. Good background. If I'm wrong, tell them. No, tell them. Yeah. Repositioning? Mm-hmm. I'm under the periosteum. Nabil is above the periosteum. I've written the papers. It makes no difference in cosmetic outcome. Either way is fine. Yes? No, if you put it below, so it's basically if you leave the base of the pedicle large, then the fat graft will be vascularized. If you don't have much of a pedicle at the base, then it may not survive. It will survive more because you're in a more vascular layer if you're above the periosteum, but the problem is you also get more lumps and bumps. So you have to pick your poison. You will find what works for you, and when you do, you keep doing what works for you. Okay, so this, do you have a Q-tip here? A little one, there you go. So basically, this edge here is the arcus marginalis. Is there any suture here, a proline or some small suture? I think they have something here. And you can cut that in half if you want to. Actually, you know what? It's not cut in half because you may want to use this for the canthal suspension. Is that double armed or single arm? Oh, single. Okay. So basically, this is the arcus periosteum. If you just turn your wrist, you can see that you've grabbed the periosteum. You can feel the tension, and then you put a bite through the wound edge orbicularis, which is right here. And what happens when you tie the suture is the brow fat pad, which is here, will elevate and anteriorly project. You're volumizing the brow. No, I put like 3 or 4. Could you keep your light on it? Oh, thank you. I see so much better with light. So trim that one short. Hold that. So just to show you the effect of this, do you see how over here the brow fat has fallen, but over here it's been pushed up above the rim. So if you took another bite from here till here and you push it, you add volume, you're actually repositioning the todic brow fat pad to a higher position. So you're elevating it and anteriorly projecting it to add volume. When you're done with the blepharoplasty, you can then fat graft this area. So you can do this with fat grafting. And in all my brow lifts, upper lift leg combinations, I fat graft everybody. And I put about 3 cc's of fat here. It makes a world of difference in the final result. I'm sorry? Three-dimensional thinking.
Usually the placement of those stitches, the first one is like about this.
No, I'll put one here, and one close to the canthus.
So the most medial will be about in this location.
Yeah, you can put more medial if you want. Okay. You can tack this down if you want. You can tack this down. But this makes a big difference in brow volume, not in brow height.
Could you do the commissurer suture?
Sure. I'm going to come around here then. Okay. Now this is a clear suture, isn't it? I'm going to use this because it has color. How old are you? I have a bigger problem. Let's take this off. Okay, so the first thing you have to do, you have a canthal incision, but what you have to do is you need to find the periosteum. Do you have the pickup here? Right here. Okay, so this is your canthotomy. A canthotomy is a canthal incision. It could spare the commissure. You spared the commissure here, it's intact, or you can cut the commissure. This is a canthotomy. Next thing you have to do is what are you going to sew it to? So you're going to score the common canthal tendon. The canthal tendon is a 3-dimensional structure. It has a horizontal component, superior inferior crus, and an anterior and posterior attachment, a superficial and deep head. So what I've done is I've created a point for which you can sew the periosteum here. Without doing this, then you can't do this surgery. So what you want to do is you want to go through the commissure. Yeah. Thank you. You want to go through the commissure. You don't need to get tarsus. Turn your wrist. What you don't want to do is you don't want to engage aponeurosis. If you engage the remember there's 4 things attached to Whitnell's tubercle. If you engage aponeurosis, which is one of those things, then what can happen is you can induce atosis. And you don't want to add these instruments. Here we go. Oh, this is single armed, isn't it? Then let's do it this way. I thought it was double armed. You can let go. So basically, here's the inner orbital rim. You want to pass a suture through. I think our suture is basically broken, but we'll do the best we can. Because this is single armed, you have to get the bite of periosteum first. Then you come through the commissure. and now you're going to go the other way. If it was double-armed, you would do it differently, right? Then you come through. You try to. It doesn't, if you don't, it's okay, but you try to. So now the only thing lacking is this connection over here. And, right, so you can grab the rim there, turn your wrist, grab the suture, and once you've done that, you can then tie this. And then if you look at the corner, once you've tied it, so watch. This is what it was like before. Now when you tie it, and the commissure is intact, you don't have to reform it. When you do a tarsal strip, have you done a tarsal strip before? Okay, because if you want, I can show you. I can take it apart. Okay, so when you do a tarsal strip, you've completely disarticulated everything. And the next thing you do is something called acantholysis. Here's the inferior crus. Do you hear it? You could then cut it, and that dynamically releases the lid. Usually with a tarsal strip, you'll shorten the lid. There's a whole way of doing that, but I'll just do this to make it easy. And then is this a suture? I got it. I'm sorry? Yeah, exactly. I love that. Deepithelialized. Sounds so fancy. So I'm just going to go full thickness because this suture is so hard to... Let's just go full thickness for the heck of it. I'll only put one bite through. So now in this surgery, once you do this, the difference from before is you have to reform the commissure, and I'll show you how to do that. So here's your bite through the rim. I don't usually do one throw. I usually get a few bites of the tarsus. Okay. And I'm slipping on this thing. One. You just need a different needle driver. You're just not grabbing. That's big too. Yeah, perhaps. Perhaps. A little bit better. Okay, so now the problem with this is, as opposed to what I showed you before, you have a commissure separation between the upper and lower lid. So if you were to let this heal, the corner would not look like a perfect corner, because you can see the upper part is detached from the lower part. Do you see that? So which one did I use? This one? Here's the better one. So what you do is you take the edge of this, put a suture through. You then put this through periosteum, because you're going to tack it down also. Are you from Australia? No. Oh, it sounds like it. South Africa. And then you want to take a bite this way. Now watch what happens when you tie this. This is called a commissure reformation technique. Let's get rid of this. When I tie this, we don't need that anymore. When I tie this, I'll show you what I do. That's the trick. You throw one throw. You use your finger. So what I've done is reform the commissure. Now the upper and lower lid will be in union again and tied down to periosteum. I don't use these sutures. I use Vicryl for this because I want to form a scar. But you can see you've reformed the commissure here. And then you can close the canthus. You guys like transcutaneous surgery, don't you? Oh, wait. Is this the boomerang? I don't know. I'm going to repeat what I said before. I really, really believe. Do you guys do a lot of eyelid surgery or not a lot? A lot of upper. So if you're going to do lower lid surgery, I really, it's not that you can't do these other surgeries. You're jumping the gun. So you're a lower lid surgeon, you want to get good at it. You start here, you want to get here. You don't want to begin here, you want to begin here. Learn basic canthal suspension techniques and learn transconjunctival excision and simple repositioning. The video I presented earlier breaks it down to its basics. I don't present anything at this meeting that's complicated. If you look at the way that I teach, I don't know if you've heard me speak before or not, everything is very basic. And I try to take things that are complicated and make them simpler. But when you start doing these very advanced techniques, you're going to get yourself in trouble, you're going to get lost, because you've got to start with a foundation. You have to walk before you can crawl. So taking apart the orbicularis, cutting it here, cutting it there, moving it around is great when you've been doing this for 10, 15 years and you want to try that. But my responsibility to everyone here is to teach them how to be very competent in a very safe way. Everything I show you is reproducible, consistent, reliable, and safe. I promise you. You can't get in trouble. Just copy the stuff, you can't get in trouble. I've been doing it for years. I don't talk about revisions. I don't talk about complicated redos. It's not fair. It's not what you guys need. You guys need to know how to get really good at this so that the patients don't need revisions. So I usually, what I do is I press on the globe and pull the lid down like this. But in this particular situation, do we have any saline to inject the lower lid? That would make a difference. That would make it a little bit easier. And then we'll need something for a traction suture. Grazie. So what I'm going to do is inflate the lower lid. Beautiful. Oh, you okay? That's okay. It's just dead juice. Nothing we haven't seen before. So what I'll usually do is pull the eye down and depress the globe, but it's hard here. So let's just make an incision and spread. And what we'll need now is a traction suture. So let's see if we have one. And you can go back this way. When you put your traction suture in, make sure you get conjunctiva and retractors. If you just get conjunctiva, what will happen is it'll cheese wire. Do we have like a little hemostat or something? Or someone can hold this down either way. That's good. And you can put traction on it. And then what I do is take a Q-tip. She will do that. So usually I'll do this myself with one hand. So I'll take a Q-tip, and if you pull hard on that, yep. And I'll dissect down to the rim this way. If we have the scissors, we'll extend the incision in both directions. Okay, so you can see that there's barely any fat here. Now I'm going to have you hold this for me. That's good. And then with the Q-tip, we'll do this. Dry that out. Do we have a little pickup? Here we go. So you're going to see two fat pads in the oblique muscle. Do you see the oblique here? Let's see if we find it. And we'll see it over here. Oh, no problem. Let's get behind that. So here's your central. I'm going to move this a little bit to the center. And then this is your oblique right here. Yeah, fat pad. There we go, right there. The oblique is right here. See this? So let's make a fat pad here. I'm cutting the connective tissue attachments. And then there's a fat pad here. And in between it is the oblique. Do you remember I told you about the shoe shine? So you can shoe shine this back and forth, sliding back and forth. I never should have come up with that term. That and that's a wrap. Big mistakes in my life. I literally go places and they go, hey, mister, that's a wrap. And I'm like, oh my God. And I don't even have her boss's presence on the internet. He's a genius. So take a look in here. This is the arcus marginalis periosteum. Is there a 15 blade there? Yep. So what you want to do is cut the arcus and the arcus only. And once you cut the arcus, underneath will be the tear trough ligament. What is the tear trough ligament? Do you guys remember? Tear trough ligament is where the orbital orbicularis meets the palpebral orbicularis. It was first described by Brian Mendelsohn. That's why I asked you if you were Australian. But Johannesburg is good. We'll take a freer elevator now. So take a look. If we can put a light in here. I'm going to dissect. Here we go. Is there a little Ragnell retractor, a small one? If not, I'll use this. Ah, perfect. Oh, not this one then. Yeah. If not, I'll use this. Okay, I'll use this. So guys, watch. I'm going subperiosteal over here and subperiosteal over here. In between will be the nerve. You can go all the way down. See I'm at the side of the nose, the piriform aperture? So here's your tear trough ligament. Where's that pickup? Right here is your tear trough ligament. Look at the depression it makes. That's where the muscles meet. When you cut the arcus, I release the tear trough ligament. Then I've dissected here. Let's see if we can find you the infraorbital nerve. I'm not ergonomically smart right now, am I? Okay. I don't see the nerve. Oh, there. Let's see if it's here. It's hard without a direct light. So now that you've created infraorbital nerve, do you know infraorbital nerve comes from where? What is the infraorbital nerve? So the trigeminal ganglion, the Gasserian, which sits in Meckel's cave in the brain, gives off 3 branches. The ophthalmic branch, that gives off the lacrimal, frontal, nasociliary. The frontal gives the supraorbital and trochlear. I'm a total nerd, guys, sorry. Do you want me to nerd out even more? The second branch is called the maxillary branch, and its last segment is the infraorbital. It does not go through the orbit. The ophthalmic goes through the orbit through the superior orbital fissure. The maxillary enters underneath the orbit through the foramen rotundum, and the mandibular through the foramen ovale. I'm such a nerd, you have no idea. And so that's the nerve. So the nerve comes from the brain, and it has an infraorbital artery. Where does the artery come from? The external carotid has 2 terminal branches, the internal maxillary and the superficial temporal. That's what you encounter when you do a brow lift. The internal maxillary, its last root, its last division is the infraorbital artery. So they come together, one from the facial circulation, one from inside the brain. So you release the arcus, you release the tear trough ligament, then you have the levator labii superioris, which we elevated, the infraorbital nerve, and the levator anguli ori. And then you go all the way down to the piriform aperture, which is here. So once we've done this, we can now do the transposition. They need a long needle to transpose. I don't know if they have a long needle here. Sorry, a long on a needle, yeah. A 2 or 3 if they have something, yeah. Yeah. To the nerve. Yes. And I'm going to put 1 pedicle of fat on each side of it. Guys, this is going to be hard. You can sweep across, but I put the fat on each side of it. This, get the video, or look at QMP, or look on my YouTube. If you learn it this way, this is hard to learn, because you should learn excision and stuff first. All right, so we have this. Then what we will do is, everyone needs a Joni. Everyone needs you. Want to move to LA? You can live with us. We have a big house. It's a lot of room. I'm just going to sit down over there for a second so I could. Pool, jacuzzis, gym in the house, you name it. Okay, so what you do is, you're going to put your suture down as far as it can go, your subperiosteal. Okay? Now you're going to find your fat pads. Here's one, here's the other. So I'll go backhand because of where I'm sitting. And what you're going to do, I've already freed the fat pads. See the oblique? The oblique originates on the floor of the maxilla and attaches to the sclera behind something called the macula, which controls your central vision. My wife thinks I'm a total loser for remembering all this stupid facts that gets you nowhere in life. Yeah. Hey, she hasn't dumped me yet. And then what you can do is you can do a third throw. If not, you just go underneath, come through, and then you'll tie the suture. And when you tie the suture, because you've externalized, look what happens to the midface. See how it comes up? The reason it comes up is because there's no periosteum down here that's intact. And the reason I transpose so low is because there's no periosteum. When you transpose externally, it lifts the midface a little bit. So effacement of the tear trough is the fat, and the midface coming up. The orbicularis actually comes up. You're supporting the tear trough. Yes. And then to tie this, when you tie this is what you have to remember. If you tie too tight, then the pedicle going over the rim gets kinked. It could necrose. If you tie too loose, it could retract. Now if we take the Damar again, we had it here at one time. So now let's take a look inside. So if you push on this now, you can see that the fat pads are underneath the orbicularis. They're covering the oblique. See the oblique in here? Oblique's there. And what you've done is you the fat. So you've taken fat from the orbit and barred it and placed it here to camouflage the defect. And the tear trough ligament, which used to be way down here, is now higher because when you tied this, it brought the orbicularis up a little bit. Does that make sense? I let it heal on its own. Yeah. 1 week. But if you've really released the pedicles, my guess is you can probably take it out in a day or 2. It's when the pedicles are still tethered that the problems occur. Yeah. Then I'll do a canthoplasty and a flap or pinch. Yeah. So if you take skin out, if you go fat from the inside, skin from the outside, you don't get retraction. Because the literature taught you, if you get a middle lamellar scar, which is a septal scar, you get retraction. That's not true. You have to go through skin, muscle, and septum. It's really a full thickness scar. Yeah. I tighten the lid, and that usually I do a canthoplasty. Yeah, if you want to tighten the muscle too, you can. It's not that you can't, but the less you do to the orbicularis, probably the better for you. Yeah. So I'll make an infraciliary incision. I'll do a canthoplasty first. Lift the skin and then dissect underneath, cut a little bit off. I don't cut part of the lid out, just skin. Yeah. Because the tightening's already been done at the canthus, yeah. I'm not sure they know what that is. That's a name from the past. You want to say that again? I bet they haven't heard of it. A quintus simonoscopy procedure. You've heard of it? Wow, I'm impressed. I leave it all alone as much as you can. Here's what I will tell you. The less you touch the muscle, the less problems you'll have. Now, what's your goal with the patient? When I see a patient that comes and sees me, I already developed a reputation and a brand. They know when they come and see me, this is what I'm going to do for you. If you want more, then you need to go elsewhere. And I would really tell you guys, don't chase cases, chase good results, and patients will come. But the more you manipulate, unless you do, I do 30 of these a month. Unless you're doing high volume of this, if you do it occasionally, I promise you'll run into problems if you play with the muscle. No matter what anyone tells you. Yeah, no, you will. Staying out of trouble is the most important thing. How did Mike get good at what he did? I bet you if you watch him, it's just pure repetition.
Yes, and he does not do, we rarely take any skin off, like the skin pinch rare, we laser. A lot for the crinkles, if there's real excess, then he'll do a pinch,
But what she's telling you is, and this is from a very well-accomplished surgeon, I don't want to mess with the muscle. So whatever you see here, I'm not saying that it's, when I talk about transcutaneous surgery, why I don't do it, it's not that it's a bad procedure. But if you take 100 doctors and have them do transcutaneous surgery, there's going to be the Nabils and the McKellys that are okay with it. But there's going to be so many more that have problems.
Well, for me, the biggest problem is the difference between one side and the other side.
In terms of what?
The thing is that when you do the transcutaneous, we were just practicing, Carl lab, but I don't usually take it. I don't want to go through the muscles because the less I touch, the less I see, the patient is like, I don't know, angry with the result.
Here's an example. Joni's 20. I know she doesn't look that old, but she's 20. When she curls, she can curl 10, 15 pounds pretty easier. But I promise you in 30 years, she won't be able to curl the same amount of weight. And when she's 80, probably 5 pounds will be difficult. So you're going to tell me that this muscle is different than every other muscle in the body, that you can cut it, manipulate it, move it around, do all this, and someone's not going to pay down the road? Do you know what I call this? Delayed iatrogenic morbidity, DIM. That's on us. That means delayed doctor-induced problems. So let me tell you what information I have and I've never published because when I talk about it, everyone hates me. My fellow, 5 years ago, we looked at all patients that came to my office age 75 years and above. 75 years old, same cohort. And then we looked at those that had previous upper and lower left in the past, traditional ones where you excise muscles, and then those that never had surgery. So the same age, the only difference is some had surgery, some didn't. They're 75. The ones that had surgery, the incidence of red eye, dry eye, eyelid retraction, ptosis, pain was 90% higher, age-matched controls. So I don't care what anyone shows you. If you manipulate the muscles that support the eyelid, I promise you, I guarantee you, that's the wrong thing to do. Neil, so here's my thing. In aesthetic medicine, we do a surgery and then we look at the patient a year out. Sometimes you'll never see them again. You do a facelift, they had a great result, you won't see them again. I do not, you may not see them again. But if we really want to know if what we're doing is good or bad, you need to see them in 10 and 15 years out to see what the consequences are. Have we done something that makes them worse? I'll give you the best example. In 2003, hyaluronic acid fillers were approved in this country for use. And everyone did them. Everyone went filler crazy. Do you know the problems we created? It is insane how many problems we created with filler. Infections, granulomas. You operate on people on their lower eyelids that had filler once in their life, their results, the recovery, the results are completely different. So what I'm saying is everything we do has a consequence. And Neil and I were talking about this earlier. Be consistent. Be reliable. Do to them what you'd want done to you. All this fancy pants, everything stuff, it's fluff. You just got to get good results and have happy patients.
It's a great point. It's a great point that he makes. There's a lot of stuff that's out there, and the things that I'm going to give a lecture tomorrow, and it's a predictability, consistency, reproducibility, and the only way you evolve is by analyzing your outcomes, short term, medium term, and long term, and that's how you see, well, I thought when I did this was pretty bad, and it did it not the way I thought, or here was an unintended side issue that I saw from it, and that's how none of us got to the point that we're at, because we started and didn't change.
But also, okay, so Neil's been doing deep thing facelift as long as anybody. And so he's seen the whole revolve of this thing. Along the course, there's been all kinds of crazy ideas and suggestions that people have done. You need to listen to people that have done it for a very, very long time. You don't want to listen to people that are trying to make a name for themselves, that are trying to become insta-famous, that are trying to do whatever. You want good, ethical, sound people. And you can tell when people are lecturing to you if they're really trying to teach you or they're trying to promote themselves. And there's a very, very big difference. And at courses like this, you need a basic understanding of everything. That's what you need. That's the responsibility. And it's responsibility to stand at a podium and talk about things because you are guiding the way people think. And they're going to copy what you do. And so I think when you present something that's so complicated, I mean, if I were in that position, I'd be lost. So learn the basics. That had previously what? So we have, yeah, so we're going to, so here's what I tell everyone that's had filler. I didn't have a chance to speak about complications because we did basic stuff here, but if you've ever had filler before, the amount of swelling and the length of swelling is completely unpredictable. It doesn't matter how many times you've dissolved them. It really doesn't make a difference. In fact, there's so many patients, when I see their post-op reports, I say, you've had filler. No, I haven't, no, I haven't, no, I haven't. They think, or I never had it done, or I never had it done. Hyaluronic acid binds 1,000 times its weight in water. 1,000 times. You know what a powerful thing this is? It's incredible. So there's a much higher incidence of granulomas. If you're transposing fat, you get nodules much more frequently. Anyone that's had fillers in their lower lids, I think when they get their teeth cleaned, should have antibiotics because teeth cleaning, the flu, surgery itself, yeah. Mm-hmm.
Yeah, the worst part is that it thinks the whole world these things are minimally invasive. I would say these things are insanely invasive. They just don't have enough.
They don't have, you're exactly right. That is the best way to put it. Do you know that during COVID, how many people I saw got vaccinated that had filler in their face? Chronic swelling. Oh my God. I have 3 patients who developed such bad inflammatory. They're like rocks. They are all seeing rheumatologists now. They're on methotrexate and cyclophosphamide and all this stuff because it's an immune. There must have been some epitope on the vaccine that was similar to what was on the HA because these people are screwed. I mean, they're just messed up from putting goo in your face. And if I told you 30 years ago I'm going to squirt goo in your face, you'd laugh at me. But today it's like a rite of passage.
Yeah, you joke about Botox in the 70s and no one buying these cans in the supermarkets now they're hoarding.
Now they're hoarding, yeah. That's right. So it's about using your common sense. Hi.
What about energy devices on the lower eyelid? Have you seen a lot of
The one thing I don't like on the face at all is ultrasound, Ulthera. I just don't like it at all. I think a CO2 laser is fine. So here's what my answer to that is. I don't know what you do with it. 10 years ago, I completely stopped doing lasers, peels, everything. You know what I did? I told my patients I'm going to do your surgery. If you feel you want the skin improved, I'm going to send you to my colleague, my dermatologist next door, and another dermatologist, and it blew my practice up because they all started sending me surgery. The reason I didn't want to do the follow-up, the lasers and the peels, is because it's just a lot of hand-holding and a lot of work and I'm a surgeon, and I can't keep up with this. The laser machines change every 6 months. You buy one machine, and because you have to make payments on it, you're going to keep it forever. I just firmly believe that do what you're really good at, and then have a good support system around it. If you want to do it, I think TCA peels are fine.
Good afternoon, everyone. It's a pleasure for me.